Ma'am, it's 8 o'clock. Can we go ahead, ma'am?
Yes.
So, yeah. Are we live? It's recording, right?
Hello.
Yes, we are live and recording.
Yes. So, a very good morning to everyone for joining in today on a Saturday morning. Well, it's a very, very special coming next 2 days for us. We have our annual conference, the rescheduled annual conference, the 13th annual conference of Pune Ophthalmological Society. It was supposed to be held in the month of December, but as we all know, the things are not in the favor of a physical meeting. So we have to do it in a virtual basis. And we have a huge lineup of the scientific feast for everyone, starting with the free paper session today. So first of all, for the opening remarks, I like to call upon the president of Pune Ophthalmological Society, and then we'll push off with the conference. Yes, ma'am.
Thank you, Dr. Mukesh. This is Dr. Geetanjali Sharma, president of Pune Ophthalmological Society. I welcome you all for the 13th annual conference of Pune Ophthalmological Society, POS Spectrum 2020-21. For the first time in the history of Pune Ophthalmological Society, we are holding annual conference on a virtual platform. We have done a lot of firsts in this year, so this is again another first for us. A lot of efforts have been taken by my team for this conference, and I wish all of you attend in large numbers and you will enjoy the scientific academic feast for this conference. So let's start today's first session, and it's a free paper session. It's a competition of free papers. So I wish all the best for all the presenters, and the judges would be there, and the best paper will get the prize tomorrow in the award function. So here we go with the 13th annual conference of Pune Ophthalmological Society. Welcome.
May I now invite Dr. Devika Joshi, the in charge of this session. Dr. Devika, the stage is yours.
Good morning, everyone. We'll start off with the free paper session. I'll just share the sequence in which we would like the presentations to be. So this is the sequence that we have planned for. All the presenters will be judged based on the originality of the paper, the research conducted, the management of patients, whatever resources are used, and how they are keeping well with the time that is allotted, which is 5 minutes for the presenter and 1 minute for discussion. So I invite the first speaker, Dr. Ketki Shah, to present her paper.
Ma'am, I am unable to share my screen. You can.
The host will just allow you in a moment.
Okay. I think host has not allowed.
Piyush, could you allow her to share the screen?
Everyone is allowed actually, she can share.
I can.
Is it Dr. Ketki Shah?
Yes.
Yes, ma'am. Just give me a moment. There it goes. I will. Are these your slides?
Just a sec, sir. I'm not able to see it.
No. I am screen sharing your slide now. Is everybody able to see?
Yes, the screen is visible.
Yeah. Dr. Ketki, I have started your slides, please.
Just a sec, sir. I am not. Sir, I'm not able to see it.
I am moving your slides. Can you see your slides?
No, sir. No.
Just
give me a minute. Yeah. No, Tushar. This is not Zoom. This is my original.
Can we move to the next speaker till then, till ma'am adjusts her Zoom settings?
मीटिंग लीव कर परत जाऊ.
Yes, Dr. Devika.
Can we go to the next speaker till ma'am adjusts all her settings for
Yes,
Zoom?
please. Yes, please. Next is?
Next is Dr. Chiranjeev Singh, judge.
Yeah.
I'm sorry, it is Dr. Marina from Tayega.
Shall I share them?
Yeah. Yes,
Shall I
please.
Please go ahead.
Dr. Marina, you can present. Yeah, we can see your slides. Can you go to slideshow?
Okay. Shall I start?
Yes, please.
Good morning, everybody. I'll be presenting a paper on the assessment of dry eye disease in young adults. Dry eye disease is a multifactorial disease of the tear film and ocular surface, though of frequent occurrence, is often not recognized due to a wide variety of presenting symptoms that mimic other disorders. The use of modern gadgets like smartphones, computers, sleep deprivation, myopic progression, etc. are common risk factors for developing dry eyes, especially in the young adults. So keeping this in mind, we aimed to assess the prevalence and the risk factors for developing dry eye disease in the young adult population in a rural medical college hospital. Ours was a descriptive observational study conducted for a period of 6 months. We included 204 consenting medical students in the age range of 18 to 23 years. A detailed OSDI and speed questionnaire were answered by them. Those with gradings of moderate and severe dry eye were further evaluated by slit lamp examination, Schirmer's 1 test, and tear film breakup time. Appropriate treatment was started, and at follow-up, the tests were repeated and findings recorded. Results. In our study, the prevalence of dry eye was 21.56% according to the OSDI score and 20.58% as per the speed score. 13.6% and 66.7% had severe dry eye according to the OSDI and speed questionnaires. A higher prevalence was observed in the age group of 23 years. The risk factors for dry eye disease, statistically significant risk factors for dry eye disease in our studies were video display terminal use, myopia progression, uncorrected refractive errors, and contact lens use in both the questionnaires. On performing Schirmer's test, we had 25% and 29.5% in the right and left eye with tear strip wetting of 0 to 5 millimeters, indicating very severe dry eye. 25% and 13.6% had a tear strip wetting of 6 to 10 millimeters in the right and the left eye, indicating severe dry eye. The tear film breakup time was less than 10 seconds in the right eye in all the 44 participants, and in the left eye in the 43 out of 44 participants. So hydroxypropyl methylcellulose with glycerin and dextran was prescribed to participants with a strip wetting of less than 10 millimeters, and carboxymethylcellulose was prescribed to those with a strip wetting of more than 10 millimeters. On follow-up at 2 weeks, a normal Schirmer's test values were seen in 81.82% in the right eye and 73.72% in the left eye. All the participants had a normal tear film breakup time score. The mean Schirmer's test and tear film breakup time values were significantly higher following the lubricating eye drop treatment and lifestyle changes, with a p-value of less than 0.01, suggesting effectiveness of treatment. Discussion. Our prevalence correlates with the studies by Ayaki et al. In Japanese adolescents aged 10 to 19 years. However, the global prevalence ranges from 18.4% to 54.3% over all age groups. This varying number is due to different age groups and different criteria for diagnosis. Majority of the participants with dry eye were in the age range of 23 years. These were the students preparing for their competitive entrance examinations, and hence activities causing an increased eye strain, such as constant reading and increased screen time, could be contributory factors. The association of significant risk factors and dry eye disease in our study are supported by various studies. Association of video display terminal use and dry eye has been observed in studies conducted by Moon et al. And Gupta et al. Wang et al. Have demonstrated a low tear volume in teenagers with myopia. Moss et al. Postulated that people with refractive errors tend to have an increased tendency for eye rubbing, thus predisposing to tear film instability. For contact lens use, the division of tear film layer decreased wettability of the contact lens surface, increasing friction between the eyelid and the ocular surface contribute to the causation of dry eye. We could not comment on the association of dry eye and refractive surgery in our study because we had only one participant with dry eye who had undergone LASIK. Allergic conjunctivitis and dry eye was not a significant risk factor in our study. Overall, the test values were significantly higher following lubricating eye drop treatment and lifestyle changes, suggesting the effectiveness of treatment. To conclude, the prevalence of dry eye in our study in young adults was 21.56% according to the OSDI score and 20.58% as per the SPEED score. So a correction of refractive errors, proper use of contact lenses, lifestyle changes such as advice regarding
Hello.
Yes, Dr.
Hello.
Marina, you're there?
Yeah, her slides. Yes, now we can hear. Dr. Marina, have you finished sharing your slides?
yes.
Yeah.
Okay, I see. Can we ask the judges if they have any questions regarding her presentation?
Dr. Marina, Dr. Nikhil here. Am I audible?
Yes.
Yes.
Good morning.
Yeah. So, So during the workup of the patients which you carried out for assessing the etiology of the dry eye,
Yes.
could you just go back to that slide and show us that slide regarding? No, the initial one where you showed us the distribution of the etiologies, suspected etiologies.
The risk factors.
My question in brief is, if we are looking at, so correct. So my question in the young patient pool that you are investigating, won't you think that you're ahead of this, for example, collagen vascular disorders, which would require a more treatment, etiology specific treatment kind of thing for the dry eye?
Yes, sir. So actually, we were only doing a preliminary study, finding the risk factors, the basic risk
No, I
factors,
agree.
especially in this. Yeah. Hello.
No, the problem is, the problem is you are saying that your, your dry eye disease severity went down as you treated these patients, right?
Yes, sir.
So you're doing a comparative study pre and post HPMC installation and the other measures that you took.
It was more of an observational study. The treatment protocols
but you did show us pre and post.
Yes, improvement.
You did some
post-treatment.
intervention. Like
yes.
Yes. Correct. So you did some comparison pre and post, right?
Yes.
Yeah. So in the treatment that you gave, if you didn't work up the patient enough in the beginning, let's say your patient had a collagen vascular disorder because you're looking at young adults.
Yes, sir.
So the treatment should have also included in that subset of young patients who had, let's say, collagen vascular. This is just one representative example.
Yes.
Then the treatment would have also included the treatment of the cause, right?
Yes, sir.
So if you don't treat that cause, that patient stays into, let's say, severe or moderate or whichever grade of dry that he or she has.
Yes, sir.
So won't that skew your results?
Yes. Yes, sir.
Yeah.
But it was more of a preliminary study, so we did not. Though we did ask
No,
for
I
risk.
understand.
We asked for history and because we did not have any such patient, this was not considered.
No, but history is not a very sensitive way of picking out these patients.
Yes.
All that I'm highlighting is this should have been thought of and there should limitations of the study.
Okay. Yes, sir. Sure.
All right. Thank you, Dr. Marina.
Thank you.
Can we move
Otherwise,
back to
Tushar Tamaza.
Dr. Ketki Bhatt's presentation, please? Yeah, ma'am, can you
Yes,
click
yes,
on the
ma'am.
share screen below?
Yes, ma'am. Yes, ma'am.
Yeah, we can see your presentation.
Yes. Okay. Okay. So shall I start, ma'am?
Yes, ma'am.
Yes. Very good morning to everyone. I'm Dr. Ketki Bhatt. I'm Associate Professor in the Department of Ophthalmology in ACPM Medical College, Dhule. First of all, I would like to thank Pune Ophthalmic Society for giving me an opportunity to present in front of these renowned juries. My topic under consideration is to evaluate usefulness of ophthalmic ultrasound in cases of ocular trauma in tertiary care hospital of rural India. So to introduce, as we all know, ocular trauma is a very important condition which have wide impact on socio-economic quality of our lives. So its early and accurate diagnosis is very crucial. But the rural setup like us have limited resources, which poses real challenge to ophthalmologists. So what is ultrasound? Ultrasound is basically a machine where sound waves are generated in the frequency greater than 20 kilohertz, and these sound waves return to the transducer. The transducer has piezoelectric crystals, which converts electric impulse to an image or an data. So there are two basic types of ultrasound, A scan and B scan. Well, A scan is a amplitude scan, especially used in cases of IL power calculation. Here, spikes are seen in corresponds to various ocular tissues, while B scan is a brightness scan generated at the with the help of 10 megahertz frequency. Here, data collected by transducer is shown by various transducer is shown by hyper or hypoechoic images. So what was our study design? We evaluated accuracy and usefulness of ophthalmic ultrasonography in cases of ocular trauma. It was a retrospective cohort analysis study done during the period of June 2018 to 2019. So our ophthalmic CID team encountered 87 patients with all types of ocular injuries. We took written informed consent from them, and ethical committee permission was also taken. After taking proper history, we did detailed ophthalmic examination in the form of torchlight, visual acuity, and slit lamp biomicroscopy. And whenever possible, direct and indirect ophthalmoscopy was done. B-scan was done with Alpino 400 ultrasound machine, and 9 megahertz probe was used. We for evaluation, we use closed loop technique, and patient was in the supine position. As we use limbus to fornix approach, all the clock hours of the eye were carefully examined, and we made sure that periphery of the globe is visualized properly. So coming to our results, male outnumbered female population in the ratio of 3:1. Industrial workers were most commonly affected, and the young age group in between 13 to 40 years of age were maximum in number. So out of 87 cases which we evaluated, road traffic accident due to fall from bike had maximum causative agent in around 64 cases, followed by industrial sharp machine parts in 16 cases. Other agents like toys, stick, stone also contributed. So in this diagram, pie chart, we can show posterior segment injuries were very common, where 32 cases had vitreous hemorrhage, followed by retinal detachment in 18 cases. Anterior injuries like mature cataract, hyphema were also seen in 7 and 9 cases respectively. We had 2 cases of intraocular foreign body. So this is the picture showing the various ocular injuries encountered by us. So retinal detachment, anterior dislocation, and the last picture is showing intraocular foreign body. We did some review of literature in this case, where we have found that Cruzini et al. Have stated that eye is the third most common site in the body affected by blunt trauma following hand and feet, while other studies based on USG of ocular trauma in USA, South Korea, etc. have also found that posterior segment injuries are very common than anterior segment. Indian study done by Brahmabhat et al. Have stated that ultrasound scanning is very useful imaging modality in patients with ocular trauma. So to conclude, I would like to say that B-scan is an effective, essential, but often underrated tool in cases of ocular injury. It is a non-invasive and inexpensive tool where you can have early diagnosis, and bedside diagnosis is also possible. So we can plan accurate management, and we can thus prevent a potential blindness, especially in the young population, where ocular trauma is very common. So, as I have already stated, B-scan is a very good bedside tool for early evaluation of extent of injury. And our study should help create awareness among ophthalmic surgeon the importance of B-scan for early and accurate diagnosis. I would like to thank again for the judges, juries, and the audience. Thank you.
Thank you, ma'am. Can we have any questions from the audience as well as the judges?
Dr. Ketki, how do you think are you assessing the effectiveness of ocular ultrasound by this study?
Sir, whatever cases they have, we saw during ultrasound, like the diagnosis was confirmed intraoperatively. Basically, it was a straightforward sort of diagnosis. All the diagnosis was confirmed intraoperatively, and there was no any test applied.
What I want to highlight is the study design should have been a little more rigorous. What you could have done is pre-operative features and the confirmation of the same by a vitreoretinal surgeon or by any ophthalmic surgeon whosoever was operating. There should have been some point system, like say you have ophthalmic ultrasound score of, let's say, 0 to 5 for a particular feature, let's say in presence or absence of an intraocular foreign body, and let's say the localization of the foreign body. The foreign body is localized to so and so cloacar, anterior to the equator, posterior to the equator, and you should have put in a score, ultrasound score, let's say 0 to 5 based on the pre-op ultrasound, and to what extent was this confirmed during the surgery.
Yes, sir, that could have
and
definitely.
you could have seen, then you could have said that the ultrasound findings were found to be so in real life during the surgery in, let's say, 90% of the cases.
Right, sir.
Then that would have helped you say that the ultrasound is really effective. That would.
It would have given more weightage to the presentation. Actually, we confirmed it, but as you are saying, the score should have been
conclusion.
Yes, sir.
A little stronger.
Yes, sir. Definitely.
Because the p-values and do all that. So that statistics is missing because most of the studies which you quoted do that.
Yes, sir.
Right?
Definitely.
And also you could have shown us a distribution of ultrasound findings that you saw in the patient cohort that you studied. For example, how many of them had vitreous hemorrhage, how many of them have had suprachoroidal hemorrhage, and so on. And in which scenarios was ultrasound found to be mandatory in further decision making. For example, in suprachoroidal hemorrhage, you decide when to drain the suprachoroidal hemorrhage based on the ultrasound picture. So let's say imagine a scenario in which a patient of suprachoroidal hemorrhage is diagnosed, but you are unable to decide when the drainage is to be done. So a center having access to an ultrasound B-scan would score over the other center which doesn't have it.
Yes, sir. Definitely.
So that would highlight the utility of this tool, and we need to find out some way of quantifying these things so that they can be compared.
Yes, sir. Definitely, sir. I will keep that in mind. Yes, sir. Definitely. Thank you, sir.
Yeah.
Okay.
Thank you.
Ma'am, can I ask one question?
Yes, ma'am.
How many of these were open globe and how many were closed globe?
Madam, maximum were open blunt trauma. So closed globe injuries were around from 87 cases, around 54 cases had closed globe injuries, and others were closed.
All right. Yes. Thank you, ma'am.
Thank you.
Thank you, Ketki, ma'am. We'll move on to the next presentation of Dr. Chiranjeev Singh Judge. He has two presentations sequentially. Dr. Chiranjeev, can you share your screen? Can you start it? Please unmute yourselves. Yeah. We're still not able to see your presentation. Shall I share it for you?
Yes.
The dry eye one, is it?
Yes.
Yeah.
to everyone. Thank you for inviting enrolling for the free paper presentation in Pune conference. So my study is regarding the prevalence of dry eye among the post-menopausal women in a tertiary hospital located in the coastal area of South India. So as we know, dry eye is a multifactorial disease consisting of tears and ocular surface problem, in which we know that tear volume is less. And we know the second main also, since it's a multifactorial disease, hormonal status also plays a major role. And in menopausal conditions, which we know is a physiological menstrual cessation of physiological cycle. So as a result of this, this disrupts the normal hemostasis maintenance of the lacrimal gland as well. So in postmenopausal women, it creates a major importance because the androgens will play a major role to regulate the lipid production of the sebaceous gland. And sebaceous glands form the lipid layer of the tear film, so which has a main function to decrease evaporation, as thus could have a major role to prevent infection.
Dr. Chiranji, can you mute and then unmute yourself? There is a disturbance from your side, please. If you can just do that. And now again, unmute yourself, please.
So is it audible now, sir?
Yeah, yes, it's better.
Yeah, there is some echo coming from behind. You can, if you are from your laptop, you can just remove the mic and just speak then. Remove this plug and then speak.
So now is it better, sir?
Much better, much better.
Okay, sir. So restarts or sir? Like,
No, you continue.
You can start with the
Continue.
present slide. Yes.
So in this study, the objective was to assess the prevalence of dry eye and to assess the severity, and majorly to assess the prevalence in which age group. In the methodology, we basically took 50 post-menopausal women after taking a consent and doing a proper examination involving slit lamp as well as tear film height and Scheimer's test. The design was basically a prospective and an observation study conducted in a college in Vinayaka Mission Medical College in Pondicherry, and a period of study was just 2 months. The inclusion criteria was patients having menopause, but excluding all those who have undergone any ocular surgeries, trauma, or any ocular surface disorder, or any topical medication, as well as ruling out any systemic disease like sclerosis or any other systemic involvement leading to the dry eye. So results were basically that women with dry eye had a 32% prevalence, that is 16 out of 50 patients, in which mainly the mild eye had a major prominence with respect to the moderate or severe dry eye. As you can see in this tabular chart, the same thing, then mild dry eye hold a major prevalence compared to the moderate or the severe. In age-wise representation, as the age increases, patients are more prone to have a dryness. Thus, they require a frequent health checkup to be done. And this was consistent with the other studies also. In conclusion, I will just like to stress upon this that dry eye is a hidden disorder, so which can be left undiagnosed. And especially since this prevalence is occurring in the females of older age group, so they're hidden, it being hidden and is more common. So thus, people with higher age group require a frequent eye examination to prevent dangerous complications like blind eye, and thus frequent regular eye checkups has to be done. There was no financial disclosure, so conflict of interest none. Thank you.
Thank you, Doctor. Can we move to the discussion of this first paper? Or shall we present the second one and discuss them together?
Okay.
Yeah, I think we'll move on to the second one and then discuss both of them together.
Yes.
Just a moment. Can you stop screen sharing so that I can share the screen? Yes.
Second study is regarding the knowledge, attitude, and the practices regarding glaucoma patients. So as we all know that glaucoma is a silent thief of sight, one of the important causes of blindness also. So and this damage caused by glaucoma is generally irreversible. So thus the objective of our study is to assess the knowledge, attitude, and the practices of the patients suffering from glaucoma. So in this, basically questionnaire was asked. In the methodology, we took 50 random glaucoma patients and assessed their scores. Now for this assessing, we had a questionnaire pro forma, which included 10 questions. The design was basically a prospective observation study conducted for a period of 2 months. In first, as we took for a social demographic profile in the result, we saw that patients were higher educated as well as higher socioeconomic class were having a better knowledge. So in this study, we had so they had a better attitude as well as knowledge regarding the disease, thus had a proper better. So in the as well as in male to female predominance in the study was almost equivalent only. After covering the social demographic profile, we also took their occupational status to understand their knowledge, attitude, and practices, how it affects their occupational status. So since majority were either unemployed or with unskilled labor, since the study was conducted in a coastal area, a hospital located in a coastal area, so more patients were having unskilled as well as unemployed. So which led to their lower, so they had a lower knowledge as aptitude, which correlation was done.
Dr. Chiranjeev, please continue.
Yeah. So first, regarding the knowledge, we asked first question was how much aware they are about the diagnosis of glaucoma. Briefly describe what is glaucoma. So in this, we were generally asking about the symptoms. After that, we asked that are they aware that glaucoma is irreversible in nature, and also that there is familial nature, thus a need for familial screening. But patient majority were having majority knew that it was irreversible, but they were not pretty much knowing in detail about glaucoma. So that resulted in very less people knowing about the familial nature of glaucoma. Coming to the second, which is the attitude. So attitude, only 2 questions were asked: whether the patient felt the need for regular doses, and second question was whether they felt the need for regular visits. They majority felt that they want to have regular doses, but regular checkups for even if IOP is controlled was very less. That was just 22% only. After covering the attitude, we came to the practices questions. In the practices question, we asked about 4 questions, which included, first of all, how much they are compliance with the uses of glaucoma, any side effects, any irritation. They were pretty much compliant. And regarding the timing also, they were pretty much compliant, which helped them. But compliance towards a regular visit was little less, and patient who rarely went for a screening of their familial members were also very less, just 32% compared to the other lot which didn't go for familial screening. So in the conclusion, the damage caused is irreversible, but with a timely intervention, it can be controlled. So further complications can be prevented. Thus, this study emphasized more on the doctor-patient interaction to be done, either using the other medical staff to educate the patient about the disease and how has to be managed. So more importance also has to be given for the familial screening, since the patients suffering from them don't emphasize on that, understanding that thing, which will eventually improve the compliance and eventually even educate the patients to prevent the further complications. To improve the compliance, patients were also given timely, we can do is that we can have a timely reminders, either way of SMS or giving a call to the patients. So there was no conflict of interest and there was no financial disclosure. Thank you.
Thank you, doctor. Can we discuss regarding both the papers now? The first is the dry eye one, and this is the knowledge attitude practice for glaucoma.
Can the
Does
audience
have
ask
any
questions?
question? Yes, sure.
Okay, great. Dr. Chiranjeev, I just have one primary question. What does your study add which is not already there in the literature?
Regarding dry eye or glaucoma?
Or the dry eye. Yeah.
Yeah, dry eye, a lot of studies has been done similar to it, ma'am. But mainly was done because it was easy to conduct a study of dry eye. So it was not that much new, but
Okay.
Dr.
No, so
Chiranjeev,
you cannot answer that it's easy to do it. Just a few comments on this thing. First of all, you have to define what dry eye, if you're defining as mild, moderate, and severe, on what basis are you defining it as mild, moderate, severe? You have to mention it in your presentation.
Use criteria.
Second, how did you calculate Dew's criteria? So there's Dew's 1 and Dew's 2.
Yeah,
so
1 to 3.
By what criteria did you define it? You will have to mention.
Okay.
Because no one uses Dew's 1 right now.
Okay.
Yeah. Other thing is that the sample size that you have calculated, it's very small for postmenopausal women with something which is a multifactorial disease like dry eye disease. So you have to also first check what is your sample size and how to calculate it. Even if you're doing a pilot project, you have to mention that this is a proof of concept, and then you are going to do a proper study later on. And most importantly, I think it would have been really great if you would have studied similar age females who have menopause and who don't have menopause. So you have an internal control. Also, you could have studied for patients who are hormonal replacement therapy for menopause.
Yes,
so these few internal controls would have made your study a little more robust.
Yes, yes, definitely we'll take it into account for future.
Sure.
All right.
Okay, I think you can put your data to good use if you could just study the similar questions which are being asked around the globe. You studied in a rural population in southern India. What about, let's say, an urban population in Maharashtra or in northern India, rural population, and so on, so that you would be able to find out some factors which are specific to your population, which require further research. Because one of the aims of presenting a research paper is if you can help with can it work as an impetus to the further research.
Yes, sir.
Right.
Definitely, sir. Thank you.
Yeah, so you should compare your data with similar population around the globe, or at least in India. So that should have been done.
For difference of factors. Thanks.
All right. Thank you, Dr. Chiranjeev, for both the presentations. Can we move on to the final presentation of this session, Dr. Shrutika? Dr. Shrutika, are you here? Yes.
Good morning, ma'am.
Good morning. Could you start share screen?
Yes, ma'am.
Please put it on slideshow. Yes.
Okay.
Good morning, everyone. The topic of my study is to study the risk factors of cataract formation in young adults in the age group of 18 to 45 years in a hospital setup. Introduction. Multiple etiological factors play their role in the development of cataract. There are genetic, socio-economic, demographic, and environmental factors acting singly or in combination resulting in cataract. Most of the patients in young adults were exposed to trauma and usage of steroids before developing cataract. The present study is undertaken to find the various risk factors causing early cataract in a tertiary care hospital-based setup. Aims and objective. The aim is to study risk factors of cataract formation in young adults in the age group of 18 to 45 years in a hospital setup. Sample size. A prevalence of cataract in young adults is 20%, being a cross-sectional study. So according to the formula of 4PD upon D square, my sample size is 64. Inclusion criteria, it includes patient age from 18 to 45 years, patient with history of unilateral or bilateral diminution of vision, patients with history of trauma, exposure to radiation, inflammation like uveitis, history of consumption of steroids, HIV positive patients, and patients with diabetes and hypertension. Exclusion criteria, it includes patients below 18 years and above 45 years, patients who have undergone cataract surgery, and patients who are pregnant. Material and methods used, a total of 64 patients visiting a hospital with complaints of diminution of vision and diagnosed as cataract were included in the present study. All the patients underwent slit lamp examination, dilated fundus examination using indirect ophthalmoscope, relevant system examination, and in some cases, B-scan was done if required. Thorough history of any illness, medications used, personal history, birth history, information regarding trauma, steroid intake, and previous history of inflammation like uveitis was collected. Patients who did not show any risk factor in the history or examination were classified as idiopathic cause. The results, we studied 64 patients so far, out of which the risk factors were found to be as follows. Trauma being major cause, leads to 45%, HIV 10%, idiopathic cause contributes 16%, diabetes 9%, steroid use 7%, and radiation 6%, uveitis 2%, and other causes which include incidental findings like hypertension, glaucoma, renal disorders, etc. were included in 5%. Trauma being the major cause of 45%, out of that major cause was because of the penetrating trauma, that is 65%, and blunt trauma included 35%. Discussion. The present study is conducted in age group of 18 to 45 years, which is a working age group of a country. And this is the most productive population, which plays a major role in socio-economic development. If young adults are affected due to development of cataract, it can lead to decrease in the output and hamper the growth of a country. Therefore, it is important to study the risk factors of cataract in young adults, which can be prevented. Trauma being the major cause of cataract in young adults are difficult to manage and at times have worse outcomes as other ocular tissues are also affected, like corneal sclerosis, iridodenesis, phacodenesis, cataract formation. It can also lead to vitreous hemorrhage or even at times retinal detachment. Also, surgeries are also complicated, so phacoemulsification is not possible in such cases. So more conventional methods like SICS is done. Related studies, a clinical study on risk factors of cataract in young adults, which was carried out in Andhra Pradesh and India, showed similar results, and also effects of penetrating and blunt trauma on the outcome of traumatic cataract in the northern India shows result in which penetrating trauma was more as compared to blunt trauma. Conclusion, risk factors for cataract in young age group for trauma, patients with HIV positive, radiation, steroid use, diabetes, hypertension, inflammation like uveitis, and glaucoma. Trauma was the main cause of cataract in young adults, and cataract due to idiopathic cause was the second most common type in the study. Take-home message from my study is, as maximum patients have development of cataract due to trauma,
We can use protective gears at work and have safe practices at workplace. Because of some peculiar causes, patients should be properly investigated, not only from ophthalmic point of view, but systemically also. And awareness can be made so that there can be a delay or we can avoid the progression of cataract in young adults. Thank you.
Thank you, Dr. Shrutika.
Yes, ma'am.
Okay. Can we have any questions from the audience or from the judges? Hello?
Ma'am, my comment would be same as the comment which I made for the prior study. So essentially, what you're doing are you're studying the these are called prevalence studies. I mean, you're trying to study a prevalence of a certain condition or prevalence of certain spread of certain etiological causes in a given population.
Yes, sir.
So merely stating that, let's say, your population has this much of trauma doesn't mean anything, in the sense it doesn't lead to any kind of action that you can take, or you can have a very limited course of action in such scenarios. So what would help, as I said with the prior two studies also, is when you compare, and you did compare, but you just, mentioned one line, that, you could have compared such a population with such characteristics and such problems, let's say in other parts of the world.
Okay.
Let's say for example, your hospital is, let's say, very close to an industrial factory.
Okay.
Right. So you would get more trauma patients as opposed to some other hospital which is located deep within a jungle, who might get, or a hospital which is part of a let's say a multi-speciality hospital. They would get more steroid induced cataracts.
Yes, sir.
So, that differential distribution of causes in a certain population which you are studying,
yes, sir,
would go in a long way in deciding the measures that you want to take for that population to avoid this control. For example, the trauma, you focus on trauma because your maximum of your patients were of trauma.
Yes, sir.
Right. So if some other population, let's
Dr. BK, are you there?
Yeah. So I was saying that some other hospital, let's say, who has steroid induced cataracts, they would have different measures and different take home messages.
Yes, yes, sir.
Right. So the measures that how these populations compare to, because the utility of your research is basically dependent on how effectively your research can be applied to the rest of the population, or how effectively.
Yes, yes, sir.
Right. And while I understand that our sample sizes can't be too ambitious, thousands, but at least you could have compared it with another population in the rest.
Okay, sir.
And showed us a comparison, as to how the
sir.
distribution spreads. Yeah.
Okay, okay, sir.
All right. Thank you, Dr. Shrutika.
Thank you, ma'am. Thank you, everyone.
So this ends the free paper session for today. We'll have a similar session tomorrow morning as well. I thank all the participants and judges for making it on a Saturday morning so early. And can we move on to the next session, sir?
Hare Manisha.
It was an excellent session and very good papers were presented by everyone. Congratulations to all the participants and excellent presentation. And also we thank the judges who early morning on Saturday are here, and a very good discussion also, Dr. Nikhil. Excellent discussion. So thank you very much from Pune Ophthalmological Society, and we'll have a similar session tomorrow and we'll enjoy it. Thank you.
So, thank you, Dr. Devika, for finishing this session well on time, and judges as well as all the presenters for participating. We are well within time, and we are geared up for deferred live surgery video session, which starts at 9 a.m. and it's till 10:15. I request other Dr. Suhas, can you put your microphone on mute, please?
Okay, thank you.
Yes. I now call upon Dr. Seema Khaire to take over this session, please. Dr. Seema, please, the stage is yours.
Thank you, Dr. Mukesh. Good morning, all. I'm Dr. Seema Khare, and I would like to welcome all the esteemed faculties and Chairman Dr. Sanjay Shah. Welcome to the first virtual POS Spectrum conference. We would like to begin the deferred live surgery video session. But before we begin, it's a kind request to all not to take any screenshot or photos of any patient during the video presentation.
Dr. Seema, can you speak a little bit loudly, please? We are not able to hear you properly.
Before we proceed, I would request all not to take photos or screenshots during patient's video presentation.
And also, we would like to invite Dr. Santosh Bhide sir and Dr. Kishore Pauja sir to co-chair the session, please.
So let me introduce today's faculty. First, Dr. Saurabh Patwardhan. He is an eminent eye surgeon from Sangli. Next is Dr. Natasha Pahuja, a promising young ophthalmologist from Pune. Dr. Suhas Sonavne. He is a versatile surgeon from Dhule, also a VR surgeon. Dr. Santosh Bhide, very experienced and dynamic surgeon from Pune. Dr. Nikhil Rishikeshi, he is associate professor at HV Desai, very renowned pediatric ophthalmologist from Pune. Dr. Prasad Valimbe, a famous pediatric ophthalmologist and author of a book, Step by Step Squint Surgery. And finally, Dr. Sanjay Shah, our chairman. So now with the chairman's permission, we'll begin the first video.
I'll just make one small thing. Dr. Parikshit Gokte was also invited for this session to present a very good surgical video, but due to some sad thing in his house, his grandmother passed away, so he won't be able to present today. If tomorrow he is able to present, we'll definitely show his surgical video in tomorrow cataract session. With that, let's take the permission of the chair to start the session, please.
Dr. Shah sir, can we start, sir? Dr. Sanjay Shah, can you hear us?
Sir, you are in mute. Sir,
yeah, I think.
Please start the session. Yeah.
Yes.
Yes, thank you.
Dr. Saurabh Patwardhan, his first video is there, deferred live surgery, cataract.
Thank you so much for the kind invitation. I'm the opening batsman, and actually I have presented deferred live surgery before, but I feel that many times if we edit it rather than showing it completely unedited, it makes more sense. So I'm going to share one video of a hard cataract surgery. And what I want to emphasize in this video is not just about your technique, but many times many complications start occurring when you are not focusing on one step. So when your mind is faster than how your hands are doing, you end up in trouble. So here is my video, and there is also audio along with it. So here I start, and I have kept it short so we can have some question answers also later. And other panelists can also.
From Nandadeep Eye Hospital, Sangli, India, and FECO Training Center. This is commented video number 6, and in this video I am going to speak about a hard cataract, case of hard cataract, and how we should be thinking about this particular case. And generally what I feel is that whenever we have a complex case, we tend to get burdened by the final outcome. So we start thinking about how this case is going to end, whether I will be able to do the proper steps or not. But I think it should be dealt in a different manner. And what I do in such cases is that I divide the case into different small steps. So we have to think about only the next step or the step which I am doing at present, rather than thinking of the steps which are going to follow. So here I have already done capsulorhexis and I have rotated the nucleus, and I start with the first step, which is trench and divide. So I am going to debulk this hard cataract. I am going to use 100% Ozil. The tip is 1.25 to 1.5 millimeter exposed, so that I can reach the deepest part of the trench. And as you can see here, that I am going to make a wider groove, and I am going to stick to the central 4 or 5 millimeter here, the safe zone. Once I feel the depth of the trench is adequate, important thing here is to place the instruments properly at the floor of this trench, so that when we divide the nucleus, it divides the posterior plate as well. So I have now rotated it 180 degrees and again completed this first division. So psychologically, I have finished the first step here. Now I will move on to the next step. Next step is doing chopping. So for chopping, I have to bury the entire 1.5 millimeter of the tip inside. Then I stop the phaco, keeping the vacuum on. I am chopping. And now while chopping also, I am doing multi-level chopping. As you can see, my Sinski is going down deeper into the crack and then dividing the posterior plate completely. So now my concentration or the focus is on dividing this piece completely till the posterior plate. So that is how I am going to focus. I am not going to think about the next steps. So first half of the nucleus is divided into 4 pieces. Now the next half, always think about the burying tip. Once it is buried completely, I am dividing till the posterior plate. Not skipping any step, not trying to hurry, but finishing of the step properly. Now the step 2 is complete, and now I am going to do some quadrant removal. So each piece has been divided into 4 small pieces. Now for quadrant removal, so now I start with the bevel sideways and I start doing phacoemulsification of the first piece. Once I use the bevel sideways, you can see the pieces will start following because they are completely separated from each other. If I would have not done the previous step correctly, I would have had stuck nucleus pieces at the posterior plate and would have made my life difficult. So as you can see, once I keep on moving to next step, the proper completion of the previous step is so useful. So here it is very simple. I am just keeping my phaco tip right at the center, bevel sideways, and start emulsifying the free pieces. After emulsification of half nucleus, my step is over. So now I am moving on to the next step, that is emulsification of the second half of the nucleus. Now before that, I always replenish the OVD. I am using here chondroitin sulfate hyaluronate combination, Hylucoat or Viscoat, which is going to protect my endothelium. So once I feel that, I push some methyl cellulose in the back, and also I will rotate the remaining heminucleus. So this is like a fixed step for me. I rotate all the remaining parts so that they lie in front of the phaco tip. This avoids trying to removal of the subincisional nucleus, which may be sometimes risky. So again, I start with the next step where I start emulsifying the remaining heminucleus, which is already divided into nicely separated pieces. So again, my focus is on keeping the phaco tip right at the center without moving it too much, and using my left hand to feed this phaco tip. I am using longitudinal power of 80% along with 100% Ozil, which are alternating with each other. So because I am using longitudinal, the tip is not getting blocked. If I use 100% Ozil, sometimes the tip gets blocked. So now you can see I'm also focusing on any anterior chamber fluctuations which might be happening. So here my focus is on keeping the tip at the center and just watching for any fluctuations in the posterior capsule. As you can see, the anterior chamber is rock solid, posterior capsule is not fluctuating, so I could complete this step also without much issue. That's the end of nucleus emulsification. So that is how psychologically you have to divide the entire nuclear emulsification into different small steps and focus on those tiny small steps and the details of it. Once you achieve that, you can achieve good success in even complex cases. Thank you so much for watching this video. More videos on our website.
Thank you so much. That's all from my side.
Excellent presentation, Saurabh. Really, it was a treat to watch a hard cataract being done in so easy way. But it's not so for the beginners. You are the master of it, so it was easy for you to do it. But can you give some tips if you are stuck into the process when you're not able to chop the posterior plate, or when there are sometimes it's not that leathery what I've seen, but sometimes it's really leathery, and whatever amount of pressure you give to divide, it's difficult to divide. Any clues or steps to come over that problem? If you can just give to our audience.
Yeah. Yes, sir. Thank you, sir. So I think what I said in the video was it's all about how you are thinking during the surgery. This case is also a leathery cataract. So you may not feel that it is leathery. That's because I have trenched it to the deepest level and I didn't miss any steps. So many times what I feel is that you have difficulty in dividing because you have not trenched it properly to the proper depth. So more leathery the cataract, more deeper you go with the trench. And when I review my old videos where I was struggling with leathery cataracts, it was because I was trying to go to the next step very quickly. Like I feel that the trench is complete now, I should go to next step. So now what I do is that I make sure that my step is complete and then only I go to the next step. And I think that is the way, if we think, then we don't find any difficult cases. Most of the complex cases, if you break it down into small steps, very tiny steps, I think you can achieve much better results than you can achieve, you could achieve previously.
Can you just explain what is the depth that you should reach? Because that is very important. As you are saying that in leathery cataract, the depth is important. But many times what happens that you feel that there is a pseudo glow that is coming up and you feel that your depth is enough. But under such circumstances, what you can say that this is the good depth for a leathery cataract to chop or a break?
Yeah, I think that's a very good question, because in leathery cataracts, in fact, you don't see any glow at all. So it's all about your three-dimensional view through the microscope, which gives you the clue. So what I do is that you always have the phaco. That's why I mentioned about the phaco tip exposure. So I keep around 1.25 millimeter exposure, which is more than 1 millimeter exposure, which I normally keep. So, and I try to go at least 2 depths inside. So it's 2.5 millimeter. These leathery cataracts are usually thicker than 4.5 millimeter, and there is no epinucleus. So you have to reach the center of the nucleus to break it properly, because center is the hardest part of any cataract. Once you go through that, you get that feeling also where with your phaco probe that now you have gone through the hardest part of cataract and you are now feeling it easier to trench. So that is the point where you can stop and then divide, because you should not wait for the glow to come, because if there is a glow in leathery cataract, you already passed through the posterior plate.
Correct, right.
Especially for depth, the thickness of nucleus is more in the center. So you have to be more in deep in the center than at the periphery. Peripheral thickness of nucleus is less. So you have to be very careful when you are trenching at the periphery of the nucleus.
Yeah, so that's what I mentioned in the video, that stay with the central 4 millimeter zone. It's more than enough. What I've seen is that many surgeons do long trenches, almost 6 millimeter, which are not needed at all. Once you create a weak point in the center, the nucleus is going to divide at the center. If you create a weaker point in the periphery, nucleus divides in the periphery and center is stuck. So the idea is to have deepest weaker point in the center. It's just like a rope which has, if there are multiple weak points, then it will break at the weakest point. So if it is in the periphery, it will break at the periphery. But if there is a central weak point, only one weak point, it will divide at the center.
Perfect, perfect. Yes, what you're saying is perfectly right. Any other questions?
I have just one question, last question for this talk. I would like to know your choice. I saw that you're using a long blunt chopper. This versus a sharp tip chopper. The sharp tip chopper, what would you prefer between this and blunt chopper?
Yeah, my personal view is that you don't actually need any sharp instruments to divide nucleus, because nucleus is naturally divided. It has lens fibers. So what is needed is the separation of these fibers. And the advantage of using blunt chopper, as you have seen, I can go till the posterior capsule very easily, and I can, open those posterior attachments without any fear of, even if I touch posterior capsule, it is not going to open the posterior capsule. So that's why you can see I am fearless in going deep. And that is the trick behind breaking all the bonds posteriorly.
Saurabh, was that a long Sinski?
Yes. Yeah, it was a long Sinski basically.
Okay, yeah, great. Excellent presentation.
Thank you, sir. Thank you.
Thank you. Yeah.
Thank you, Dr. Patwardhan. Thank you, Sanjay Shah, sir. Thank you, Dr. Santosh Bide. Now I invite Dr. Natasha Pahuja to present a video, Deferred Life Surgery, SMILE.
Thank you so much for this humbling opportunity. I would like to thank POS for giving me an opportunity to present on something that I'm very, very passionate about. Sorry, 1 second. Okay, is my screen visible?
Yes.
Yes, yes.
Okay, all right, perfect. Before I start, you have raised the bar very high, Dr. Saurabh, for making a live presentation. It's absolutely amazing. Watching you operate is a treat for the eyes, really. So congratulations on that video. I have something which is very, very elementary, because SMILE surgery per se hardly takes a minute to operate, but it's the nuances that are there to make the SMILE surgery perfect is what I would be talking on in this video. So this is a female, a 23-year-old female who came to me for SMILE. She came from Iran. She had a refractive error of -6 with -5.5, and she had a cylindrical component in the right eye, not so much in the left eye. And she uses contact lenses for more than 2 years. Now, this is her topography. Her topography looked more or less all right, with showing the cylindrical component in both her eyes, more in the right eye. So because she had a cylindrical component, I decided to go ahead and do the cyclotorsion marking. So I do a cyclotorsion marking if the cylinder is more than 0.75, and this paper has been published by Dr. Sri Ganesh group. So it's much like the toric marking that we do for toric IOLs. Looking at the Purkinje image, making the parallelepiped horizontal, and so that it's coaxial, I just ask the patient to look in the light and then mark 0 and 180. We do it in both the eyes, obviously, making sure the head is, the forehead is absolutely touching the slit lamp. So this is what I'm doing. I do it with the 26 gauge needle by putting a surgical marker on the 26 gauge needle. Also, the beveled edge of the 26 gauge needle makes a very small epithelial defect. So even if the mark goes away, the defect, a very superficial defect remains. So it helps me refreshing the marks intraoperatively also. Now, this is the SMILE planning. You go ahead and choose Relax SMILE, and this is the interface. So I'm just mentioning the refractive error here. What is the optical zone? I decide the optical zone based on what is the pupillary size. What is the pupil size? And of course, how much pachy I have left, and the transition zone depends on that. Moving on, the most important aspect here is that it also shows you where the position of the incision is, how big your optical zone is, and how much are you correcting, what is the transition zone. The dotted zone is what is the transition zone here. So after doing that, we go ahead and also decide as to where we want to place the incisions. I place it superiorly at 90. Here I've kept it at 3, but actually my choice of width of incision size is 2.5 mm or 2 mm, depending on how cooperative the patient is preoperatively. So what I essentially want to show here is that you can basically change the position of the incision and the number of incisions that you would want. Now, this is a very, very, very important step, and you will see why I'm mentioning this. I tend to moisten the surface, the ocular surface slightly, but it should not be so wet that it can cause suction loss. So it has to be adequately moist. After doing that, the most important step is on what do we want to center the treatment. You want it on the pupil center, the visual axis, or the corneal vertex. It is ideal for astigmatic surfaces to do it on the corneal vertex, but it's very difficult to actually mark the corneal vertex. So the closest to that is the visual axis, because that is what is physiologically acceptable to the patient. So how do you get the visual axis centration? Is you basically ask the patient to look in the light, the green blinking light, and the patient constantly looks in the blinking light. So if you see here, I do a very soft dock. So this is before I have put the suction on, you can see a peripheral rim that is not applanated still. So you have to make sure that the applanation is just 70%, and then you put the suction on, because if you compress the cornea too much, it's going to have the cornea is going to have multiple folds, and that area does not get the femtosecond does not pass through those areas smoothly. So it would be ideal to just very gently touch the cornea and then start the suction. What I also do is I do an infrared on, check where am I centered. So this is basically centered on the visual axis. You see it's not centered on the pupil. So this is just essentially just to make sure that how the centration is. Also, because once we do this infrared, the cornea sort of very nicely sucks into the applanation cone. So this is the right eye what we started. This is the refractive error, as we remember from before. Now, astigmatic, in this cornea especially, I have refreshed the marks. As we can see here, these are the marks I've refreshed with a toric marker. So what we essentially do is we look at the reticule that we have in one of the eyepieces, and the reticule has to align with these toric markings, which is 0 and 180. And if you see, I'm rotating the applanation cones slightly. So this just makes sure that it is at 0 and 180, and then of course we fire the laser. The laser, because it's just 70% docked and then suction is turned on, so it gives a very beautiful OBL, very smooth OBL. And then you go ahead and open the primary incision. Now this I went on very, very smoothly. She was an Irani patient who didn't understand English, so it was very difficult to communicate with her. But actually the crux of the matter is the other eye. So this is the anterior cap separation. And now I go into the posterior plane. I tend to leave the 6 o'clock part and then remove it a little later on. Now what happens if I do not wet the cornea adequately? Now this eye has been docked twice. She was for the second eye. I could not communicate to her because she didn't understand English. So here again, I soft dock it and then start the suction. Now if you just notice the ablation or the OBL that comes here, there are a lot of black spots right in the pupillary zone. That means and this is the refractive cut. So this is the one that determines how much power is being corrected and what are the aberrations that are going to come. So after looking at the central zone, which was not cut, I personally was of the opinion that we should not proceed with this because if there are certain areas, if you see here also, once we see it on the microscope, this shows an absolutely black zone in the refractive lenticule, which is the posterior plane. So in this case, I didn't want to take a risk and I didn't want to basically just be adventurous and try to just manipulate, which is why I just left this patient alone, and I explained the translator to explain to the patient that the patient will have to come back later. Just hydrated the cornea because of the multiple applanations. This is on day 2 post-op. I did an OCT for this patient. So if you look at the OCT, we can very clearly see here that there is an primary incision and the anterior cut and the posterior cut is present, but the posterior cut is absolutely absent in the right in the pupillary zone. So I decided to just wait and do serial OCTs. After 3 weeks of waiting, if you see the OCT here, it shows more or less homogeneous stroma. And just in the periphery here inferiorly, we can see the initial cut. So I decided to take this patient up again. But the trick here is that, of course, this time I think I was over enthusiastic and hydrated the cornea a little too much, which is why we see here that there is collection of fluid in between in the interface. So this is also not a good sign. But then I just explained it to her that she'll have to wait. This time I got the translator inside the OT as well. So he was just asking her to calm down and keep looking straight in the green blinking light. You also have to explain the patient that the green blinking light will disappear or it may become dull, so that they stop looking for it, because that's the most common cause of suction loss. So we go ahead and now I get a very smooth posterior cut. But if you see, there is slight movement that is happening and there's a lot of fluid that is getting accumulated here. So this is a very risky sign, but I was just very optimistic and I went ahead. Now, if you look at this, my incisions, I avoided the primary incision, which was here at 90. And instead, I took 2 other incisions, which are along the meridian, but along the arc, but quite away from the primary incision. The point essentially is that if I have a different incision, then there is a possibility that I may not be going into the previous plane, which is why we decided to have 2 separate incisions. Just in case if I'm not able to open the first incision, I already have a backup of the second incision, and these do not cause any induced astigmatism on the cornea. So you can place how many corresponding incisions as per your need. So in this case, I am, if you can see here, there is the old primary incision which is getting highlighted here, and these are the other 2 incisions corresponding to that. Now, with the right incision, I open up the anterior plane. That is how we ideally do it. You first open up the anterior plane and then you open up the posterior plane. Now, if you notice here, I'm not applying any pressure at all. So however my instrument is going smoothly, automatically, without any pressure, I just allow it to go. So with the right side incision, I open the anterior plane. And with the left incision, I open up the posterior plane. So these are doing that particularly that there should not be superimposition of the previous cut that we had done 3 weeks back. So this with the right incision, I'm opening up the anterior plane. This opens up very, very smoothly. Again, I am just allowing the instrument to go naturally. There is absolutely no pressure being applied or counter pressure being applied. I don't have second instrument that holds the eyeball in place. Now, if you see superiorly, I have a little resistance, especially at the site of the primary incision. But I know for a fact that I haven't entered a previous plane. Another important point to note here is that the docking has to be at the same point where you have done 3 weeks back. Now, if you see in the posterior plane, there I'm getting a significant amount of resistance, especially in the superior aspect. So I change my instrument and I use a spatulated instrument, which basically allows smoother cleaving or cleavage of the refractive plane of the stroma. And with the other instrument, I just try to hold the eyeball in place. So this is just me smoothly trying to wriggle out the plane just to make sure that it is one smooth plane and it does not have coinciding with the previous cut that was made 3 weeks back. Now, this is just to ensure that there is enough coverage, you have to go beyond the optical zone just to make sure that the entire lenticule has been separated completely. And once you're absolutely sure, what we essentially see is a line like this, which is a silver line. This is a sign that the entire lenticule has been separated. After which we just go ahead and with the forceps, with the microforceps, you go ahead and remove the lenticule. It is important that you check if the entire lenticule has been removed or not. While removing the lenticule, I could see that it has a smooth margin, which is why I just left it to that. And the patient recovered immediately, and she was 6'9" on first post-operative day and 6'6" after 2 days. So this is just me learning from my very small mistake that I did not hydrate the left eye, because the left eye is usually more exposed for a longer time because we start with the right eye. And because the left eye had gone dry, I did not make the cornea extremely smooth and adequately moist, which is why I had a lot of dry spots in the left eye. So just a very small step of making sure that the ocular surface is moist is very, very important in SMILE surgery. Thank you very much.
Surgery, Natasha.
As we are running short of time, I request the next speaker, Dr. Santosh Bhide, to present his video about cataract, deferred life surgery, cataract.
Mukesh is there?
Yes.
Yes, sir. Sharing right now.
Yeah, please. I am also going to show you a phaco in grade 4 cataract. Saurabh Patwardhan has already shown excellent step-by-step surgical video on grade 4. And actually, both the phacos are being shown before nucleus drop, which will be managed by my friend Dr. Suhas Sonavane from Dhule. Proper staining is a must. And here, capsulorhexis is of most important step in phacoemulsification. If you ask me which is the most important step in phaco, I will say that capsulorhexis. If you have done a perfect capsulorhexis of adequate size, then I think half the battle is won. I insist on adequate size because there is a tendency to make a small capsulorhexis or a baby size capsulorhexis. And then in such hard cataracts, it's very difficult to manage nucleus or emulsify nucleus through small capsulorhexis. If you find that the capsulorhexis is going towards periphery, then you can inject viscoelastic again, make anterior chamber deep so that the anterior capsule becomes flat and you have more control on capsulorhexis. You have to utilize shearing and tearing forces in proper manner so as to achieve capsulorhexis of adequate size. What is meant by adequate size means it should be about 5 to 5.5 millimeters so that it will cover optics of the intraocular lens from all the sides. Once you have done capsulorhexis, you have to, before doing hydro procedure, you have to remove visco from the anterior chamber so that there is no stress on the zonules. You have to be very gentle in doing hydro procedure in such grade 4 cataracts because there is hardly any epinucleus or any cortex. Here I am using a torsional phaco, 0.9 millimeter, 45 degrees, mini flare tip is used. And another important step is before starting phaco, you have to remove some of the viscoelastic from the anterior chamber so as to avoid wound burns. If you immediately start doing phaco, as soon as you enter the anterior chamber, there is clogging of the tip of the phacoemulsification probe. And because of clogging of the tip of the phaco, there is generation of heat, which leads to wound burns. And if there are wound burns at the initial stage of the surgery, then the entire surgical procedure becomes very difficult. Please note that I am going almost 80 to 90% deep in the center. Then I am rotating the nucleus because the subincisional part of the nucleus is not emulsified. And then again, I am going almost 90%, 80 to 90% deep. You can't see a below, so you have to be very careful. I'm doing a stop and chop technique, which is a very safe technique. once once you divide a nucleus into two fragments, then the further steps are very easy. Again, please note that I am not using any sharp chopper. I also prefer to use Sinskey hook. In fact, almost 95% of the cases you can manage with Sinskey hook. And for dividing the nucleus, there is no need of chopper. You can divide it with Sinskey hook. Please note, Saurabh has also insisted that you have to rotate the tip of the phacoemulsification probe tangentially so that you can remove all the fragments very easily. There is hardly any longitudinal phacoemulsification applied. I am doing a slow motion phaco again. I have rotated the half part of the nucleus, filled it with the viscoelastic again. Slow motion phaco is our teacher, Dr. Vasavada sir, always explains that you have to stop doing phacoemulsification after 1 minute, inject viscoelastic again, and finish the phaco. Please note that while removing the last particle of the nucleus or last part of the nucleus, you have to be very careful. All the parameters, vacuum should be low. There are some small bits of nucleus which usually remain, and those bits you can easily remove with the help of coaxial irrigation aspiration port. There is no need to chase those bits with the help of phaco probe. Here is a small bit of the nucleus which I am able to chop and remove easily by using a coaxial irrigation aspiration. The chamber is very stable so that there is hardly any fluctuation. Removal of cortex is not that difficult, but you have to note that in such hard cataracts, there is usually capsular bag is very floppy. So when you go towards the periphery or the fornix of the capsular bag, you have to be extremely careful. Insertion of lens is just routine. So by using certain principles of stop and chop technique, you can achieve good results. You can get good postoperative vision immediately. You have to use Arshinov's soft shell technique, in which a combination of cohesive and dispersive viscoelastic should be used. For capsular axis, you use cohesive viscoelastic, and while doing phacoemulsification, use dispersive viscoelastic so that it coats the endothelium and protects the endothelium throughout the surgery. I thank Team POS for giving me opportunity, and congratulations for an excellent organization of this virtual conference. My best wishes to you. Thank you.
Excellent surgery, Santosh, and very well explained all the important points which are required for any hard cataract to be operated. Congratulations. Any one question from anyone? So we go to the next case. I think there are no questions.
Swat can show us now if there is nucleus drop in such hard cataracts, how to manage it.
Dr. Mukesh, can you start next video? Dr. Suhas Sonane from Dhule, VI surgeon, showing a video of drop ultrasonic fragmentation for drop nucleus.
Drop nucleus is a serious intraocular complication in the modern cataract surgery, and its incidence has been increased with the phacoemulsification technique. And any surgeon who has got a sizable surgical volume and who is operating on a variety of complicated cataract cases going to face condition of drop nucleus once in a while. So for management of the drop nucleus, you need to have a very trained vitreoretinal surgeon with a modern vitreoretinal setup like vitrectomy machine, endo illuminator, endo lasers, etc. The gold standard treatment for the drop nucleus is 20 gauge pars plana vitrectomy with ultrasonic fragmentation of the nucleus. If the nucleus is soft, and cortical material and nuclear shell can be removed with the vitrectomy cutter itself. But if the nucleus is little harder, then you need to use ultrasonic phacopragmentation. But sometimes the nucleus are very hard, just what Dr. Santosh Bide has shown. Such hard nucleus cannot be even managed with the phacofragmentome. They need to remove via limbal route. So there are some principles for using ultrasonic fragmentation for drop nucleus. First, you have to do a complete and thorough posterior vitrectomy and remove all vitreous attachment from the nucleus to be fragmented. As this phacofragmentation is a very high flow system, any vitreous in its way, it can pull the vitreous and cause vitreous traction, and it can induce the retinal breaks also. So you need to hold the nucleus in mid-vitreous cavity and do the fragmentation. Many a time while doing phacofragmentation, the nucleus will keep on, you tend to lose the grip and they will keep on falling on the retinal surface. So every time you have to pull the nucleus in mid-vitreous cavity and hold it, grab it and do phacofragmentation till you finish the last nuclear piece. Never try to do phacofragmentation close to the retina. It might damage thermal or mechanical damage it can induce on the retina. Sometimes if the fragments are very closely adherent to the retina, that time you might induce retinal hemorrhages or retinal breaks also. Here you can see in the inferior portion, you see the small retinal hemorrhage induced by PVD, which has been taken care of with the help of laser endophotocoagulation. So coming to the lens implantation, you can put larger foldable or non-foldable lenses in the sulcus, or if there is no capsular support, then you can go ahead for scleral fixation lens or blue iron technique. Coming to the timing of the vitrectomy, it is best to do at the same sitting of the cataract surgery. Best you can do it in within 1 month, 1 week time, or but 1 to 2 week time, or you have to do vitrectomy by the 3 weeks time. If you to prevent the lens-induced inflammatory complication, you have to do vitrectomy in before 2 weeks time. Here is the another case which has been shown where the anterior chamber lens surgeon has placed the anterior chamber lens and there is a drop nuclear fragment in the vitreous cavity. You should never try to put lens in the in such cases of PC rent and drop nuclear fragment. These drop nuclear cases they are associated with various post-operative complications like uveitis, vitreitis, secondary glaucoma, corneal edema. So to prevent this progressive cycle of lens-induced inflammation, it is better if you do this vitrectomy at the same sitting. It will avoid the second surgery, cost of second surgery, and it will also avoid the counseling for a patient for the second surgery, which is the hardest job for the ophthalmologist. Now, coming to the gauze of vitrectomy. Nowadays, we are doing 23 and 25 small gauze vitrectomy for many retinal, for surgical management of various retinal disorders. But 20 gauze vitrectomy is still a valid indication for these drop nuclear cases, because smaller gauzes instrument are it takes long time to remove the nuclear fragment, and if the nuclear fragment are very hard, you need to have a fragmentome, and 23 gauze fragmentome is not available, then you have to convert it into 20 gauze. One port you need to convert into 20 gauze. And there are another thing is that we are using trocar cannula system for 20 gauze vitrectomy. These are recently operated eyes. For trocar cannula system, you need to have a firm and intact eye. These operated eyes, if they cannot sustain so much pressure of trocar cannula. At that time, you might land up into wound gape, iris prolapse, and hypotony. And hypotony in such cases might lead into choroidal hemorrhages and choroidal detachment. So one biggest principle of treating complication is prevent further complication. So the direct entry with MVR blade is a better option and better practical option.
So was excellent presentation, and really you have shown really the nightmare for all phaco surgeons. And you are a vitreoretinal and a phaco surgeon, so it's easy for you to do the things in one sitting. But average surgeons like us who don't have any backup of vitreoretinal surgery, that as you rightly pointed out, that the nucleus should be removed at the earliest, and maybe a 1 week's time, or you say 3 weeks is also okay.
Yeah, after 3 weeks, the lens-related inflammations, it increases and it will change the outcome. See, if you refer these cases to your vitreoretinal colleague, the results are excellent, mind-blowing. But if you delay this referral to more than 3 weeks, then the lens-induced inflammatory complications add-ons, and it will decrease the it will decrease the visual prognosis. Means visual prognosis will be bad. So before 2 weeks time, the referral is definitely, such cases will give very good surgical outcome, and they will also have a very good vision.
Okay, just a small tip for phaco surgeons, the anterior segment phaco surgeons. What are the do's when they experience a drop? Like, what should they do before going to a vitreoretinal surgeon?
Suppose if you encounter similar condition of that, if you are feeling that something is going wrong, something is not happening what you are desired to do, and if you are suspecting there is a PC rent, you should recognize the PC rent earliest. If you recognize in a later point, you might land up into nuclear fragment drops and all. But never in such cases, if you feel that the nucleus has been dropped, or there is a big rent and nucleus fragments are falling in the vitreous cavity, don't try to fish it at the same sitting. Leave it. Your boundary is up to posterior capsule. If you are attempting any other maneuvers like chasing with the visco cannula or putting vectis and all, you are going to create much more worse problem. If you think that you have encountered such a situation, simply you stop it, do anterior vitrectomy, remove the vitreous from the anterior chamber, and close the wound. And the first and foremost, you call your vitreoretinal colleague that such a such thing has happened, and when your case can be taken up earliest, because there is not much of in a hand of anterior segment surgeon.
Perfect.
Earliest reference should be there.
About the last question, about the lens implantation, you feel that in every patient you should not implant, or if the patient, if the nucleus drop is softer, you can put a lens and get away with the problem?
Yeah, if the nucleus, the softer and moderately hard nucleus can be managed with fragmentum. Fragmentum is just like ultrasonic needle, but it is less powerful compared to the phacoemulsification needle, because you cannot use much power, because we are using it without sleeve. If you use more power, then it might induce the scleral bund around the sclerotomy. So the harder nucleus, like what Dr. Patwardhan and Dr. Santosh Bide has shown, this type of hard nucleus you cannot be tackled with even fragmentum. They need to remove with the help. You have to hold it and bring it to the limbal root. So if you think that nucleus is very soft and small, epinuclear plate has gone, then you can do anterior vitrectomy, create the space over the anterior capsular area and put the lens. That can be done.
Excellent. Thank you, Suhas. Santosh, you want to ask anything?
Excellent surgery by Suhas as always, and he has covered all the points. We should insist that immediate referral to a colleague is a must in case of nucleus drop. And second point which I want to insist is that you have to be very truthful to the patient. If this thing has happened, you have to explain the patient that this has happened. It can happen with anybody's hands, and then you will avoid all the further complications if you are truthful to the patient. Thanks. Thank you.
That's great, Dr. Suhas. Congratulations for an excellent surgery. Dr. Suhas is my batchmate from BJ Medical College, and he practices in Dhule, but such an advanced surgeries he is doing. And so congratulations. We specially invited him today for this conference, and also Saurabh from Sangli. So we are really, really happy and grateful to these surgeons showing such excellent surgical videos along with POS members, of course.
Yes, I agree with Gitanjali. I agree with Gitanjali. I visited his center, and it's really one of the wonderful
Best,
centers,
yes,
one of wonderful centers with all the equipments that are required in his center. Congratulations and best wishes for him.
Thank you. Thank you,
Dr. Suhas Sonane, and we are grateful to have you here, and excellent insights for the anterior segments. And now we'll take the discussion to the next part. Dr. Nikhil Rishikeshi is a pediatric ophthalmologist, and he's going to present the next video, pediatric cataract cases. Over to Dr. Nikhil Rishikeshi.
Yeah. So good morning, everyone. And am I audible to everyone?
Yes, sir. Very much.
Okay. Thank you so much for inviting me here and giving me this opportunity. So I have actually broken up. I've got about 2-3 small videos, 2.5 minutes, so that I can show probably a couple of variations as well. So is the video visible?
No, sir, it is still sharing. Yes, it started.
Okay. So as you can see, it's a congenital cataract in an infant. I think it was a 6-7 month old infant. We did a bilateral cataract 1 by 1. But this is without IOL implantation. You can see that it's a central cataract. Now, in such cases, the anterior capsule can be a little tricky. Now, this instrument is what I really want to recommend to everyone. It's called the microrhexis forceps. I'm sure almost everyone knows about it, and quite a few are using it. But this does give a lot of good control for the anterior capsule CCC. It's really, really important. Cystitome, sometimes, most of the times, the capsule wants to run away. So the runaway rhexis is the commonest complication. So this is a slightly, it gives more control. And then, of course, there is no nucleus, so it's just irrigation aspiration. The cortex has been aspirated bit by bit. And of course, what is more important is the polishing of the posterior surface of the anterior capsule, that is the CCC, and the anterior surface of the posterior capsule. And this is really important so that we don't leave behind any cells, cuboidal cells that will later grow and form a membrane, and after cataract, a PCO. All of us know that PCO in pediatric cataract is 100% is going to happen. So that is why now we can see that with the cutter, we are doing a PBI, the peripheral iridectomy. So I also recommend that the PI should be done before you open up the posterior capsule, so that if there is some bleeding, it will not enter the vitreous and cause a vitreous hemorrhage. So after you do PBI, we are doing the PPC, the capsulotomy with the cutter itself. We can see the margin of the posterior capsule getting cut. So it gives a very controlled sort of cutting with the vitrector, and followed by limited anterior vitrectomy. It's really important. It has to be limited. The word is limited. We can't do over.
Pediatric cataract में primary posterior capsular rhexis करते हैं ना?
That's करते हैं ना.
Dr. Hemashri, you have to mute.
After that, we suture both the cords. Now, is this the second one coming up? Is it visible again? I hope so.
Yes, sir.
Is this? Okay.
Yes, sir.
Now this is another pediatric cataract, developmental cataract, in which we are going to implant an IOL. So again, we stain the anterior capsule with blue Rex. And again, it's the microrhexis forceps that gives us very good grip. You have to be careful right till the end, because even at the last sort of spot, it could run away. So we have to be very, very careful. Like Dr. Bide has absolutely correctly mentioned, the CCC is the most important step. especially for the pediatric cataract surgery, because if it is not intact, the IOL will not stay in the bag because of the positive vitreous thrust. So it has to be in the bag, and the CCC has to be moderately sized, not large. Like in a brown cataract in adults, we do a large CCC. We can't do that in pediatric. The IOL will just pop out because the vitreous is going to push it out. So now we can see that with irrigation aspiration, the whatever soft nucleus is there, it's aspirated. The cortex is getting aspirated. A good hydrodissection, multi-quadrant hydrodissection is very important. You can't inject too much saline at one spot, because sometimes you'll have some dehiscence or some hidden dehiscence, you never know. So a multi-point is good. The IOL is injected, obviously dialed into the bag that we have. And now again, this is a PI that is being done with a cutter. And you go behind the IOL. Now this cutter is behind the IOL. And we are opening up the posterior capsule. So it should be about 1.5 mm smaller than the anterior CCC. You can see the PC getting cut out here. And we are doing the limited anterior vitrectomy. I have sped it up a little so that I could show a video more extra. So that is why probably you'll see that the vitrectomy is not being done, but this is the limited anterior vitrectomy will be, and the sutures. Now again, you have to suture all three ports in pediatric cataract. It is very, very essential because the sclera is not well formed. It is not hard. It is a soft sclera. So that is why it is always important that we suture it up. Okay, I'll show another quick one. I think, yeah. So this is a membranous partially absorbed pediatric cataract, which also we'll see very commonly. We'll see a lot of rubella cataracts like these. We'll see a lot of traumatic. This is not traumatic. This is a membranous partially absorbed. So the capsule at points will be calcified. At points it will be fragile, and sometimes it just tears. Now luckily this one did not. And again, it's a microrhexis. I'm really going to keep on stressing this forceps is magical. Now you can see that it is partially absorbed and there are spaces out here. So this is a primary PC dehiscence. I have not done anything there. There is already a dehiscence out here. So you do a careful hydrodissection just to loosen it up as much as possible. And with the IA, we are trying to remove it, taking care not to aspirate too much vitreous. Now, the advantage that we have in pediatric age group is that the vitreous is a semi-solid gel. So the vitreous is not liquid, it doesn't come out immediately until and unless we really irritate it quite a lot. Then it won't stop. But till then we have our space, we reduce the irrigation and bit by bit we try and, but it's still going to extend. But you have to remove the cortex as much as possible. And it's fine if it extends, only thing under control. You have to know, and you have to, it can't extend beyond a certain limit. Otherwise, obviously you can't place the IOL in the back. Now with the cutter, again, 23 gauge cutter at a high speed cut rate, it's essential that you cut all the vitreous from the anterior chamber and do a limited anterior vitrectomy, aspirating whatever little cortex if possible, making it clear, ensuring that there is no vitreous in the anterior chamber, where you don't want the vitreous staying there and causing a wick or displacing the IOL later on. And then of course the IOL is implanted in the bag because we already had a CCC, and the posterior opening has, or the dehiscence is controlled. So you can still place it in the bag. Then of course again we do the PI. There is no change in that. What if we are trying to see if there is any vitreous in the anterior chamber, and again you suture them up. So if I have time for another one, I can show one more. Should I? Quick one?
No, I think.
Okay.
So we are running short of time.
Sure.
Nikhil, excellent presentation. Really, pediatric cataract is a challenge. It's not a bread and butter of everyone, every surgeon, and you have done it excellent job. Only a single question. Is it mandatory to do a PI in every case? And if it is so, why?
It's always better, sir. It's always better to do it because you never know. With the pediatric glaucoma or lens post-cataract surgery, glaucoma is such a known entity that you just want to try and do everything possible to try and maintain a good aqueous flow so that there isn't a pupillary block. whatever you can do, whatever we can do, we do.
Okay.
I mean, it is needed in every case, a very clean case. And the other thing is, we really don't know which pediatric cataract after surgery is going to show up with glaucoma. Everything
Correct.
can go smooth, but if there is something in the angle, a dysgenesis, an agenesis, an ill-formed trabecular meshwork, we really don't know what is going to happen. We don't know.
Correct.
As a prophylaxis.
True, yeah. As a prophylaxis, we do it. Perfect. Excellent. Excellent presentation. Thank you.
Great. Thank you so much.
Thank
Good point that you have to suture all the ports. That's a very valid point.
Yeah. Otherwise, it just doesn't form.
Yes.
Actually, you should err on the tighter side, because you can
Yes.
have it a little tighter because the sclera is so soft. It's not going to cause astigmatism.
Correct.
Yes, Nikhil, what rightly you have pointed out that vitreous is really a semi-solid thing and it doesn't come out so easily unless until you really want to bring it out.
Oh, you have to try really hard.
Yeah, really try. Well, I have been doing pediatric cataracts for a long time, and and I have very well noticed this that it doesn't come out unless until you really want to bring it out. I know. Yeah, true. And CCC is a crux for pediatric cataracts. It's really challenging. And really you have to be vigilant at every point, and you cannot be just lenient ki ata hota and jhala. That's not the case. At that point of time, it will run away.
It will run away, yeah.
Correct. At the end only it will run away. You feel that now I am able to complete, and suddenly you'll see that it is running away. Perfect. Good.
Yeah, and even in very clean case, sometimes there is a very high chance of, because of the unpredictable outcomes, there can be pupillary block. That's why I fully agree with Nikhil that we should always do peripheral iridectomy. Theoretically, it's not required, but for all practical reasons, we never know in which patients, even in a very clean case, there is a pupillary block because of anterior movement of the lens. So that's why I think PI is a good option.
It's a point well taken, because I have been doing pediatric cataracts for last many years, and I have not been doing PI, and somehow touch wood, I have not faced any problem because I have done cataracts of 4 months, 5 months. And now my youngest patient is now 22 years old. I have done a secondary implant, and she is pursuing his studies in US. So
you are lucky, Sanjay.
Yeah, I'm lucky too. But henceforth I'll change and do a PI for all patients.
Luckily, we have the tool called a good vitrector. I think it's really essential that
Correct. Yeah. Thank you
so much.
Excellent cases and take-home messages. Now we'll take that discussion a little further, and I request Dr. Prasad Valimbe to show his video on pediatric glaucoma cases.
Yeah, Mukesh, do you have it? Yeah, actually, congenital or pediatric glaucomas are not very common. They say if a general ophthalmologist might see just a few, maybe in single digits. But one should know what to do in such patients. I'm not able to see the video.
Just a minute.
So this patient which I am showing, it's a 1-month-old baby, which I just done 2 weeks back in Dinanath Hospital. You can see the increased corneal diameters to around 13 millimeters. See, because of the increased corneal diameters, the white to white is much beyond the insertion of the conjunctiva. So for this eye, the corneal diameters are 13 millimeter. You can see the corneal edema because of the acute eye drops. Now, after doing the Fornix-based conjunctival flap, we should do gentle cautery. We should always plan examination under anesthesia and the surgery in the same sitting, just so as to avoid the repeated general anesthesia to the small kid. The pressure in this eye was 28 millimeters of mercury, and the other eye corneal diameters were normal, and the pressure was 14 millimeters of mercury. A rectangular flap, the base should be 4 to 5 millimeters, but the height can vary. We should be extremely careful because the scleral flap should be around 50% of the scleral thickness. With the help of a crescent knife, we gently dissect this flap We should be extremely careful because the sclera as well as the limbus is very, very thin. There is a very high chance of scleral perforation or the flap perforation. The procedure of choice for congenital glaucoma is trabeculotomy plus trabeculectomy. So we are proceeding for trabeculotomy. You take a vertical nick where the scleral fibers end or the junction of white and blue, and then you gradually dissect till you see the Schlemm's canal. How to identify Schlemm's canal? You'll see a sudden gush of aqueous and blood. This is the Harm's trabeculotome, which the key thing is it should go very smoothly inside. Then you maneuver it inside the anterior chamber so as to break the abnormal mesodermal tissue overlying the trabecular meshwork. Similarly, you insert the Harm's trabeculotome in the other side. So this is trabeculotomy. Then you proceed for trabeculectomy. You make the nicks on the scleral flap, and with the help of your punch, trabeculectomy punch, you can proceed for trabeculectomy. So only trabeculectomy doesn't suffice. Even the goniotomy or only trabeculotomy also doesn't suffice. I'm trying to do the trabeculectomy with the help of punch, but as usual, the punch was not working. So I shifted to age-old technique of our 1-hour Caesar. And in selected patients, one can apply mitomycin C before the start of your scleral flap, 0.2 milligram per cc, 0.2 milligram per cc for 2 minutes. The iridectomy should be good so that the iris doesn't block the ostium. Then this scleral flap should be sutured with 10 nylon. And if you find it leaking, one can have additional suture in between. Another important thing is to wash the undersurface of your scleral flap so as to clear it from the debris. Now here you can see even the corneal edema is subsiding. In fact, on table you can see a little bit of clearing of the cornea. So this is one of the surgeries which are really very rewarding. You can really prevent the childhood blindness. 2 key points in suturing the conjunctiva. You should include the episcleral tissue so that there is a watertight closure of the conjunctiva. And also you can have a partial thickness corneal suture going through the conjunctiva so that there has to be a watertight closure. And at the end of surgery, you can inject subconjunctival dexamethasone and atropine. So these are the patients which really require this type of surgery, not only trabeculectomy or not only trabeculotomy, but a trabeculotomy plus trabeculectomy. And the results are really rewarding. You can see on table clearing of the cornea also. Yeah, thank you. Thank you for the opportunity.
Excellent, excellent. It's really a challenge for doing a pediatric cataract and a courage also, because really they are very tiny eyes and with low scleral rigidity, thickness is very small. Very well done, Prasad. Very well done. Thank you.
Thank you.
Any other questions?
Dr. Valime, मला एक प्रश्न आहे.
Yes, yes, please.
Overfiltration, underfiltration, according to you, in your experience, pediatric glaucoma किंवा ट्रॅप प्लस ट्रॅपच्या नंतर तुम्ही जास्त काय बघितलंय, अंडर का ओव्हर फिल्ट्रेशन?
Under. So yeah. many times they do require second surgery.
Correct.
In this patient specifically, under examination under anesthesia, the pressure was around 28. Pressure is never big because because of the low scleral rigidity, the eyeball increases in size. Instead of pressure, the eyeball increases in size. Whatever I could see the fundus through that white cornea, the nerve was also good. So this was the right time to intervene. So as soon as the child is fit for anesthesia, you should take him immediately, and also plan the examination under anesthesia and SOS glaucoma surgery in the same setting. You just can't afford and take the risk of giving repeated anesthesia to the child. Afterwards, in fact, checking the pressure in such small babies is quite easy than the toddlers, because you ask the mother to breastfeed the baby nicely sleeps, And in the lap of the mother, you can check the pressure with the Perkins tonometer or your handheld tonometer.
Fantastic.
But as far as possible, try to avoid repeated anesthesia. But sometimes, in spite of your good surgery, the glaucoma progresses, and there is no role for medical line of management.
Right.
In fact, some of the patients I have seen, they have been put on brimonidine, which is a strong no-no in childhood glaucoma, because the child can go in apnea. The only drops which you can use maybe for the time being, just to buy the time, either latanoprost or timolol, or if the pressure is high, till the time you do surgery, you can give oral carbonic anhydrase inhibitors 1 milligram per kg body weight with pediatrician supervision. But the essential treatment is surgical, and you have to monitor the pressure afterwards.
Absolutely. So in fact, because of the low scleral rigidity, the optic nerve doesn't take a beating.
Yes. But if done at the right time, if it persists for maybe for a few months altogether, there is an optic discolor, and you cannot do something for that.
The increased size of the cornea or the increased size of the eyeball, it doesn't go back to normal, does it?
Yeah, it's a very good question, because most of the parents, especially mother, asks me this question.
Yeah.
In fact, I have observed in some of the patients which have been done less than 1 month old. Sorry. What did you ask?
So I think it is just 10 to 20% reduction in size will occur.
Yes. If done at the right time.
Yeah.
But it won't regress dramatically.
Right. One last question, if I may.
Sure.
So how many cases have you seen after intervention with trap plus trap? Have you seen pediatric cataract occurring?
Not many, because if you are seen over here, don't enter into the antechamber except when you are doing the trabeculectomy. In fact, over here, one mistake you will see, a small air bubble has slipped inside, because air is also cataractogenic. Fortunately, many of my patients in which the air bubble was there, they didn't develop cataract. The longest follow-up which I have now is around 22, 23 years old. They are still fortunately doing well. Pressures are under control. No anti-glaucoma medicines are required, or except for the fact that they are highly myopic. But the vision is in the range of 612, 69 corrected vision, and that is the longest follow-up I have. Cataract, just 1 or 2 patients I have observed.
Thank you, sir. Thank you so much.
And just Prasad, a small question.
Yeah, sure.
How frequently you monitor the intraocular pressure?
After surgery, every visit. So initial visits I usually plan every week, and after that, if everything is fine, just like your pediatric cataract, 3 monthly. But till they are in teens, I feel that every 3 monthly pressure checkup is very important. Unless you are damn sure that the pressures are absolutely normal and are not fluctuating, then a 6 monthly follow-up is also sufficient.
But
in the immediate follow-up, every week I follow them.
Okay. And the pressure checkup may be lifelong?
Yes, of course.
Great. Wonderful.
Requesting others to mute yourself, please.
Thank you so much.
Can you give a few words on visual rehabilitation of such patients? Amblyopia treatment and all that, a quick few words.
Yeah. In fact, that's one of the very, very key point which is always neglected, because doing surgery and doing postoperative is just one part. Like a pediatric cataract, congenital glaucoma, or a pediatric glaucoma, according to me, the main treatment starts after that, because in such patients which have been operated at the right time, they have good visual outcomes. But many times the patients usually show very late. In spite of your good surgery, the pressures are not that much under control. The vision is not that good, and especially for bilateral cases, they always require low visual aids. Sometimes, if they are totally blind, a blind school and vocational rehabilitation is also very, very, very important. So that counseling as well as that backup is very necessary. And that's the purpose of having a frequent follow-up counseling. But that's a very valid question, and that's a very important question. The same thing applies for pediatric cataract also. According to me, the half work is just surgery and half work is after surgery. The follow-up is very important.
Thank you, Dr. Prasad Valimbe, sir.
Thank you.
Take-home message is sclera is soft in pediatric cases, so eye can increase in size, pressure cannot be controlled, so lifelong follow-up, and importantly, visual rehabilitation is required. Excellent take-home messages, Valimbe sir. And now I request Dr. Mukesh to present a video of Dr. Suhas Sonawne, phaco in silicone filled eyes.
Cataracts is a frequent complication of vitreous surgery. Generally, it occurs between few months to few years after the vitrectomy surgery. Cataract surgery is a challenge in vitrectomized eye, and the post-vitrectomized silicone oil-filled eyes are even more challenging. Removal of the vitreous has profound effect on cataract surgery. Normal eye, the vitreous is firm and it will support the cataract during the surgery, and it will maintain the normal depth of the anterior chamber. But when after vitrectomy, when there is no vitreous, the eye is filled with fluid and aqueous, it will not support the cataract, and during the surgery, the chamber will be very deep and the posterior capsule will be more mobile, and there might be a zonular weakness. Though it's safe to do phacoemulsification in such cases, but these eyes cannot be treated like normal eyes. You need to take some more extra care while doing this type of cataracts. We generally do this combined procedure of phacoemulsification and silicone oil removal after 4 to 5 months of the primary surgery, after the primary surgery, and we also confirm whether retina is attached well before the surgery. Most of the time, you will see lots of primary posterior capsular fibrosis in such cases. And initially, we do phacoemulsification and oil implantation, and then we proceed for the silicone oil removal procedure. Here we are using 23 gauze sutureless technique to remove the silicone oil. You need a strong aspiration force to remove this silicone oil because it is too viscous. And once you complete your silicone oil removal procedure, you have to remove small tiny silicone oil bubble over the surface of retina by doing repeated fluid air exchange. And you have to make sure that you are not creating any hypotony while removing the 23 gauge cannula. This is another case. Per se, the cataract may not be challenging, but post-vitrectomized eyes will have a high incidence of intraoperative complications. Generally, in post-vitrectomized eyes, you will get a nuclear sclerotic type of cataract. But here you can see if you have some lens touch during the vitrectomy, you might get a wide such type of cataract. So you need to keep other options ready because you might land up in posterior capsular tear or lens drop in such situation. You have all options open while doing such type of cataract. Here you can see suddenly the silicone oil comes up from the posterior capsular defect, which must have been at the time of occurred at the time of vitrectomy. So everything in plan need to be changed. You have to remove this cortical material under the silicone oil without any irrigation. So the chances of intraoperative complications are very high in such types of cataracts. That's why you need to take a lot of precautions and you need to keep all your plan and options open. Here I'm removing this cortical material under silicone. I want to preserve that opening of the anterior capsular capsulotomy for future implantation. So here the plan is changed. Now I have to remove this oil from the limbal root through the primary posterior capsular defect. Once you remove the oil, then again you do repeated fluid air exchange to remove the small bubbles from the retinal surface. Here we are implanting the lens over the anterior capsular support.
So was very well presented, very nice, and very important tips that you have given. And really, it's a challenging cases when there is no posterior vitreous support, that the chamber becomes deep repeatedly. And any tips to take care of that for an anterior segment surgeon, or you recommend any vitreous irrigation or anything of that kind can help to reduce that problem?
No, actually, this type of cataracts, they have our underlying retinal pathology also. So anterior segment surgeon need to explain to the patient that even after successful surgery, there might not be so much of great visual improvement. And the second thing, because of lens power calculation also can be vary, and you must explain to them that refraction may be, he might get some post-operative refraction also.
Correct.
And while doing the surgery, anterior segment surgeon also do some slit lamp proper workup, whether there are zonular defects there or not. And while doing the surgery, he must anticipate that the chamber is going to be deep. As such, most of the time, these eyes are myopic, and there is a deep anterior chamber, and with no vitreous inside, it might cause very deep chamber. And doing as soon as you enter your probe inside the chamber, you will see the sudden deepening of the chamber. It might give a lot of problems while doing the capsulotomy also. At that time, at this time, we suppose, and in cases where the eyes are filled with the silicone oil has got it floats upward, so it tried to push this posterior capsule toward the it pushed toward the anterior direction, and it makes your job very difficult. Doing rexis is also become difficult. Management of nucleus also become difficult, because you may most of the time you might land up into posterior capsular tear, and also the placement of the lens also become difficult. So you need to take a lot of extra care, and he has to have a vitreoretinal backup for doing such kind of cases.
Thank you, sir. Thank you for excellent presentation. Seema, you can take over.
Thank you, Dr. Suhas Onane. Excellent take-home message, like the post-operative refractive errors should be counseled for such a silicone filled eyes. If Dr. Santosh Bhide is around, there is a question from audience. Dr. Aditya Kaka wants to ask you a question.
Yes, please. Yes, I'm here.
Do you use any cohesive viscoelastic material along with dispersive?
Yes, I do use. I use Orogel and Orovis PFS. No financial interest, but I use Orogel along with Orovis PFS.
Any other
I use
question?
Orogel for capsulorhexis. Then after capsulorhexis, I use Orovis, which is methyl cellulose that coats the anterior chamber. And then just on the top of the nucleus, I inject Orogel. And before starting, I remove that Orogel so that BSS replaces Orogel. So it's a try soft shell technique of Archinop. And there is no wound burns. I think for hard cataracts, we have a tendency to use more power, and there is a high chance of wound burn. So it is always better that you remove some visco from the anterior chamber before starting phacoemulsification.
Great.
Thank you, sir. Now, I thank all faculties and Chairman Dr. Sanjay Shah, and I declare this session as over, and I request Dr. Mukesh Paryani to take over the next session. Thank you very much.
Thank you. Thank you very much. Excellent session. Thank you.
Thank you, everyone. It was a wonderful session and well conducted. We are starting a refractive surgery session now, and we are absolutely bang on time. I welcome all the faculties as well as delegates to this refractive session. First of all, let me just call upon the chairman of this session, Dr. Ambarish Dharak sir, a very, very well-known, renowned refractive surgeon, very senior refractive surgeon, has had enormous experience of refractive surgery, practicing at various parts in India, and also a keen filmmaker. So I welcome you, Dr. Ambarish sir. Yes, sir. And also we will just quickly go through the faculty that we have lined up today for the refractive surgery session. Starting with Dr. Ridhima Bagli. We all know she is a young dynamic refractive surgeon and the director at the Medilasers as well as the Nayan Jyot Eye Clinic. Dr. Ladi sir, past president of POS and past president of MOS, extremely dynamic refractive surgeon. Dr. Vardhaman Kankaria, he has got an enormous experience and amazing n number of publications. We could not write in this one slide, so here it is, Dr. Vardhaman Kankaria for us. Professor Dr. Natasha Pahuja, and she has also n number of publications and she has amazing interest in the scientific research, mainly on keratoconus and refractive surgery. Dr. Shruti Varke, my colleague from done a fellowship from Narayan Netralaya, Bangalore, and she heads the cornea, cataract and refractive surgery department at Vision Next Foundation in Pune. We are very happy that you are here with us, sharing your experience. And last but not the least, Dr. Susan Jacob, and she is the director at Dr. Agarwal's Refractive and Cornea Foundation and recipient of n number of awards. We are extremely fan of her surgical videos and her presentations all over the world that she does. So with this, I would stop the screen share, and we welcome all. And we can, if I have the permission of the chair, Dr. Ambarish Dharak, we can proceed with the first presentation today.
Sure, Mukesh.
Good morning, everyone. Respected seniors, colleagues, mostly friends, I'm very happy to start the refractive session. But at the outset, I would like to thank Pune Ophthalmological Society, especially Dr. Geetanjali, Dr. Mukesh, the wonderful team, for this opportunity. I'm going to start the session with my talk on groundwork for refractive procedures. So to start off with, when we are working up a case for refractive surgery, the first thing and important thing, unfortunately, that we think of only is the corneal thickness and the parameters related to that. But I think before we move on to that, the first thing that we need to see is the patient as a whole. We need to look at the eye in total and look for any systemic factors that may contribute and affect the outcome of our surgery. More important even than just the ocular or systemic diseases is the patient's personality. We need to assess why he wants to undergo surgery, what is his motivation and his expectations from our procedure, so that we do not end up with an unhappy patient at the end of it and we do not lose our patient peace of mind at the end of it. That's the most important thing while working up a refractive patient. So the factors that we consider before planning refractive surgery, the first and foremost is the age of the patient. Ideally, the age of the patient needs to be 21 years of age completed. And that is because this is a quick Randleman's ectasia risk scoring system, which considers 5 factors. And the younger the age of the patient, the higher is the risk of ectasia happening. So here we consider 5 factors like the age of the patient, the magnitude of our refractive error, the pre-op corneal thickness, the residual stromal bed, and the topography. So if we are operating on an 8 diopter myopia when the patient is 20 years of age, he's more at risk for ectasia versus if he's 30 years of age. So the age of the patient, we usually wait firstly for him for the refraction to be stable. Even if he's 21 years of age and if we find that he's using a -3 and our refraction says 4.25, we still wait for the refraction to be stable. So it should not have changed by more than half a diopter over the past year. We need to wait for the refraction to be stable before planning for refractive surgery. Now that we've seen the lower age limit, is there an upper age limit for refractive procedures? We get a lot of patients in the presbyopic age group who would be willing, who are keen to get rid of their near vision glasses. So how do we manage these patients? Again, here we need extra chair time to see what their expectations are, what are their day-to-day activities, how much is their uncorrected near vision helping them in their day-to-day activities, and are they going to be unhappy after we correct their myopia? So counseling the patients is most important, but options for presbyopic correction, either, you not do anything, but if we feel like the patient is a good candidate, firstly, while working up these patients, we need to find which is their dominant eye. After finding their dominant, non-dominant eye, I would suggest that we do like a small trial with a monovision, because all of these procedures are going to induce a small amount of a myopic error or increased depth of focus, spherical aberration in the non-dominant eye, and giving them a trial with spectacles with like a 1.5 add in the non-dominant eye would give us an idea whether they're going to tolerate this procedure. So assessing the patient in total and customizing the procedure in this age group is extremely important. The second factor related to gender, if it's a female patient, we need to ask leading questions, elicit history of pregnancy, lactation, any hormonal treatments she's on before planning for refractive surgery. The third, looking for ocular comorbidities or systemic comorbidities, looking for blocked meibomian glands, dry eye, and treating these adequately before proceeding with the surgery. Also asking for history of any autoimmune collagen vascular diseases that may lead to unpredictable wound healing, or history of keloid tendency that could cause haze after a surface ablation. These things need to be looked for before we choose what procedure we want to go ahead with. The next is the magnitude of error. So what are the limits? Usually the error should be at least more than 1 diopter. The maximum I would say do with LASIK would be about say 8. SMILE can correct up to 10 diopters of myopia and up to 5 diopters of astigmatism, or allowing, taking into consideration the pachymetry, keratometry allows it. So as an example, I've taken a patient, suppose he has about a -9 diopters of myopia. How do we decide for this pachymetry, a normal topography 540 or 530, can we proceed with a refractive surgery for this patient? So what do we consider? So for every, this is the Munnerlin formula wherein the magnitude of error, how do we correlate that with the amount of ablation that we need to do? So the amount of ablation depends 1/3 on the magnitude of error and 2/3 on the optical zone. So for every diopter that we need to correct, roughly, we are going to be removing 13 micron of tissue for a 6 mm optical zone. So for a 9 diopter, that would come up to around 110, 112 microns of ablation. So I think this term is also familiar, like residual stromal bed. How much do we leave behind in LASIK or in SMILE? How do we calculate that? If we subtract the amount of ablation that we need to do from the earlier formula and you add that to your flap thickness or your cap thickness, and you subtract these two values from the total corneal thickness, we would know how much is the residual stromal bed. And ideally, we need to leave behind at least 300 microns of residual stroma after a LASIK procedure. But now the more popular term is percentage tissue altered. That means if the same value was expressed as a percentage, if you add your flap thickness and amount of ablation and express it as a percentage of the total corneal thickness, then we would be saying that not more than 40% of your cornea needs to be altered by our procedure. So in SMILE, we would say the cap thickness plus the lenticule thickness expressed as a percentage of the total corneal thickness. So in this case, if we are considering like a 9 diopter correction with a 1 diopter cylindrical correction, our residual stromal bed thus would be like around 260, 270. We are almost altering 48 to 50%. And the first slide that I had showed, an ectasia risk score of more than 4 is considered to be high risk. So probably in this case, we would not go ahead with a laser procedure and probably go ahead with a phakic IOL procedure. But this is just an example to show what factors we consider and how we see if it's okay and safe to go ahead with a laser refractive procedure. The next factor is the corneal thickness. If this is like a low myopia and the corneal thickness is about 480, 490. So this is usually what we consider as the lower permissible limit. Less than 480 or 470 microns of corneal thickness would be a red flag sign to proceed with a corneal laser procedure. In this case, these parameters show that it is safe to go ahead even with a LASIK procedure, or you can opt for a surface ablation procedure if you have reservations in terms of the corneal thickness. The next important factor to consider is the keratometry. So the keratometry is important because you do not want it to be flatter than 35 diopters or steeper than 50 diopters after a hyperopic treatment. And how would that be calculated? Usually, roughly for every diopter that you're treating of myopia, it would flatten your cornea by 0.8 diopters. So that would lead to an optically poor optical quality of your cornea if you were to leave it very flat or very steep. So estimating the post-op keratometry is an important factor before proceeding with refractive surgery. Also, the keratometry is important. You don't want it to be too steep or too flat when you're planning a blade LASIK procedure, because you don't want to end up with buttonholes or free caps, and that has to be kept in mind before planning for a refractive procedure. The most important factor, the pattern of topography. So this is the a quad map on topography printout, which shows the anterior elevation, the posterior elevation. Here you see that there is a steepening on posterior float, the pachymetric map, and the sagittal curvature. So this I have just put up to show that if it's suspicious on topography, that does not mean that you go ahead with surface ablation or SMILE. A contraindication for LASIK should be a contraindication for all corneal laser procedures. In a topography pattern like this, I would suggest that you wait and follow up the patient and see that it is stable before planning for a non-corneal procedure probably. So a workup of a refractive procedure would involve a good refraction, a cyclorefraction in all cases, testing which is the dominant eye, because inevitably after the surgery, patients are going to say one eye sees better than the other. So if you have that documented beforehand, that would be helpful. A thorough eye examination, anterior segment, and dilating, seeing the rest of the retina and making sure there are no treatable peripheral retinal lesions, assessing for tear film in every patient, doing at least a basic T-BUT and Schirmer's test, the pupil size measurements to make sure that you don't have a very large pupil size, the mesopic pupil size, and a corneal topography after discontinuing contact lenses for an adequate amount of period. So to summarize, assessing the patient's expectations and needs is the most important first step. Looking at over every parameter, not just the corneal thickness, and making tweaking and making small changes to get an adequate refractive outcome. Counseling the patients what to expect after surgery, all side effects, all possible complications have to be explained to them beforehand, because it's a refractive cosmetic procedure. And the most important thing, the first step that we all refractive surgeons need to learn is when not to touch the patient. Knowing when not to operate is the most important step. So thank you for your attention. I would be happy to take any questions.
Yeah, Dr. Darak sir, your inputs, please.
Two things I just want to know. As per my knowledge, the minimum thickness criteria about the cornea for any refractive procedure has been given as 490.
Okay, sir.
So one should not operate when the corneal thickness, central corneal thickness is less than 490. And second thing, so it is applicable in all the cases, provided you can take a liberty of 10% when you are doing a surface ablation procedure. Then that percentage ablation index comes to normal thing. And second thing, now I think we have a important role of corneal tensile strength now, say with the new equipments, the diagnostic modalities available. So I think that has become an important criteria before we take any patient for refractive surgery nowadays. So Ridhima, you have experience about that. So can you comment on that part also, please?
Yes, sir. So actually, yes, I've missed out on including the corneal biomechanics and measuring the corneal hysteresis, so that could also be an important factor in predicting ectasia risk later on in these patients. So yes, thank you for your input. So I've forgotten to mention that.
Yep. So that was Dr. Ridhima telling us the groundwork for any refractive surgery. And the last line is the most important when you said that when not to operate is the most important thing in a refractive surgery. Now moving on from selecting a patient, now what procedure to select for the patient? I invite the next speaker, the eminent speaker, Dr. Vardhaman here. He can start the screen share and proceed with his talk.
Thank you, Dr. Mukesh. Can you see my slides?
No.
It is already shared. Can you see them?
No.
Not yet. Okay. It is already on share mode.
Now it's seen. Yeah. Please go to the full screen mode. Yeah.
Yes. Thank you. Thank you very much. So I think first of all, I would like to thank Dr. Gitanjali ma'am and Dr. Mukesh for the kind invite to be part of this excellent session. And after we have understood how to select the patient from Dr. Ridhima, I'm going to tell you how I choose the ideal refractive procedure for each of my patient. Friends, we all have to know that refractive surgery of today is a dream realized. These are the surgeries to eliminate or decrease the dependency on glasses or contact lenses. And they are a 5 to 10 minute, very quick, endless, and in today's time, completely bladeless and flapless procedures with a great amount of wow effect. A survey done by SCRS has shown that 97% satisfaction index, which we have seen in refractive surgery, is much better than any other lifestyle modifying surgery that is done on the human body. From there of RK to today's era, where we have the entire armamentarium of refractive surgeries which are available to us, it is very crucial that we actually choose the best possible technique for a given patient, because we want the best safety, best efficacy, and also the best longevity of the treatment outcomes for all our patients. So it is also equally important to know that one size does not fit all, and we have to customize the decision of choosing the best refractive option for a given patient, and that plays a huge role in patient satisfaction and safety profile. Just to give you a small heads up, is basically what can happen if you don't choose the right procedure for the right patient. Although every single procedure is a great procedure, but we have to really choose the best for that given situation. So this was a patient who was actually a traffic police person, and this patient had undergone advanced surface ablation with one of my colleagues elsewhere. This patient landed up in having post-PRK haze, as we can see. When the patient was referred to us, we had to do a PTK ablation along with mitomycin C and the haze reduced. However, this is a case scenario in which you should understand that a patient who is highly prone for UV light exposure and has to be on the street all the days, or let us say in the Western world is a surfer by profession, they should avoid undergoing advanced surface ablation. Here is another patient. You can see that this patient was actually an athlete. He was a football player, and he had a mild trauma while playing after about 2 to 3 months of his femtolasic procedure. And you will see this mild stry and mild displacement of the flap, which happened, and it required flap reposition in this case. So these two cases basically tell us, although all the procedures are great, it is very, very crucial that we actually choose the right patient with the right procedure. In the previous case, a flap procedure should have not been chosen because an athlete is more prone for eye injuries, and a flapless procedure such as SMILE or surface ablation is the best choice. We have already learned about optimal patient selection. So after the patients have got selected and patients have realistic expectations, that is when we come to all the armamentarium. Friends, refractive surgery today is a completely different specialty. That means we have multiple options which are available for the patients today. And a refractive surgeon ideally should be well versed with each and every of these 7 surgeries which are required as a refractive procedure. So as we all know, we typically use corneal laser procedures for the patients who are suitable for corneal lasers, who have a, let us say, emetropia less than 8 or 9 diopters. If the cornea is not suitable or the emetropia is higher than that, we choose a phakic lens implant such as ICL procedures. And rarely, if the cornea is not suitable and the internal space for ICL is not enough, then only we go for what is called as a natural refractive lens exchange procedures. So just to give you in the next 3 slides a small overview of what are the procedures and how we choose them, is that if you have a patient who has a low to moderate emetropia, that is less than 9 diopters of myopia, less than 5 diopters of hyperopia, and less than 4 or 5 diopters of astigmatism, that is the time, and if the corneal parameters are suitable, we go for laser vision correction procedures. The laser vision correction procedures can be classified into being flap-based procedures, such as microkeratome-based flap LASIK surgery, or it can be a femtosecond LASIK surgery, which is basically a femtosecond laser flap-based procedure, or it can be a flapless procedure, such as advanced surface ablation on the surface, or a lamellar flapless procedure, such as RELEX SMILE, which is currently the latest generation surgery. However, it is not only on that. Basically, when you have to look at the total parameters, it is very important that you do the wavefront as well as the topography of this patient. For vast majority, that is more than 95% who are suitable for corneal refractive procedures, have excellent topography and very, very good wavefront. These patients can undergo what is called as a wavefront optimized ablations. Wavefront optimized or aspheric ablations can be done with LASIK, with femtolasic, with surface ablation, as well as with SMILE. But given a situation, we always prefer a SMILE procedure for them. However, if the patient has topographic abnormalities that you see, then you should choose what is called as a topographic guided femtolasic, which is also known as contour. And if the patient has a significant wavefront aberrations, then you should go for what is called as a wavefront guided technology for these patients. Of course, there are a lot of patients who come with very, very high emetropia, who have more than 9 diopters of myopia, more than 5 diopters of hyperopia, who have high astigmatism, and corneas which are not suitable for laser because of either thin corneas, keratoconus suspect, or who have keratometry which is not deemed to be suitable. In this case, in vast majority of them, if the anterior chamber depth is 2.8 or 3 millimeters, we go for phakic lens implants such as ICL. And if the ACD is inadequate, then we go for refractive lens exchange. So this is general overview. But let us look at a typical common scenario. So I think we did a small survey in our Asian Eye Hospital to see, and we have seen that more than 80% people are actually in this common typical scenario in which they have a mild to moderate myopia, excellent topography, and basically all the parameters which are known to be ideal. If this is the situation, currently my first choice is a RELEX SMILE procedure, which is also known as small incision lenticular extraction. And if the SMILE is not possible for that given patient because of reasons that we will see now in the future slides, then I go for other corrective procedures. So what is SMILE? So basically SMILE is a small incision lenticular extraction in which we are actually creating a disc of the corneal lenticule with the help of a femtosecond laser, which is a super precise laser. As you can see, this is the posterior cut of the smile. This is a side cut of the lenticule. This is the anterior cut of the lenticule, and this is only a 2 mm incision that we have created. With this 2 mm incision, now I'm going to have the access to go and remove this lenticule. So this is known as currently the most minimally invasive technology for lamellar procedures. I have identified the superior and the posterior plane of this lenticule. I'm going in and I'm dissecting this lenticule out. This is the anterior part of the lenticule that I'm seeing, and this is the posterior part of the lenticule. Once the lenticule has been dissected completely, then I go with the forceps and I remove it in toto, and this is the end of the procedure. So the beauty of this procedure is basically we have the advantage of both. We have the advantage of advanced surface ablation because we have a flapless procedure with possibly better stability. And we have the advantages of also femtoLASIK, in which we have a much faster recovery without any pain or haze, which is seen in advanced surface ablation. So the Relax Smile, because it gives me the advantage of both technologies together, this becomes my first choice whenever it is possible. Nowadays, we do see a lot of patients who are using computers and they have mild dry eye. So another thing which is in SMILE is basically being flapless and without having any flap issues. We also have less induction of dry eye. So you will see that in SMILE, the disc that we are trying to remove is much under the anterior subepithelial nerve plexus. So we preserve more nerves in SMILE as compared to the basic procedure. And because of that, you will see that the corneal neuropathy is much lesser in SMILE. The dry eye parameters by both objective as well as the subjective parameters are better, and the corneal sensations are also better preserved. And variety of publications have already shown that SMILE leads to less induced dry eye parameters. So the indications for SMILE currently for me, for vast majority of my patients, are moderate to high myopia between 2 to 8 diopters, low to moderate myopic astigmatism. I treat up to minus 1.75 astigmatism with SMILE. And if there is anything beyond that, then I go with tubercle-guided femtoLASIK procedure. If there is a pre-existing mild dry eye, of course, we should choose either surface ablation or SMILE. And if a patient has contact sports, then definitely you require a flapless procedures. I don't do SMILE currently for very low myopia, such as less than -2, where I prefer advanced surface ablation. Patients who have hyperopia or pure or very significant astigmatism, the topo-guided femtoLASIK is the procedure of choice. Coming to the next cases, you will see that this is a very good case for laser procedure. However, this patient has a very significant astigmatism of -2 diopters. So if anybody has -2 or beyond astigmatism, the procedure of choice becomes topographic guided femtoLASIK procedure, because that is the one which will correct your astigmatism in the best possible way. This is another case who has an asymmetric bow tie with a bit of superior steepening. All the other parameters have been normal. We published about 7 years ago that superior steepening is not a contraindication for laser. And we have seen in a follow-up of 5 years that there are very safe procedures with LASIK or femtoLASIK. So again, in this case, because we have a topographic abnormality, a topographic guided femtoLASIK or a contour is going to be the best choice for this patient. Another patient who has hyperopia. So you will see that this patient has a hyperopia who is 27-year-old and has a flat cornea, a very good topography. Again, the procedure of choice is going to be topographic guided treatment. When it comes to topographic guided LASIK or femtoLASIK procedures, you have the choice of making the flaps either with the mechanical microkeratome or with the femtosecond laser. Generally, the femtosecond laser based flaps, whenever I have to make a flap, is what is going to be my choice, because the femtosecond laser flaps are more safer, they're more precise in its thickness, they're also more customized in terms of their diameter of the flap and other things, and they are also known to have better fitting to reduce the chances of epithelial ingrowth. I choose mechanical microkeratome only for patients who can't afford the femtosecond laser flaps, and especially if the patient already has a corneal scar or incisional surgery in the past, because the femtosecond laser application in them will lead to what is called as epithelial breakout because of vertical gas breakthrough. A very particular thing, which is the advantage of topographic guided treatment or contour in hyperopic eyes, is basically because the topographic guided treatment inherently have the centration over the visual axis, as against a typical femtoLASIK surgery, which is going to be in the center of the pupil. And this is important for hyperopic eyes because they typically may have a very significant angle kappa, and that should become your first choice. Again, another case in which you should avoid microkeratome assisted LASIK and perform a femtoLASIK or a topo-guided femtoLASIK is when you have a very flat cornea, because there is a higher chance of flap complications such as free flaps. So friends, the second choice of procedure for me in my institution is topographic guided femtoLASIK that I choose when the SMILE is not possible. For example, for people who have very high myopic astigmatism, people who have high hyperopia or hyperopia, people who have pure astigmatism, and people who have flat corneas less than 42 diopters. I avoid any flap creation in patients who are in occupation who are prone to trauma or who are athletes, for example, who have significant dry eye, and people who have epithelial basement membrane dystrophy because they will be at high risk of development of what is called as epithelial ingrowth. The third procedure of choice for me, which becomes a backup, is for situation when the lamellar procedure is not possible, when I go for surface ablation. Surface ablation has had a great resurgence from the past and is a great tool. Dr. Natasha is going to speak about it now in the next talks. But like in this case, where you are not very sure about the topography and the corneal, basically myopia is only moderate, surface ablation becomes a great choice. Another case, when the topography is borderline, the myopia is moderate, the surface ablation should be planned and you should not plan any lamellar procedure. So these patients did very well with surface ablation and are absolutely perfect. Another case who has a 2.5, 2.75 diopters of only myopia. And as you can see, the cornea is very thick, but the cornea is steep. It is 49 diopters. So basically, because the corneal topographic parameters again are borderline, but the myopia is low, we can still go ahead and perform a surface ablation procedure after following up this patient for 6 months, just to see that everything is very, very stable.
So may I request you to sum up, please?
Yes. So I have just very few, like 2 or 3 slides more. So basically, this is a specific situation in which you can combine the surface ablation with collagen cross-linking when patients have suspect keratoconus. We did a small study that we published in which we have seen different kinds of surface ablation. They give rise to different results, but actually all the kinds of surface ablation procedures are actually equally good in this scenario. And the last approach is the lenticular approach, as we discussed, in which if you have a patient who has a very high myopia, such as this case, -11 with -1.5 cylinder, or a patient who has moderate myopia but low corneal thickness, as you can see in this case, where the thickness is 480 microns, but the myopia is about -7 diopters, or you have a patient with very, very thin cornea, such as 450 microns, but on low myopia. These are the patients in which you should actually plan a phakic lens implant, such as ICL procedures. There are a variety of ICL different lens implants which are available today, and we plan they include ICL, RIL, IPCL, and also the ones from Biotech, which is iCry. And for patients who have extreme emmetropia, you can always plan bioptics for them by combining the ICL along with the corneal laser procedures generally. And the last but the least is when nothing else is possible or the patient has more than 40, 45 years of age, you can think about refractive lens exchange as well. And as it was also discussed in the past, it is very important that in some patients you have to avoid everything and just reject the patient for all refractive procedures. So just to conclude, newer techniques of corneal lens-based and bioptic approaches have optimized outcomes of wide spectrum of refractive errors. It is very important that you have to customize the decision and have a good know-how of each and every refractive surgery and not only one. We have to take into account all these parameters to give the best possible outcomes for our patients. Thank you again to POS and Dr. Sharma ma'am, Dr. Mukesh for the kind opportunity to present my talk. Thank you.
Thank you, Dr. Vardhaman, for a wonderful presentation. With just respecting the time constraint, we'll take questions at the end if that's okay for you.
Perfect. Thank you.
Yes, and we will move to our next talk. Is by our own past president, Dr. Jeevan Ladi sir, and he will be speaking on safe technique for the SMILE surgery. I'm going to screen share for his video from my laptop, please.
Thank you, Dr. Mukesh. Shearing applied force extraction of lenticule by reverse pull with wow factor in refractive lenticule extraction. There is no financial interest in this video. Sometimes going in the reverse direction is beneficial. Femto laser makes 4 cuts. The first cut is a posterior lenticular cut, as you can see in profile view also. Then it makes the second cut, which is a side cut of the lenticule, which moves 360 degree vertically. Third cut is anterior lenticular cut, which goes beyond the posterior cut for better dissection. Fourth cut is incision taken at 110 degrees. As you can see in profile, the incision cut is seen. Laser makes tissue separation by series of air bubbles. This is the posterior cut. Energy is kept moderate, 150 nanojoules. First cut starts from periphery to center, and anterior cut starts from center to periphery. We are presenting a simple technique with better results. The need of less inflammation and early visual recovery. Strategic dissection is done for the optimal results. You create initial pockets anterior and posterior to the lenticule. This is the anterior initial pocket, and this is the posterior initial pocket. So further dissection is easier. We are going anterior to the lenticule now. While going posterior to the lenticule, we do a swiping motion so that posterior lenticule is separated well. Now we go obliquely away from the posterior pocket to the opposite side. Dissect left and right half. Then separate central 3 mm area behind the lenticule. Separate 180 degree away from the incision. Then paracentral quadrant is separated and only right paracentral quadrant is kept, attached and removed last by using safe technology. This is very safe and predictable technique with minimal time required for the removal of the lenticule. The stoma around is not manipulated much. As you can see, we are going oblique away from the posterior pocket, go to the opposite end of the wound and dissect about 30-degree area to create a track from the incision to the opposite end. Then slowly we dissect above the lenticule in an anterior pocket. First we do the left half of the incision, then we do the right half of the incision. An anterior pocket is now completely separated. While going behind the lenticule, we depress the instrument so we enter into the right plane. Then we dissect central 3 to 4 mm area to create a potential space and the separation doesn't become haphazard. Now we bake through the lenticule opposite wound for about 180 degree. This brings the lenticule towards the incision. Then we separate the left para-incisional quadrant. So now only right paracentral quadrant remains attached. We keep it attached because that gives a control, and we remove the lenticule by safe technology. Check lenticule 360 degree, inspect for any tears. To get a wow factor, you should have a less inflammation and early visual recovery. Do adequate hydration. Use lenticular pressurized dissection, that is whenever you are separating the tissue, press onto the lenticule for separation, so surrounding tissue is not disturbed. That gives early visual recovery. Do stomal massage vertically and horizontally. Milk out the BSS injected inside the wound. This apposes the tissue quite well. Operate under high magnification for better tissue separation. As you can see at the end of the surgery, on table, on a slit lamp, cornea is seen crystal clear. This is the immediate post-op picture. And day 1, cornea is also seen more pristine, clear, with a vision of 20 by 20 in more than 95% of the patients. This technique is effective even in complicated cases like opaque air bubble. You can see left upper opaque air bubble. Do separation very gently. Remove left paracentral area by safe technology where air bubble was there. You can see black areas surrounding the central part showing inadequate energy or missing energy. While dissecting, take care that you are going along the plane of the lenticule to avoid tearing of the tissue. And once you do that, remove the tissue by safe technology. In conclusion, use safe technology, lenticular pressurized dissection, high magnification, adequate hydration, and stomal massage. Now, relax, relax. Because it gives a wow factor. And smile. Because it's safe. Shearing applied force extraction of lenticular by reverse pulling of lenticule. Thank you.
Thanks, Dr. Mukesh. Thank you. Thank you so much, sir. It was a wonderful technique. I mean, the clarity of the video was too good. It's an explanatory video for many of us. And any inputs from the chair? Dr. Zarak, any inputs you want to put?
It was a very good presentation. I don't have much experience about that SMILE yet. So probably you people only can contribute something to that video. Probably Natasha, Vardhaman.
So, yes, it was an amazing video. Now moving on, the topic that's kind of actually coming back in a big way, and who else better than Professor Dr. Natasha Pauja to cover it on PRK. Dr. Natasha, please proceed with the screen share. I request all the speakers to please stick to their timings. We have a huge session ahead of us.
Is my screen visible?
Yes, ma'am. Yes, ma'am. Yeah.
Okay, perfect. Thank you so much, Dr. Mukesh, for that kind introduction and invite. And thank you, Dr. Gitanjali, ma'am, for this humble opportunity. In the next 10 minutes, I'm going to be talking about why is PRK or surface ablation or trans-PRK not the primary choice of treatment for refractive surgery. Now, we have seen how the refractive surgery is involved. It started with the radial cuts on the cornea to the minimally invasive 2 mm, 1.5 mm cut, removing the lenticule to SMILE. But what has still stood the test of time is that we still are performing surface ablation, whereas other procedures have gone out of vogue. So why is it that? I mean, there is something which is beneficial in that procedure, and we need to see how to overcome the limitations of it. So let's just do a little problem-based understanding of this. Now, if I have the luxury of all these 3 procedures in my clinic, I want to know what of these corneal procedures would I choose in a very tricky refractive dilemma case. So, for instance, if this is the cornea, the thinnest corneal thickness is 490, has a refractive of -3 and a -1.5 diopter of cylinder. What would you do in such a case? Of course, how Dr. Ridhima earlier mentioned that we're going to do a strict screening with the ectasia risk scoring system by Randleman and the PTA by Marconi Santiago. So coming to that, let's just see what do we get in this particular case. So the age of the patient is 26-year-old male. So the ectasia risk scoring system is just 2. But if we do a flap-based procedure, we are going to be taking off about 110 microns more. With the ablation, depth is not so much, which is 90 microns, but the thinnest corneal thickness is 480 or 490. In this case, the PTA is 49, which is actually not an ideal case for refractive surgery. But if we just change this 110 and reduce it to half, which happens in surface ablation, then this would be a good candidate to consider for refractive surgery. So it would be a good candidate for surface ablation PRK. But the limitation which probably stops us to consider PRK is probably the haze. Most of us have a cutoff of -4 diopter sphere or a -2.5, 2 to 2.5 diopter cylinder. And the other limitation is post-operative pain, which is a major limitation for the patients. So let's just see, how do we tackle this? What are the predisposing factors that we can avoid probably with considering bringing haze into perspective? So the only thing that we can modify in all of this is probably the ablation depth, and we can keep the cornea hydrated and make sure that the corneal temperature during the surgery does not increase, which is why wash it with cold VSS. Understanding how does haze really occur is, now this is a very simple pro-healing response. As soon as there is an insult or surgery to the cornea, there are a lot of these mediators that are released. They act on the keratocytes. Now this is called the pro-inflammatory response. As you can see on the confocal image, there are increased activated keratocytes. Then comes a pro-fibrotic, that is a TGF-beta pathway, which basically converts these keratocytes into myofibroblasts. So as you can see here, these white hyperdense images are the myofibroblasts. They are bigger in size as well. Now these myofibroblasts basically lay down normal collagen, and then myofibroblasts undergo apoptosis. But what if there is inflammation, if mild inflammation or there is chronic inflammation? In that case, the myofibroblasts do not get converted into normal collagen and they lay down aberrant collagen because the pro-inflammatory response is continuing. So in this case, as we can see here, there is excessive myofibroblast and fibroblasts, which causes aberrant collagen to lay down, and hence what we clinically see is significant haze. Now the haze post PRK or post ablation is very, very typical. It's got a granular appearance. So what do we do in such a case? Now you would say that there is inflammation, why not simply treat it with steroids? You're right to a certain extent. Now steroids work on only certain aspects of these inflammatory modulators, but they do not work on Wnt pathways or complement pathways or other modulators that are present in the haze pathway. So what do we understand by this? We published this paper in Scientific Reports where we determined all the factors that are possibly present in causing haze. But what we also noticed was that these are responding very well to mitomycin C. Now, the usual protocol for mitomycin C is that everybody uses 10 seconds for every diopter that is of diopter or spherical equivalent that is being corrected. Now, there's a very interesting paper that had come up which basically said that you can reduce the usage of mitomycin C from 0.02% for every diopter to instead just use it for 12 seconds, and it is equally effective as 60 seconds or 90 or 120 second application, and it had a huge sample size. So from that time onwards, we have reduced the contact time or the application time of mitomycin C on the ocular surface. Furthermore, advancing a little more, there is a new molecule, a new kid on the block, which is called SAHA. This predominantly, if you notice here, it does not, the pink images that you see on the first image on the top, that is basically a pro-fibrotic response. So a lot of pink or red is basically not good after surgery. This is also something that causes a lot of changes in the collagen that is being laid down, and it is not normal collagen. But if you see in the lower image, which is SAHA, the red images or the pink images, which is alpha SMA, is not significantly elevated. That means there's not too much of pro-fibrotic response. which means is very, very classically targeting only the area which is causing haze and not touching any other aspect of the corneal wound healing response. So which is incredible. What is even more better about this is that it does not have any effect on the limbal epithelial stem cells. So even if there is dispersion of SAHA on the rest of the ocular surface, nothing happens to the rest of the ocular surface. So we're waiting for this drop to be commercially available. Other factors that we can clinically today start doing right now is probably, this paper was published in IGO very recently by Dr. Fogla, to look at certain preoperative factors, which include history and the clinical examination. Of course, we have to rule out dry eye disease. If there is, we have to treat it. For history, the most important factor is to look where the patient is going to work post-surgery. If the patient is exposed to a lot of outdoor activity and a lot of UV radiation, you would want to treat the patient with UV blocking glasses, or probably treat the patient on soft surface steroids and other immunomodulators like cyclosporin for a little longer time. You also have to rule out and treat if there is allergy. And if the patient is wearing contact lenses, you have to treat the patient with soft surface steroids for a little time. Other thing that can be clinically tested is that we can measure the amount of MMP9 that is there on the ocular surface by a screening tool, which is the RPS rapid kit. The other way is that we look for other immunomodulators, like checking for serum vitamin D. If a patient has got high risk factors for developing haze, it would be ideal to check vitamin D, and if the vitamin D is elevated, you won't want to treat that first. Also, if there is surface inflammation, you would want to treat it with probably 6 weeks of cyclosporin, because cyclosporin actually takes 2 weeks to start acting. In patients who already develop haze, the ideal treatment for that would be to treat them with topical steroids for a little longer time. And this haze, before it sets in, you would classically see it probably on the second or the third post-operative day itself, where the cornea does not look pristine, does not look clear, the stroma underneath the healing epithelium. Other thing that you want to add is doxycycline, because it stops the proliferation and the increment of matrix metalloproteinases on the ocular surface, thus decreasing the inflammation. And of course, treating with vitamin C is also important. As we mentioned earlier, please provide UV protecting glasses, irrespective if they go out, if they are working outdoors or not. The other factor, which is a limiting factor for us to choose surface ablation, is pain. Now, there's a very interesting work that has been done by Narayan Nitrale. They use topical ketorolac preservative-free solution. And what we found was that compared to the conventional treatment, after putting ketorolac eye drops, it was still better, but after making a depot of the contact lens. So basically, the contact lens that is used, 20 minutes before the patient, you place the contact lens on top. Just 20 minutes before that, you would want to inject 0.2 ml of ketorolac in the bandage contact lens. And then this bandage contact lens, after placing it for 20 minutes, you can then directly, after the procedure is done, after the PRK or surface ablation is done, we can go ahead and place the bandage contact lens. And it was noticed that the ketorolac solution made sure that in almost every patient, the pain score had reduced significantly. Some of the patients even said that they didn't feel any pain post-operatively. Now, these are overcoming the limitations. But what is it that the surface itself, the surface ablation itself provides advantages for? First and foremost, after numerous studies and having stood the test of time, we have realized that surface ablation or PRK is a biomechanically much stronger procedure as opposed to LASIK, even as compared to SMILE. This paper was published by Abhijit Sinha Roy, where they have looked at the finite element modeling, and they've realized that PRK is relatively leaving a stronger residual stromal bed as compared to LASIK and SMILE, which is again a very good news, especially for the refractive dilemmas or the thin corneas that we have. To make it stronger, you can always go ahead and do a PRK extra. Now, this is another case. An ophthalmologist, she had a smaller refractive error and wanted refractive correction. Now, if you look at the corneal topography, This is again a refractive dilemma. She has got inferior steepening, whereas the thinnest point is slightly deviated, but all in all, the corneal topography looks normal. Now, if you look at the bad D total, it's 1.6, and the standard deviation for it being suspicious is 1.60. So 1.56 is not too far away from 1.60, which means this is slightly suspicious corneal topography, but with a stable refractive error, 29-year-old female. So in this case, my personal choice would be doing a surface ablation of PRK. Now, there has been a significant advantage. Earlier, we used to use various methods to remove the corneal epithelium, be it mechanical scraping or alcohol debridement or using PTK. With the advancement in certain lasers now, I personally have had my hands on Schwind Amaris, which is providing a smart surf technology. So it is no touch. You don't have to touch the corneal surface at all. What it essentially does is that it shapes the cornea in such a way that the epithelial removal.
Dr. Natasha, can you sum up, please?
Yeah, this is the last slide. Is so smooth that it does not cause a gutter in the periphery, and hence there is no hyperopic shift, and hence the treatment profile is much better. And they have also shown that compared to other procedures, trans PRK is as robust as LASIK or SMILE. So in summary, if we have certain modifications in the pre-op and intra-op factors and take care of very subtle changes, very simple clinical changes, probably we can resurrect surface ablation and bring it as close to SMILE as we are doing today. Thank you very much for your kind attention.
Thank you so much, Dr. Natasha, for a wonderful talk. And we will ask questions at the end of the session if we have the time permits. We can now proceed to the next talk by Dr. Shruti Varke Patil, and she's gonna talk again on a gray area, the management of presbyopia using a corneal-based approach. I request Dr. Shruti to please share the screen and start the presentation, please.
Yeah.
Is it visible? Hello? Hello? Am I audible? Hello?
Yes, Dr. Shruti, you're audible.
Yeah, good morning, everyone. Thank you, POS and Dr. Mukesh and Gitanjali ma'am for giving me this opportunity. Is my PPT is visible?
Yeah, just go on the full screen mode, please.
Yeah.
Please limit your time to 8 minutes.
Yes, definitely. Okay. So today's topic, I'll be discussing mainly the presbyopic LASIK. There are different modalities we correct the presbyopia, spectacle, contact lens, surgical. But today I will be mainly talking on the corneal based, specifically the SupraCore, which is the platform by Bosch and Long, which I myself have experience about it. Okay. So just to sum up, there are different Presby LASIK procedure which are center based or peripheral based and laser blended vision. So which we will be discussing is SupraCore, which is a central Presby LASIK where we actually target center for the near vision and the mid peripheral zone for the intermediate and distance vision. So main principle of this SupraCore is it causes the central 3 mm area hyperpositive area, which induces the negative aspheric ablation for the near vision, and the distance, which is corrected by the aspheric optimized model for the intermediate and distance vision. So one thing we have to consider that it is a totally pupil dependent procedure. So we have to, when we are pre-assessing the patient for same, we have to check the pupillometry and the angle kappa very cautiously, because if there is a problem with that, then patient won't be happy. Just to show that when we plan for the SupraCore or the presbyopic LASIK for the near plano subjective fraction, in SupraCore, there are hardly central ablation is very minimal, around 5 microns in the plano patients. So switching to the SupraCore, we have to take a detailed history of patient about his lifestyle, his expectations, and as any for routine LASIK examination, we do the refraction and visual acuity for near distance.
the main important part with the presby-LASIK, we have to check the dominance of the eye, because all the presbyopic LASIK procedures, they are on dominant and non-dominant eye. We have to customize the treatment according to the dominance. Then again, as I said, pupil is very important. So we have to check the pupil, scotopic and photopic. So for the supracore, which we use, the photopic pupil should be at least 2.1 for the hyperopes and at least 2.9 mm for the myope patients. As I said, more dominance we have to check, because as we target more for the near, we are sacrificing more for the distance. So in dominant eye, we usually target for the distance, and for non-dominant eye, we target for the near. So in every patient we are planning for the presbyopia treatment, we have to give the simulation test either by the glasses or by the contact lenses. So what we do is we give full correction for the best. We give full correction in the trial frame for distance, and we add plus 0.5 diopter. Bilateral, if you are planning for the bilateral treatment, we add bilateral, or if you are planning only for the non-dominant eye, then only in the non-dominant eye. And we have to tell patient this might be the distance vision after surgery. If patient is okay with that, then probably supracore is a good choice. But if patient is not comfortable with that vision, then supracore may not be the best choice for this patient. Other for the near, on the best corrected distance vision, we add plus 2.5 or plus 1 according to the patient need. And if patient is happy with this near vision, then we can actually go ahead with the treatment. But if patient needs more addition than plus 2, then probably the this presbyopic treatment is not a very good option for the patient. So in the presbyopic treatment, the targets are not the default target, which is set in the software. It is not plano. It is always minus 0.5, but you can change the treatment according to that. So this target of 0.5 diopter, it causes the increase in depth of focus as approximately around 1.75 to 2 diopter in the central zone. So that actually gives patient a clearer near vision. And the distance vision, we actually compromise for loss of one or two line as per the treatment protocol. So we have to be very clear with the patients while counseling that the expectation has to be realistic. It won't be the presbyopia, any presbyopia treatment. It is to correct the presbyopia. It is not to cure. And it is to reduce the dependency on the glasses. It is not exactly that 100% they will have to stop wearing glasses, or it is not like that. So we can try the presbyopic treatment pseudoflux, but there are a few challenges we have to face. So if there is a corneal scar and already the cataract surgery is done, so there is a wound abnormality, then if the IOL has a tilt or any decentration, it itself induces any abrasions. So it is difficult to correct the presbyopic treatment. Also, the dry evaluation is very important pre-op, because we have to check dryness and we have to treat dryness if it is there, because tear film itself induces so many abrasions, so it can interfere with our results. And of course, in pseudophakic patients, there is a loss of accommodation. So that range of residual error we have to keep in mind while treating the patient. Okay, I would like to just discuss few cases. So this is the 44-year-old female auditor, and she really doesn't want to use any glasses and doesn't even want to use the progressive glasses. She is a mainly hyperope for distance and with +1 addition, and all her pre-op assessment seems to be okay and give green signal for the presbyopic treatment. But when we gave the simulation test, she is comfortable for near, but not very happy for the distance. But she is very happy with the monovision. So in this case, what we have done is in the dominant eye, she has a right eye dominant. So we have targeted right eye totally for distance. So we have done the aspheric treatment to correct for the distance. And in the left eye, which is a non-dominant eye, we have given the supracore regular treatment. So regular treatment, we target around addition of plus 1.5 to 1.75 for near, and post-op she is very happy because her distance is binocularly, she has a distance vision of 6 parts with N6. There is another case. She is a 50 years old female and doesn't want glasses for near work. She's a housewife, doesn't drive and anything. So you have to keep in mind patient's real expectations after the surgery. That is very important in presbyopic classic. So on simulation, she is very happy for near, and there is a drop of one line for the distance, but she doesn't mind it. And so what we have done, we have planned bilateral treatment, and we have given a regular treatment in both eyes, targeting around 0.5 diopter myopia. And she is having 6/9 binocular vision post-op and with N6. And post-op, she is very happy because what she wanted in her life is for the near vision. She doesn't want a dependency for the glasses. So it's about, while planning the patients, we have to really check for their expectations after presbyopia. Every patient has to be informed that this is to reduce your dependency on the glasses. And you have to tell the patient that presbyopia is a dynamic condition and the treatment is static. We are correcting the current accommodation problem. And any patient, they might require the top-up surgeries after a few years, like 5 to 7 years. And another very important thing, we have to tell patient that they cannot compare both eyes separately, because it's a binocular treatment we are targeting, and adaptation time is there. The neuroadaptation with this new multifocality at cornea, it might take 3 to 6 months. Okay. There is another case, which is 36-year male who has a hypermetropia plus exotropia around 20 prism diopters with left eye amblyopia. He has definitely having right eye dominance. He also doesn't wanted glasses. We have explained that this treatment might because of the problem with angle kappa, as this is a pupil centric procedure, but his angle kappa was around 4. So we have to restrict our treatment around till maximum 5 degree. Usually it is 2 to 3, so maximum 5 degree. So we treated him for the right eye mild supracore and the left eye regular one, which was an amblyopic eye. So post-operatively, his right eye vision was 6/9 parts and N8, and left eye 6/12 parts and N6. So in this condition, when there is a high angle kappa is noted, treatment should be fired exactly on the center on the visual axis. It is very important for any presbyopic treatment. We have to ablate on the visual axis, because these treatment works on this principle where center is very important. There are different, there is one more patient with a hyperopic where we have planned both eyes supracore. Okay, there is one, this is the 52-year female where she has a history of LASIK done in 2015, and she is very happy with her distance vision. So her distance vision is 6/6 unaided, but now she requires the glasses for near with +2 addition, and she really doesn't want to use glasses. So even pre-LASIK treated patient, we can go ahead with the presbyopic treatment, but it's better if you are able to relift the flap, because even if you do a new flap, it itself induces more abrasion. So relifting the old flap was done in this case, and we have done right eye mild supracore and left eye regular, because right eye was the dominant. You can see here for the plano refraction for the distance, it's hardly center, the ablation of tissue is very minimal. The center is 5 mm, and around mid periphery it is around 19 in dominant eye, and in 23 microns in the non-dominant eye. So you can see this center presbyopic classic, there is a advantage of minimal tissue ablation, and they are more physiological than the peripheral presbyLASIK treatments.
Can you sum up, Dr. Shruti?
Yes. So to conclude with the talk, I would like to say that being this LASIK procedure, there is no additional learning curve. Rather than doing the surgery, it is the main important thing is planning and the patient counseling, which is very important. As talking about the supracore, it is there are various studies. So hyperopes and emetropes are more happy with the central presbyLASIK treatment. and the multifocality which is induced is more pupil physiological, as it is a pupil centric. So mainly the key points are, we have to select the proper case, and the patient's understanding the patient profile and his expectations are more important. Customization according to the patient needs, because it is a bilateral treatment we are planning. It is not a unilateral treatment. So we have to customize the treatment according to the patient's need. And we have to do the proper counseling, because it takes around 3 to 6 months for the adaptation. Thank you. Thank you so much.
That's the very reason it's a pretty much a gray zone in corneal refractive surgery, because there are so many factors that revolves around the outcome in a presbyopia. So we'll come back to we have some questions for you, but we'll come back to it once we are done with the last talk. And for the last talk, I would like to invite Dr. Susan Jacob. Welcome, ma'am. Welcome, and thank you so much for joining us here. And we are looking forward to your talk. And who else better than you to speak on Pediatric SMILE? Dr. Shruti, can you just stop the screen share so that ma'am can start?
Yes. Thank you so much, Natasha and Dr. Mukesh, for having invited me here to this beautiful conference of yours. As you said, my topic is Pediatric SMILE. I am just going to share my screen. Yeah, just 1 second. Okay. So I'll try to keep it short and within the time. It's an 8-minute talk, is it?
Yes, ma'am.
Okay. So, fine. So this is a little bit of a possibly a controversial topic because LASIK or refractive surgery in children is always controversial. I will talk about SMILE in children and basically, 1 second, yeah. Basically, we know that laser refractive surgery is generally approved by FDA only above 18 years of age, and in fact, the FDA website clearly states that it is not approved for patients under the age of 18. So why would you want to even think of refractive surgery in children? Well, there are certain situations where this could be an advantage, and one is bilateral high refractive error. Where you have very high refractive error in both the eyes, and just when the patient is not even cooperative for not able to tolerate glasses or contact lens. So that's the most important thing. Unilateral severe anisometropia with amblyopia is another important indication. And of course, in both these indications, high ametropia and anisometropia, the important thing is you do not consider all children for this refractive surgery, but you consider those who are not amenable to glasses or contact lens use. And you may also have some other groups of children also who cannot wear contact lenses or glasses for various reasons, or who are not comfortable with glasses, and therefore who don't comply with these modalities. For example, if you've got limbal dermoids, or if you've got golden hour syndrome. Also, a lot of patients with behavioral or developmental problems, autism, mental retardation. There could be so many things. Facial deformities which preclude wearing glasses, cerebral palsy, and so on and so forth. And also, we know that contact lenses are sometimes difficult for some patients and parents. It can become very emotionally taxing to have to put this in and take it out every time. The cleaning protocol, the making sure that the children are taking care of it, not sleeping with it on. All this is really taxing, and some patients and parents, even the parents, don't prefer to do this. So that's another situation. Increased risk in some situation, as I said, maybe low socioeconomic status and all these conditions. You could think about whether contact lens would be safe. Are you really exposing the child to a day-to-day risk of contact lens wear? And then, of course, these high errors can cause visual isolation, social and behavioral abnormalities, social isolation, which is so well known. And many times we see that when the child is really able to see well, this social isolation goes and the child starts to actually mingle with the peer group, and his whole personality starts to develop. So as I said, refractive surgery doesn't just give visual improvement, but it also gives social and psychological improvement to the child. The child is not isolated from his friends anymore, and he's more alert and involved. But what are the problems when you do refractive surgery in children? Well, the most important thing, of course, is that this is a still growing eye. So that's something that really has to be kept in mind, and you have to adapt your surgery accordingly. The changing refractive status has to be thought of. Preoperative assessment is difficult. Of course, in children, surgery is more difficult, and postoperative assessment is also difficult. And you can have complications such as induced aberrations, flap-related complications, and so on and so forth. So all these things have to be kept in mind. The commonest indication that I like to do is anisometropia, of course, and over the world over, even more than bilateral ametropia, is anisometropia. And this is generally because of the high risk of amblyopia. There's less motivation for children to wear glasses in anisometropia because they see well with the other eye. And of course, you have to remember that even if you do the refractive surgery, the child is going to become myopic again with the growth of the eye. What are the advantages of this any kind of refractive surgery? You have lesser chance of amblyopia, as I said. You have better chance of regaining binocularity. You have full-time correction of refractive error, which is a big plus, especially when you compare it with contact lens use. It's not dependent on the compliance anymore at all. So you have taken that part away, and the child is able to see with that eye and do the, the occlusion exercises, whatever, everything is able to be done better. No danger of contact lens wear, as I already said, and you have to follow up with glasses for residual refractive error occlusion therapy, and close follow-up is required, of course, as I said. And informed consent is very important for to the parents, because they need to understand that this surgery is really not cosmetic surgery, and you're not you may not be trying to get it to a perfect zero, but your aim is to try and prevent amblyopia and get some amount of binocularity for the child. Preoperative assessment, as I said, is difficult. So sometimes you may even have to do it under general anesthesia, but many children can cooperate also. So older children, you can go ahead and do a reasonably good preoperative assessment. You would need a GA machine, so your refractive suite has to be able to be, it has to be closer to the main OT and things like that. The anesthetist will need to come over if you're doing a child. You have to remember that fixation by the child is not possible. So you're doing surgeon centration. Decentered ablations are possible, so you have to take care about that. The aim, while it could be plano, but it's more important that you're avoiding anisometropia. So that's the more important thing. So you don't necessarily have to aim at plano. Postoperative steroids may be more required more intensively and longer, and a myopic shift with growth, as I already mentioned, is expected. So I'll just skip over this slide. It's just about how the growth of the child occurs. Generally, you wait for 2 years before you consider refractive surgery, and that's because of a huge change in refractive error in the first 2 years. But by the time the first 2 years are over, maximum growth of the eye is over. Also, the cornea is very soft, and suction microkeratoma are unreliable less than this age. So that's another thing. And how you do basically is take pachymetric measurements at multiple locations all over the cornea. You may do a handheld topographer and so on and so forth. There have been cases where refractive surgery has been performed as early as 10 months by Bill Lassell. So now LASIK, we know, is very effective, very popular in adults, and there's really not much pain. But the disadvantages are that the microkeratome is difficult because of the low ocular rigidity. Femtolasic, you may have to shift between machines. You may have to shift the GA machine, even if you're just tilting the trolley around. GA gases, of course, that's most important, can affect the LASIK settings and the outcomes. And of course, flap-related complications in children. It's very difficult to examine this flap postoperatively, and there's a high chance of the flap being dislodged in children. Surface ablation is in that way safer than LASIK, but because there's no risk of flap rubbing, but there is a risk of and the risk of regression. You would need more medical management.
Can I request Dr. Neha to go on mute, please? Dr. Neha.
Oh, sorry.
Also, frequent IOP checks are required. So the haze and regression would be one major problem for PRK. RLE and phakic IOL, again, I'm going to skip over this, but we generally know the disadvantages of these surgeries: higher chance of retinal detachment, high myopes, high inflammatory response, glaucoma, loss of accommodation, and of course the antechamber and the posterior chamber problems with phakic IOLs. So what about SMILE? So we know, I don't have to again describe SMILE. It's basically you're removing this lenticule through a very small incision. The advantages that SMILE offers you in pediatric surgery are many. It is safer, and you are using corneal suction, so that's a big advantage. You're not going onto the sclera. That's a cap again, so that's again another advantage, because there's no risk of flap rubbing, displacement, epithelial growth is much less, dry eye much less. The chances of flap-related complications both intra and post-operatively are much less. GA gases and such things are not a matter of big concern, as is also the environmental factors such as the humidity, temperature, and so on and so forth. You don't have to shift the child. The child heals rapidly. There's less dry eyes, better biomechanics, presumably, and it's also an extraocular procedure. The disadvantages with SMILE, of course, is that you can't treat hyperopia at present. You can't treat HOA. Hyperopia you can treat, but not available commercially. You can't treat HOA presently, and no trackers for astigmatism, but you can do up to -10 sphere and -5 diopter cylinder. So this is just an example of a child we had done. One of the children, 5-year-old child, 636 uncorrected. And this was the right eye, -2, -1.5. cylinder, and in the left eye he had 660 minus 10 minus 1.5. So you can see here the aim is not to get the full correction or plano. So what I did is, since the cylinder was very similar in both the eyes, I left the cylinder alone and opted to treat only the sphere. So we've corrected a minus 10 diopter sphere alone. He had a very good RBT, corneal thickness, as I'll show you. We took a 120 micron flap and a 6.5 millimeter optic zone. Because you do have to think about a possible slight decentration which may happen, though you have to do your best to avoid that. And we had an RBT of around 311. So here's the case. That's just again the pre-op parameters which I just showed, and you can see here the docking which is happening, and you'll see that it's slightly more difficult. Sorry about that. I'm sorry, I don't know, my video is running. Okay, you can see that the docking is sometimes more difficult. You have to take more pains to make sure that it goes well. So you can see that I am having a little bit of trouble there. The child is under anesthesia. The head has to be rotated or kept in position perfectly. And especially when you dock, you have to tell the anesthetist that this is the moment, the next 30 seconds, when the child should not be moving at all. I was not happy with the docking the first time. So you can see I've removed it, and then I have gone on and redocked. And again, here you go. You can see that it's reasonably well centered, and we go ahead with the cuts, and that's the entire cut process done. And then of course the extraction of the lenticule is as you would generally do. So because it's a 10 diopter lenticule, it's really a thick one, and it's really easy to remove. So this patient post-operatively improved from 660 to 618 uncorrected, and I'm sorry, I'll go back to that, and his best corrected visual acuity actually came up to 6.9. You can see that the cylinder remained, and he had a -1 sphere, -1.5 cylinder post-operatively, which was very good because there was no longer any anisometropia for the child, even though he did continue to wear glasses. Here's the post-op post-SMILE topography, and you can see it's a very well-centered ablation, and the child really did very well. So we did about 7 children in the study that we had last, analyzed our results, and the age was around 10 years standard deviation, but the youngest was 5 and the oldest was 15. And we had about these were basically the pre and post-operative refractive error. And I will just minimize this because I've written it here. So the pre-op was between 260 to 360, and post-operatively the uncorrected visual acuity improved around 618, and best corrected was around 615 pre-op, and post-operatively improved to around 6.9. That's of course the average. And the spherical equivalent also came down from about 11 to about 2 diopters. So we had really good results. These were the parameters, about 112 on an average flap thickness, 143 lenticule thickness, and an RBT of around 270. So you have to be careful when you plan, because you need to do multiple pachymetric measurements with different devices and err on the safer side. You don't necessarily need to correct fully, as I said. You just have to bring it down so that the anisometropia no longer exists. And as regards astigmatism, it's not necessary to treat it. Sometimes you can do just the sphere if the astigmatism is not too much. But if the astigmatism is a significant component, then what we prefer to do is overcorrect by 10%. The informed consent is important, and GA is again important. You need to make sure there are no centration errors, rotational errors. As I said, eye and face to be positioned properly, and inform the anesthetist, and no movement while dissecting the cap, while dissecting as well, because that could lead to cap tears. So to conclude, majority of children with ametropia, unilateral or bilateral, do well with glasses or contact lenses, but a minority don't. And it's important that we consider pediatric refractive surgery for this small minority. Pediatric SMILE is possible. It has all the advantages of SMILE surgery while doing away with many of the disadvantages of PRK and LASIK. Hypometropic correction is not possible as of now. Aim is to improve, and perfection is not possible. May not be possible. It's not a must either, and we need not look for perfection. Of course, you have to follow up properly with glasses, occlusion therapy, and close follow-up. Thank you so much.
Certainly, that was a brilliant talk, because there are not many of us, we practice pediatric SMILE, or in fact, pediatric refractive, corneal-based refractive surgery. So it's certainly an enlightening thing. I request a chairperson to have some inputs, please. Dr. Amrish Dharak, are you there, sir?
It was a wonderful talk by Dr. Susan. So 7 cases is too big, because you are doing exceptional work all throughout your practice. And I just want to ask about this pediatric SMILE. Only anisometropia is the criteria in all these 7 patients, or some other criteria was there?
Yeah. for us, we mostly did only anisometropia. Ametropia can also be taken as an indication if the child is not wearing glasses, not compliant at all. But generally, you can find smaller children reasonably compliant to glasses when you have that thing that goes around the ears and all that. So that was not really a big problem for us. But anisometropia, yes, is a problem because the child may not even wear glasses. The parents may also not be motivated enough to make them wear glasses. So that we felt was really one big indication for doing SMILE surgery.
And what is actual thought process behind not treating the cylinder in these cases? Just because it's a SMILE process or procedure or anything else?
Yeah, because you can have centration errors. There's a higher chance of inducing aberrations and things like that if you start combining sphere and cylinder. A sphere is generally a safer one to operate, and you'll have lesser problems happening post-operatively. Especially in SMILE, you may have more of rotational errors because the child is not even fixing. It's mostly surgeon fixation. So unless the astigmatism is significant enough to be causing the anisometropia, I prefer to just leave it alone and treat just the sphere.
I have one small question for Natasha and Vardhaman. How is your experience with topo-guided treatment when you are doing it with femto LASIK?
So, sir, I personally, thank you for that question. I personally do a corneal wavefront guided with Shrind. With hands-on on the Wavelight platform, the femto did not have any significant difference, but with Vizumax, I have noticed that the femto flaps have a little different dynamics. Yeah, little different dynamics as compared to microkeratome. But sir, I've realized over a period of time, the epithelial healing that happens over a period of time on such femto flaps, it sort of causes masking, and it just comes back to how you would expect any topo-guided or corneal wavefront guided procedure to be.
Because post-operative with femto topo-guided treatment, I haven't got a desired result or outcome what you actually look at. Probably, which means say if you are doing PRK, topo-guided PRK or topo-guided LASIK, microkeratome LASIK, you can actually see the map post-operative outcome, which I couldn't appreciate in this femto patient. Even I operated on Wavelight also, and with my present machine also. So what is your experience, Vardhaman, on the same machine?
Right, sir. So basically, I will definitely say that topo-guided is probably slightly more hyped than what is the reality, as you are saying. And it should be actually restricted to only very, very selected categories of patients where we actually see those topographic abnormalities. Given a situation, definitely wavefront optimized treatments in the form of either SMILE or wavefront guided or wavefront optimized femto LASIK or LASIK will give excellent results in more than 95% of the cases. One of the main caveat in topo-guided treatment I have seen is when your corneal astigmatism does not match the refractive astigmatism that you have seen in the patient, these patients actually do very, very poorly after the topography guided femto LASIK or a LASIK procedure. In fact, these are the people who will be extremely, extremely unhappy. So I think there has to be a case rejection that also has to be planned. Not all patients with astigmatism should undergo topo-guided treatment. And definitely a topo-guided treatment will work very well with surface ablation, because in surface ablation, you are actually looking at the real topography of the patient, and that is going to be replicated as against with a flap procedure per se. So yes, definitely, I do agree with you on those fronts. And we did have a small discussion about the same even with Dr. Rohit, because they do a lot of topo-guided treatments there. And he also said the same, that if both of them are not matching, then typically they go for different optimized treatment only for such people.
So if you want to do topo-guided treatment, what will be your choice? Using femtosecond laser or doing it surface ablation or LASIK in this?
So if it is within the, so for me, the surface ablation, let us say right now I'm treating people up to -5 diopters with surface ablation. So if it is in that limit, I will go with surface ablation also. But if it is beyond that, then I'm not very comfortable doing surface ablation. In that case, I would prefer to create a flap. In that case, I'm currently not using microkeratome to that level. So I think all my flaps are 100% with the femto only. And yeah, but definitely if it has to be replicated, surface will replicate it much better than with a flap.
I think
Yeah.
If I can just make one input, when we do topo-guided, one important thing to do is epithelial mapping, because the epithelium can end up, giving you a lot of varying results, which may give you post-operative surprises. So that's one thing you always need to keep in mind if you're doing topoguidon.
Absolutely. Yeah.
Thank you.
Good morning, all. Nice to see Dr. Devdutt here from Muscat.
Hello, Dr. Devdutt.
Yeah, nice to see you all actually on this forum. I just have one question. We went for one patient with a mild keratoconus last week with a topo-guided PRK, as you are discussing, with an Athens protocol. So post-operatively, he was doing well, but vision was 612 from 618. And I noticed a mild haze in his, one eye. So I put him on loteprate post-operatively on a tapering dose right now. But any suggestion regarding tacrolimus eye drops, as one of the panelists mentioned, and what should be should we go for that in usual cases, or should I wait?
Dr. Devdutt, if you have a very mild haze, which is you're seeing immediately post-operatively, that's absolutely common.
Okay.
But what I strongly recommend is, if it's a suspicious case of keratoconus, it's a good thing if you're getting a mild haze, because that's going to, in fact, prevent the progression. If the haze is significant to cause distortion in vision or cause the change in quality of vision, would definitely recommend to use soft surface steroids, and it reduces over a period of time. Even if you don't use steroids for a long period of time, the haze significantly reduces over a period of, say, 8 months to a year or maybe 2 years.
Okay, so loteprate is a good option to probably give for around 6 to 8 weeks, and that should reduce the haze.
Maybe longer.
Okay, okay.
But loteprane is absolutely fine.
I'd like to say that if I see a haze developing that has the potential to turn into a scar, then I generally start either tacrolimus or cyclosporin, because I'd like to decrease that scarring. If a patient scars post CXL, you can almost be rest assured that he's never going to progress again. But the problem is he's going to get a huge amount of flattening in that area, and that's going to cause a lot of topographic abnormalities and a poor quality of vision. So that's something that can do also.
Cyclosporin helps.
Cyclosporin for a long time, yeah.
Right. Natasha, one small question for you. See, you covered the surface ablation so nicely. So in clinical practice, where all these diagnostic modalities or tear film evaluation things are not available in detail, so what will be your ideal prescription for PRK patient post-operatively?
Sir, I do a very soft surface steroids. If the refractive error is more than -3, then I do. If the refractive error is more than -3, I use mitomycin C for just a period of 12 seconds. And post-operatively, I just give surface steroids. I ask them not to step out in the sun. And if they are stepping out in the sun for the next 6 to 8 months, they have to wear UV protecting glasses. If immediate post-operatively on the second or the third day, if I see there is some amount of haze that's developing on the stroma and the haze is not attributed to the epithelial healing, then in that case, I would request the patient to start oral doxycycline for a period of 15 days, because that itself causes a lot of matrix metalloproteinases to break down. And preservative-free lubricants are a good option. If I see the haze is significantly, present on the second or the third day, like Dr. Susan earlier mentioned, I would start the patient on topical tacrolimus as well. So it's just a moderation of treatment. It's not a same treatment for all the patients.
Thank you.
So I thank you so much, Dr. Zarak, and all the panelists, all the speakers for a wonderful refractive session. I thank every one of you personally, because it was entire saga, right from LASIK, SMILE, complicated cases, pediatric SMILE, and presbyopia. So thank you all the panelists and Chairman sir for joining here today. We will now move on to the next session. And I invite Dr. Pranjali to take care for the next session. Thank you all. Thank you, Susan ma'am. Thank you all the panelists.
Thanks so much.
Thank you, Dr. Mukesh. This was a really interesting session and a brainstorming session, I must say. Let's move on to our next session of glaucoma and pediatric ophthalmology. Okay, I welcome our chairperson, Dr. Mrs. Medha Prabhu-Desai, and co-chairman Dr. Prasad Valimbe for this particular session. I welcome you all, our esteemed faculties, Dr. Medha Kulkarni Prabhu-Desai. She's a glaucoma consultant and excellent surgeon at Prabhu-Desai Hospital, and she has published a book titled Atlas of Optic Nerve Head Analysis in Glaucoma. Welcome, ma'am, and she's chairperson for this session. Dr. Pankaj Bendale, a young dynamic glaucoma surgeon who is currently working at NIO. He is a glaucoma and neuro-ophthalmologist consultant. Then he has many publications at international and national levels. Our next faculty is Dr. Neha Zadav Gaute. She's a glaucoma fellow and ex-consultant from Ganpati Netralaya. She's an assistant professor.
What's your name?
My name is
Dr. Vardhaman, you have to mute yourself.
She's assistant professor at Kashibai Navle Hospital. Our next faculty, Dr. Zai Kedkar. She's director at NIO, pediatric ophthalmologist and a cataract surgeon. She has various publications in journals. At present, she's associate editor of IGO pediatric section. Welcome, ma'am. And Dr. Abha Kanade, ma'am, famous strabismologist, and she was the first to receive a fellowship from Strabismology Society of India. Welcome, ma'am. Our next co-chairman, Dr. Prasad Valimbe. He is a renowned pediatric ophthalmologist in Pune. He has edited and written textbook titled Step by Step Screen Surgery. Welcome, sir. Then Dr. Nikhil Rishikeshi is Associate Medical Director, Department at HV Desai Eye Hospital. Thank you, sir. I welcome all the faculties and the chairpersons for this particular session. I'll stop my screen sharing. Let's open our session with our chairperson, Dr. Medha Prabhu-Desai. Her talk is on New Horizons in Diagnostics and Rho Kinase Inhibitors. Over to you, Dr. Ma'am.
Yeah, I'll start sharing my screen.
Yes, ma'am.
Just let me know it's visible.
Yes, ma'am.
Okay. Okay, so today's my talk is newer horizons in glaucoma diagnostics and ROC inhibitors. So there are multiple things coming in glaucoma, and as we know that glaucoma consists of it's like a jigsaw puzzle, and you have to match all these pieces together to say that this patient is suffering from glaucoma. So next few slides are on anterior segment OCT. So this is an assessment of anterior segment structures involved in the pathogenesis of glaucoma. This provides a definition of ocular tissues. It is comparable to histology and comparable also those obtained with UBM, but it is more useful than UBM because we can go to the same segment and same landmarks and capture the same image to see if there is any change. So complementary to gonioscopy, definitely not a replacement. You have to do gonioscopy to see what is going on in the angle, but it is a potential as tool for identifying patients at risk in angle closure. Useful also for patient understanding. It is effective if you show this to the patient and say that this is the open angle and this is closed angle, they understand immediately. So let's now see. We all know how a gonioscopy diagrammatic looks like and how to identify structures on gonioscopy, and let's identify structures on ASOCT. So this is a corneal wedge which we know, and this is Schwalbe's line here, and this is a scleral spur. So these two landmarks are very important in ASOCT. So now let's see. This is a corneal wedge, Schwalbe's line. This is a scleral spur, and in between is the angle structure. So this we can say on qualitatively that this is an open angle. So next one, again a corneal wedge. Here the Schwalbe's line, the scleral spur over here, and you know that this is a narrow or a occludable angle. So qualitatively, definitely you can make out whether these are open angle or not. So on your left side is the open angle and right side is the pupillary block occludable angle. So there are some static risk factors which are important in PACD, that is primary angle closure disease. So once is a lens vault, so you should identify the lens vault because this is an important mechanism. The next is iris thickness and iris curvature. The next is angle opening distance from the scleral spur. So it can be either 500 microns or 750 microns. And the next two are angle recess area, which is a triangular area, and trabecular space area or TISA, which is a trapezoidal area from the scleral spur to the anterior surface of the iris, and the angle opening distance. So the primary angle closure has been divided into 4 mechanisms, that is pupil block mechanism here. The next is plateau iris mechanism. The third one is the thick peripheral iris, and this is a exaggerated lens vault mechanism. Now let's see a few pictures of this. This is a patient with bilateral angle closure. You can see all 4 scans are showing angle closure here, and this is post PI in both the eyes, how the angle has opened up. So this is pre-PI angle, and the right slide on the right side is the post-PI. This is pre-dilatation in an angle where PI has been done, and this is post-dilatation. So you know that the angle remains open even after dilatation. So this is again a narrow angle where there is a almost oppositional angle closure. So it was not possible to do PI in this patient. So we did iridoplasty, and after iridoplasty, just see how this angle has opened up. So there can be certain complications. These are book pictures. So there can be endothelial thermal damage. You can see the capes are there. There can be stromal thermal damage, and there can be thick Descemet's membrane afterwards. So you need to avoid this because the angles are very shallow and the endothelium is very near to the iris. So we know by looking at this that these are the open angles. So let's see a few of these angles. And now here you can see that the iris is totally concave. So this can be seen in patients with pigmentary glaucoma or patients with very high myopia. And you need to check these angles for any pigmentary blockage or pigmentary deposition for these patients. So this is a patient of chronic angle closure, and you can see how the iris is, there is a cynical angle closure in both the eyes. Another patient, you can see that this happens in the patient of NVG. We know that there is a fibromuscular membrane which contracts and the iris is pulled. So here exactly what you can see what is going on in a pathology in a neovascular glaucoma. So in NVG, once you put the AGV, you know how the tube is, where it is patterned, whether it is touching the cornea or not, and how is the intrascleral pathway going on. So this is well covered with a partial thickness scleral flap. So you know that this eye is a safe eye. Coming to MMC bleb, this patient, we had done MMC almost 25 years back, trap with MMC, and you can see that the blab is cystic because of the mitomycin, but you know that it's a good cover of the conjunctiva over there, and a scleral flap is seen with the aqueous pool behind that. So what are the findings on acidity of a good bleb? So there can be multi-layer appearance, low reflectivity of the bleb, reflectivity of even the fluid filled cavity. So this is a fluid and this is the bleb wall over here. So you can make out that the blebs are behaving really well. So this is a patient of blunt trauma. Here you can make out that there is iridodialysis, ciliary body swelling is there, and most important is the patient is having a cyclodialysis cleft. So all these findings can be seen on ASOCT. Again, another patient, you can see the hyphema where there is inferior here, and even the Descemet's folds because of the blunt trauma. So iris Bombay also you can treat with PI. Obviously, peripheral PI will not be possible. So you need to do a PI which is in the mid periphery, as you see here, and there is a resolution of iris Bombay. So coming to the next advance, that is Hood report in a OCT. So it is available with Topcon's web OCT and also Heidelberg Spectralis, and this is an improvement over OCT analysis helps us. So here you get a 9x12 mm cube of a single wide field scan. You have an N5 image and an RNFL thickness map. And the most important is that the report gives you a maculocentric scan. So what is maculocentric scan? So let's see that this is displayed as nestin. Usually we have temporal to temporal, which is a T-SNIT map. So because we know that most of the RGCs are in the center and glaucoma, the central vision is very, very important. So, and we need to find out if there is any threat to fixation. So this scan is very important. So this is a nestin, so which is a maculocentric gap. Just see one example. So here, wherever there is an RNFL thinning 15 degrees from fixation, you will get nasal step over here. So whenever there is a borderline thinning also will give rise to some small loss of decibels over there, and this is very important. Next is, if there is thinning 8 degrees from fixation, you can get a parafoveal defect. So 10 degree pattern deviation shows a parafoveal defect over there, which can progress to form a threat to the fixation. So this is most important finding here. Advanced RNFL thinning, as we know, there is a floor effect. The RNFL is gone down totally. So we know that whether this comprises to the pattern deviation in 24-2 also and in 10-2 also. So this is a truly an advancement over OCT analysis which we have. So coming to ROCK inhibitors, which is the next talk here. So we know that glaucoma is a growing concern, and globally it is a leading cause of irreversible blindness. From 62 million in 2010, it is now almost doubling till 2040. So it's a most important thing that we should identify and treat these patients. So elevated IOP is one of the main risk factors for the onset and progression of glaucoma, and we don't have any drops which are 24 hours effective and which give us some other additional functions also. So let's see what is the emerging role of Rho kinase inhibitors. So these are the Rho kinases are widely expressed in ocular tissues, and they are implicated in the pathology of many ocular conditions, mainly glaucoma, cataract, corneal dysfunction, and even some retinal problems. So ROCK pathway has an effect on reduction of aqueous humor, and which gives us raised IOP. They have some scarring of bleb also, and they can damage RGC and optic nerves also. So we inhibit this ROCK pathway. They are involved in the calcium dependent regulation of smooth muscle contraction, and they have a direct relationship between the it's established between the Rho kinase functionality and age outflow. So Rho kinase inhibitors, how they work? So they decrease the aqueous humor outflow resistance. They also give neuroprotection to RGCs, and there is increase in ocular blood flow. So this is the cellular components are of trabecular meshwork and Schlemm's canal are altered, and hence there is a decrease in aqueous humor outflow resistance. They give enhanced axonal regeneration and give neuroprotection. They cause increase in blood flow by relaxation of vascular smooth muscle, leading to vasodilatation and inhibition of transdifferentiation of tenon fibroblast into myofibroblast. So can be used as anti-scarring agents after glaucoma surgery. They also promote corneal endothelial healing. So introducing netasedil. So this targets underlying disease pathology of glaucoma and decreases outflow resistance. The international brand name is Ropresa, and this is the structure. So mechanism of action of this particular ROCK inhibitor is threefold, that is on trabecular meshwork, net transport, and episcleral veins. So it decreases the actomycin contraction of the smooth muscles, which gives rise to relaxation of trabecular meshwork, increases aqueous flow outflow, and hence there is a reduction in IOP. Net inhibition causes vasoconstriction, reduction in blood flow to the ciliary body, and decreases formation of the aqueous. It also lowers EVP significantly. Approximately 10% of pressure reduction is by lowering EVP. So pharmacokinetics, it is metabolized by esterases. There is no systemic absorption of netasedil, and clinical evidence shows that once daily netasedil is non-inferior to twice daily timolol. There is a consistent reduction of 5 millimeters of mercury over 90 days. All these various studies have shown this. And there is a combination of mechanisms, both proximal and distal outflow pathways, and hence there is reduction of intraocular pressure.
So safety profile includes safe and tolerable performance. Once daily netasertib has a very good performance, and the most important contraindication is hypersensitivity to the active substances or its excipients, and the main adverse effect is mild or transient conjunctival hyperemia. The recommended dosage is 1 drop in the affected eye once daily in the evening. Additional benefits, as we have seen, can be neuroprotection of RGCs, increase in the ocular blood flow. There is a potential to reduce scarring after glaucoma surgery, and also it is known to preserve corneal endothelium also. So netasertib has potential to fulfill the need of the hour, which we want. It has age over conventional therapies. It targets disease pathology, that is effective IOP control, effective as monotherapy and also in combination therapy. There is triple mechanism of action. We have acceptable safety profile for this, and additional beneficial pharmacological properties are there. So this is about the new generation medicine, that is ROCK inhibitors. Thank you for your kind attention.
Thank you, ma'am, for the excellent talk and really advanced diagnostics in glaucoma. And ma'am, I would like to ask you, what is your experience in netasertib?
Yeah, till now I've been using netasertib for almost 6 months now. It was introduced in last summer actually, but because of COVID, actually extensively I'm using it from September. I'm still not using as a primary therapy. I'm using it as a combination therapy. Only one patient had severe hyperemia, but rest of the patients are really happy, and the pressure reduction is from 4 to 5 millimeters of mercury till now. So let's see how it helps us.
Okay, ma'am. Ma'am, are you carrying some study for that?
No, I'm not done any study till now. Okay. It's my clinical judgment right now.
Okay, ma'am. Thank you so much, ma'am. I invite on our next speaker, Dr. Pankaj Bendre, for pitfalls in OCT RNFL analysis.
Yes, yeah, thank you. Thank you for the invitation, and good afternoon all. So I'll be talking about the pitfalls in the OCT RNFL analysis. So I'm audible?
Yes, sir.
Yes, sir, you're audible, sir.
Yes.
So I'll share the screen. So pitfalls in the OCT RNFL analysis. So before going into details, I would like to share this slide, which gives structure-function relationship with which most of the glaucoma specialists will agree that whenever glaucoma pathology starts, it is the RNFL analysis that is first to pick it up. Then the fundus photographs where RNFL defects, thin hairline RNFL defects or wedge-shaped defects, they will start coming up. Perimetry lags behind slightly, and eventually then perimetry will come positive. As Dr. Mehta madam was saying, in the advanced glaucoma, this is the zone, advanced glaucoma, where the OCT gets flowed, and after a moderate to severe glaucoma, then OCT doesn't add much to the clinical value of decision making. So OCT RNFL analysis generally fits into pre-perimetric glaucoma and mild to moderate glaucoma for the taking out the information about the diagnosis and the progression analysis for the glaucoma. So, but this test is not independent of artifacts. Just like any other test, this test also has a lot of artifacts, and that can affect our clinical judgment. So there are certain types of artifacts. Out of that, acquisition-dependent artifacts are also very common. These are caused by the operators. For example, operator is not doing the scan exactly centered around the optic disc. Then some different area gets scanned and some weight value analysis will come out. So here is one example which shows the decentered scan, where the scan is not exactly focused on the optic disc, and that's why this is a decentered OCT artifact, and that is giving rise to red disease. Now, this can be get wrongly labeled as a glaucoma patient, and that's what is labeled as a red disease. When despite patient having the normal optic disc, healthy RNFL, still the OCT analysis labeled that as a glaucoma. So this is what is called the red disease, and this is the decentered OCT. And only solution for this is repeat the OCT, not that one single scan that you do that should give you the exact information. So if there are any of this kind of acquisition artifacts are there, obviously we have to again scan the eye with the well centered on the optic disc and then draw the conclusion out of that information what the OCT patient is giving. Now this is another one common artifact that we see, the blink artifact. When we see a completely black zone coming in the field, so this is where all the readings they go to the baseline, and somewhere hairline some red is analysis is shown on the RNFL analysis, and also this also scan just needs to be repeated. Now this blink artifacts can be at the initial stage of OCT, but then that will, if it comes in the superior zone, it can show as a superior or inferior RNFL defect. In the middle zone, then it can show as a temporal or nasal RNFL defect. But again, all this needs to be correlated clinically, and if you fit this scan doesn't fit into your whole clinical examination, obviously we have to repeat this scan. So this blink artifacts also I see very commonly when patients have done OCT outside on glaucoma medication for a long time. Now, disease-related artifacts are also there. Now, this is related to the large optic disc. Now, all large optic discs are not glaucomatous. Sometimes in the high myopic eyes, when there is a large peripapillary atrophy, there also software fails to identify the nerve fiber layer properly, and that can also go into the red zone. So these are also the common artifacts that we see in the OCT. Another common pathology that related artifact is epiretinal membrane, because that's how the OCT analyzes the thickness of the retinal nerve fiber layer. So if there is any epiretinal membrane or if there is any partial PVD in that area, so sometimes thickness estimation can vary from over towards the underestimation also. So epiretinal membrane also is a likely one which gives us to error into the RNFL analysis. Now there can be instrument related artifacts. So this can be the most two common are patients having any head tilt during the scan or any macrosaccades which they have during the scan. So this with the artifacts due to macrosaccades also appears area as a blacked out area, and which can be identified in the printout. So if you find out this kind of areas, then please repeat the scan. That's the best solution for this. Now, how to manage this problem? So we have to spend a little time to make sure that what we are getting from the machine hasn't been altered by the artifacts. And if you find any artifacts, obviously you have to repeat the scan. Now, there are certain non-glaucomatous conditions that can also cause RNFL loss. Out of that, common things are AION, optic neuritis, optic disc drusen, AION, any toxic, nutritional, or ethymetal-induced optic neuropathies. Some retinal conditions that affect one hemifield, like retinal detachment or maybe retinal artery or vein occlusion, they can also produce any asymmetric RNFL loss, and that also will come in the OCT printout. So before seeing the printout, we should also have a clinical examination also, what to expect from the scan, and whether the whatever scan is showing, whether it is getting correlated clinically or not. Now, normative database also is the one big issue. Each instrument compares scans with the reference database of the patients without any ocular and systemic disease. Now, these databases are limited in the size with regard to age, ethnicity, optic disc size, and refractive error. The term red disease describes these patients who, despite being healthy, are flagged as abnormal in the OCT printout. So, database is not the very good, robust database for all the machines, depending on their size and depending on their limited numbers. That's what data is fed to the machine, and then machine analyzes the whatever patient's data with that data, and sometimes it can be erroneous also. Now, this is one example which I'll show you. In the right eye, where we see the superior disc hemorrhage and superior thin retinal nerve fiber layer defect. Left eye is showing the inferior retinal nerve fiber layer defect. Same thing we can see on the red picture also, where the disc hemorrhage is seen very clearly in the right eye, and thin retinal nerve fiber layer defect. Left side, it is showing the thin inferior retinal nerve fiber layer defect. Now, once this right eye, which is clinically very definitely glaucomatous, pressures are 25, there is a disc hemorrhage, there is a retinal nerve fiber layer defect. But now, when this right eye gets subjected to OCT, now see the OCT is totally green. Now, this is called the green disease error. That means, despite very well proven clinically glaucoma with high pressures, with disc hemorrhage, with retinal nerve fiber layer defect, this all the analysis still in the green zone. So this is what is called green disease. Means despite the glaucoma, OCT is still in the green zone, and this is likely to get labeled as a normal, despite contrary when this patient has a glaucoma. So this is called green disease artifact, which is also very common because patient compares the database, and whenever patient's RNFL thickness measurements are still in the green zone, this can be still labeled as the green disease. So we have to see the height of the inferior NRR, inferior RNFL, and superior also. Here superior it is appearing slightly blunted, where it is still in the green zone, but it is definitely down from what it was previously. But as it is still in the green zone, machine still labeled it as green and doesn't label it as a glaucoma. So this kind of green disease artifacts are also very common in some of the diseases, some of the optic discs. Now, another artifact that we commonly see is poor signal to noise ratio. This can be because of media opacities. When cataract and dry eyes also are responsible for this. In fact, patient continuously staring at the OCT screen without blink, that can also give rise to poor signal strength. So if patient is having any dry eye, it makes sense to put some artificial tear and again repeat the scan, so you can again have a better signal strength. Now, detecting the progression. For detecting progression, there are mainly two main strategies that exist for detecting progression using OCT, like event analysis and trend analysis. Now, event analysis progression is detected when the difference between the baseline and follow-ups can exceed the predetermined amount, which is usually instruments test retest variability. So whatever is instruments retest variability is there, if the variation is more than that, that is labeled as a progression in this. Trend analysis, where the progression analysis between the given parameter over a period of time. Progression is defined as a significant negative slope of the parameter in the questions. Now, when analyzing an OCT for progression, clinicians should remember that current OCT progression analysis software does not take into account the normal age-related thinning of RNFL and macula. So that is also one thing. cupping doesn't remain stable throughout our life. There is a normal age-related RNFL loss, age-related natural ganglion cell loss. Once that takes speed, that is what is called glaucoma. But then whenever we follow this kind of algorithm for analysis, the machine should also have that kind of algorithm where the normal age-related RNFL thinning also is taken into the account. If it doesn't take into account, then next time it may show the progression. So whatever OCT gives information, we should not jump to immediate conclusion. We should see the whole setting also. If pressures are very well controlled, just because OCT is showing progression, that doesn't mean we go on adding medicines. So ultimately, whole big picture, how things are, how all other tests are showing, how the perimetry is showing the results. So all that is taken into account to draw a conclusion to label this patient as a definitely progressive or not. Now always confirm the suspected progression with the repeat testing and first decide if any statistically significant change is clinically relevant. What is the current target pressure that is achieved, what number of medication patient is on, and whether this, whatever report OCT has shown, whether it really makes sense when the whole clinical picture is taken into account. So this is what are the common pitfalls in the OCT. Do not rely solely on the red, yellow, green color scheme that interpret OCT. Watch for the artifacts, especially acquisition errors or segmentation errors are common and can significantly impact the results of OCT. Remember, there are other conditions that can cause RNFL and ganglion cell loss also. This is one example where the patient has the superior and inferior both RNFL defects, where the inferior RNFL defect was quite prominent on the fundus photo. Here the inferior thickness is now quite getting blunted, but still in the green zone. So this is a very definite glaucoma, but still in the green zone. So this is again a green distal artifact example. So my pulse for OCT analysis is that ensure the image being interpreted is high quality with a well illuminated scan and the optic nerve or fovea centered within the three-dimensional acquisition window, and correlate the OCT finding with the clinical examination and other results. Don't let the clinical examination totally become irrelevant. Know how the things are, what is the ablation pressure, how is the pachymetry, how is the disc, how is the current pressure, what medication pressure are on, and then what you should anticipate from the OCT and whether OCT is showing something similar or it is showing very diagonally opposite. So don't let the clinical examination become irrelevant. Take that into account, and then you can draw the better conclusion out of all the OCT analysis that you are getting. Thank you.
Thank you, Dr. Pankaj Bendre, sir. It was an excellent talk, and we got many inputs of the artifacts in OCT scan. I think now we have a different view about OCT scan. Let's move on to our next session. Can you stop screen sharing, Dr. Pankaj?
Yes, I'll stop.
Yeah. We'll move on to our next session, interesting and challenging cases by Dr. Neha Gaute.
Yes, good afternoon, everyone. First of all, I want to thank POS team and especially to Gitanjali madam for giving me today's opportunity. So let's start with my today's case. I'll just share my screen.
I request speakers to adhere to their time allotted, please.
Just a minute. Just a minute, there is some problem. So, sharing. Application.
Interesting. Application is pulmonary.
Oh, sure. Can you see my screen?
Yes, ma'am.
So
yes, we
just
can
see. Just start with today's case. A 35-year-old male admitted for right congenital varicose veins with infected wound on lateral malleolus in general surgery ward, and he has history of loss of vision in right eye since childhood, and it is totally painless. So on examination, the face of the patient is showing port wine stain on the right side of face, involving both the lids on the right side of face, and left side was normal. And right eye examination, was visual acuity was hand movements close to face, and perception of light was there, but perception of rays was inaccurate. And intraocular pressure was 52 millimeter of mercury on applanation tonometry. Central corneal thickness was 616 microns. On gonioscopy, it showed multiple small pass 360 degree, and megalocornea was there with the 13.2 millimeter diameter. There is scleral thinning also in that eye with diffuse corneal edema, relative afferent pupillary defect, and nystagmus was there in both the eyes. Glaucomatous optic atrophy in right eye. With on fundus examination, actually there is a hazy media, but I could see tortuous veins, and rest of the things appeared normal, and there is no evidence of choroidal hemangioma. So this is the intersegment photograph of right eye and left eye. So right eye was the affected eye, and left eye is completely normal. And the right eye, the clear picture is showing the scleral discoloration over inferior and medial side of the photo, and tortuous conjunctival and episcleral vessels. So here are the other photographs of the patient. Not only the face and the eye was involved, but the limbs of the patient were also involved. So in the first photograph, it is showing varicose veins and limb hypertrophy, which is more on right side of lower limb than the left. And in the second photograph, there is a red to bluish discoloration of the skin of lips, right upper chest and back, as well as the right upper limb. And this is since childhood, and there is a facial hypertrophy on it is more on the right side of face. So this is the video of right eye showing nystagmus, and the left eye also showing nystagmus, and it is more on the extreme gazes actually. So on fundus examination, with I have a fundus photo. Because of nystagmus, it is a little bit blurred. So in right eye, it is showing glaucomatous optic atrophy, but the rest of the fundus is normal. There is no evidence of choroidal hemangioma. In left eye, the fundus picture is like this with 0.3:1 CD ratio, and a healthy neuroretinal rim. Vessels were also normal, and the macula is also normal. Rest is normal in left eye. So what is the diagnosis? So looking at the facial port wine stain and the secondary glaucoma, we all definitely might think about the Sturge-Weber syndrome. Yes, you are right, but it is not completely, because the patient is not having only port wine stain and glaucoma, but the patient is having cutaneous hemangiomas involving the limbs, even right right upper limb and lower limb. Along with the venous varicosities and asymmetric hypertrophy of soft tissue and bones. That is showing the hypertrophy of right face, as well as the asymmetric length and the width of thickness of the right upper limb and lower limb compared to the left side. So actually looking at the Sturge-Weber syndrome, it is a phacomatosis with triad of port-wine nevus on the face, glaucoma, and third is vascular lesion in the ipsilateral brain and meninges, that is leptomeningeal angiomatosis, what we say. So out of this, the first two were present in this patient, but along with that, the other findings which are there, like venous varicosities, cutaneous hemangiomas involving the limbs, and hypertrophy of the tissues and bones, that is the feature of Klippel-Trenaunay syndrome. So here there is overlap of both the findings in these patients, and it is very rare. So if there is overlap of both the things, so diagnosis will be Klippel-Trenaunay Weber syndrome with the secondary glaucoma. So investigations in these conditions, ocular investigations, we have already seen in the previous slides that intraocular pressures, gonioscopy, pachymetry, OCT and fundoscopy. But the systemic investigations what we did in these patients are like this. So except MRI, venogram and venous Doppler, everything was normal. So in venogram, it showed the low flow velocity and hypoplasia of the iliac vein. So all these factors are suggestive of the findings which are correlating with the Klippel-Trenaunay syndrome. So how to manage this case? I have managed this case conservatively, because the patient has loss of vision since childhood, and currently it is painless loss of vision. So I have explained the poor visual prognosis to the patient, and added a eye drop with the combination of the dorzolamide and timolol maleate twice a day in the right eye. But left eye is currently absolutely normal, even the intraocular pressures, corneal thickness, even the cup disc ratio. The optic disc is totally normal, and angles are also open. So I'm just observing the left eye currently, and the patient is managed conservatively for varicose ulcer by general surgeon, and 6 monthly follow-up was advised to the patient. So can we save the vision in early presentation of such patients? So yes, of course, but it is really challenging because ophthalmic management in the Klippel-Trenaunay-Weber syndrome or even in Sturge-Weber syndrome, it is challenging because of early development of glaucoma. It can be because of angle malformation, high episcleral venous pressure, or combination of both, or even there can be a ciliary body angioma which can lead to increased aqueous secretion that can lead to even early development of glaucoma. And second thing is there is poor response to the standard medical treatment. That is what is observed to the with the many the studies which are done, the papers which are presented on such kind of disease. So they are saying there is poor response to standard medical treatment, as well as there is failure rate of the surgical procedure is also more, and the complications of surgical procedures what we do here are choroidal effusion, expulsive hemorrhage, or there can be exudative retinal detachment. So these are the surgical complications commonly seen in such conditions. So glaucoma management and the choroidal hemangioma management, these are the two aspects what we can see here. So in glaucoma management, it depends upon the onset of glaucoma. If it is since birth, it is a congenital glaucoma. In such patients, we can the first line of management is surgical, because the medical management has very poor efficacy, and even in the patients with the ophthalmos as well as corneal opacities, it is not possible. So for surgical management is the first line management. Even in that, the goniotomy or the trabeculotomy alone is not useful, because it will treat only the angle malformation, but the episcleral venous flow, episcleral venous pressure is also raised in such conditions. For that, we need to bypass the episcleral drainage system, and for that we need a trabeculectomy surgery. So the standard treatment for especially for the children and infant is surgical management with trabeculotomy with trabeculectomy. And when the onset of the glaucoma is late onset, likely in childhood or in adolescence, in that case we can start with the first line management as a medical management. In that prostaglandin analogs will be the choice, because it really bypass the trabecular outflow, because it increases reduces the intraocular pressure by increasing the UV scleral outflow. So PG analogs and as well as aqueous suppressants, and in the last the alpha 2 agonist also help in medical management. But the efficacy of the medical management is actually not that good in such cases of where there is the vascular malformations associated because of the increased episcleral venous pressure. So here we need to bypass the episcleral venous drainage system. So the most of the times it is not, medical management is not sufficient. We have to go for surgical management. In that, trabeculectomy, filtering surgery, or wall implant surgeries are preferred. So it helps in few studies. They have mentioned that trabeculectomy also helps, the wall implants helps, but that too for only few years. In next few follow-ups after 6 to 7 years or 10 years, they have seen that it is also failing. So in the next options are cyclocryotherapy and the rehabilitation in case of poor visual prognosis. And the second thing is choroidal hemangioma management is also needed here, because indirectly the choroidal hemangioma causes the vision loss by causing exudative retinal detachment and macular edema. So to treat these conditions, we might need photocoagulation, photodynamic therapy, external beam radiotherapy, brachytherapy, and anti-VEGF agents. So by using these agents and by this kind of management, we reduce the size of tumor, that is choroidal hemangioma. We reduce its size, we reduce the blood flow of that tissue, and indirectly we inhibit the vascular endothelial growth factors. So it will reduce the leakage of the fluid. So indirectly this is a mechanism to treat in such conditions. So to conclude here, we have seen a 35-year-old male who has presented with a varicose ulcer in general surgery ward with a port wine stain on the face on right side only. It is there since birth, and there is reddish to blue discoloration of skin of right side of face, chest on right side, back of right side, upper limb and lower limb even on right side since birth. And along with that, there is varicosity of veins on the right lower limb, and there is right facial and limb hypertrophy. There is right-sided secondary glaucoma with the glaucomatous optic atrophy, as we have seen, and there is loss of vision in that eye, which is painless since childhood. So findings in favor of Klippel-Weber syndrome are here with the right advanced secondary glaucoma. So with the poor visual prognosis in this case, I have managed it conservatively. So at the end, I want to thank you once again to the POS committee for giving me the opportunity.
Thank you, ma'am, for presenting very rare cases. Can I invite Dr. Medha Prabhu to add her inputs?
Yeah, excellent presentation, Neha. It's a very rare case. Almost, I think I remember 1 in 1 lakh or something, the incidence. And it's very rare. Sturge Weber we see very commonly, but this KTW syndrome is very, very rare to see. And obviously, if the patient presents in early life, we can manage this patient. But once there is a very poor prognosis, it's very difficult. You have to just conservatively manage this patient. We have done a few Sturge Weber syndrome initially, like I have done trap plus trap in these patients, and they behave very well. Pressure is under control, and even though we know that episcleral venous pressure is it's there, but trap plus trap definitely helps in these patients. Very few, like maybe just 10% of cases of what I've done trap plus trap, we need to do a secondary wall implant or something. But this is a very rarest of rare cases, and the presentation was really well. Thank you.
Yes, thank you, ma'am. Thank you.
Can I request the next speaker to start the screen share, please? Next speaker. Dr. Zai Kelkar.
Yes, I'm here.
Yes, ma'am, you can screen
share. Should I start? Okay. Okay, so let me thank POS that they're very happy to be with everybody, even though virtually in these difficult times. Heartiest congratulations to Mukesh Parani sir and Gitanjali ma'am for executing this conference so flawlessly. So let me begin with my topic. It's monocular elevation deficiency. So what is monocular elevation deficiency? It is limitation, as you can see in the picture. The patient is not able to elevate his eye in either adduction, abduction, or straight up gaze. Earlier, it used to be called a double elevator palsy, but now that term is a misnomer now, and now it's been replaced by the term monocular elevation deficit, because it encompasses all the cases like isolated superior rectus palsy, inferior rectus restriction, supranuclear lesions, all are covered under the name MED, monocular elevation deficiency. So superior rectus is the main muscle for elevation of the eye, in whether it is adduction, abduction. In presence of a normal superior rectus, the inferior rectus restriction can also cause monocular elevation deficit. Secondary contracture of the inferior rectus due to a primary SR palsy can also lead to MED. So Jampel and Fels have suggested a unilateral supranuclear lesion in pretectal area or inside the third nucleus in some cases. So what are the clinical features? The most important clinical feature or the diagnostic feature is elevation deficit. So the eye is not elevated in either abduction or adduction or straight up. There is ptosis and pseudotosis naturally because superior rectus and levator palpebris superioris have a common origin, and when one is affected, the other also shows less movement. The patient can have both pseudotosis as well as a ptosis. Marcus Gunn jaw winking phenomenon also is seen in up to 25% of cases with the monocular elevation deficit. Other features which can be consistent or inconsistent are Bell's phenomenon, which is usually absent in cases of inferior rectus restriction and superior rectus palsy, but it may be present in cases of MED, which is called by supranuclear defects. So presence of Bell's phenomenon can give you an idea whether it's a supranuclear case that you're dealing with, or is it just a muscular restriction or palsy. Amblyopia will be present if there's a constant deviation of the affected eye, or also because of ptosis. Ptosis will give rise to anisometropia, cylindrical power, and that also has to be looked at. Vertical diplopia may be seen in cases of acquired MAD, and usually it will be absent in congenital cases. There can be an abnormal head posture, which is usually because the patient is not able to elevate the eye and also the ptosis is playing. So what are the types of MADs? There are 3 types. Type 1 includes patients with primarily inferior rectus restriction and fibrosis. They are usually orthotropic in primary gaze and their FDT is positive. Type 2 includes cases with primary superior rectus palsy. The FDT here is negative. And type 3 are the supranuclear types. Here the FDT is negative and it is usually congenital, and it is characterized by an intact or mildly reduced vertical saccadic velocity below the midline, but abnormal or absent velocity above the midline. And the differential diagnosis is first is Brown syndrome. And so the diagnostic feature for Brown is deficient elevation in adduction is Brown's. The elevation will be normal for abduction and upgaze in cases of Brown syndrome, but not so in MAD. There can be vertical Duane syndrome, but that will be pretty rare. Then congenital absence of superior rectus or the inferior oblique often mimics, but are usually associated with craniofacial anomalies. CFEOM, that is congenital fibrosis of the extraocular muscles, also can look like a MAD, but usually they will be bilateral, and there are involvement of other extraocular muscles also, so that will help you distinguish it. And third nerve palsy. Now, third nerve palsy is one diagnosis which is very difficult to differentiate from MAD, but abnormal pupillary reactions or esotropia of the affected eye can be commonly seen. Then you can suspect a third nerve palsy. A palsy of the superior division of the third nerve affecting the SR and the levator is also very difficult to distinguish from MAD. However, the good news is that the management remains the same, so you don't have to worry too much. So management is of course surgical and non-surgical. As I said, look after the refractive error, treat amblyopia, and operate only when surgery is indicated, like when the patient has significant vertical deviation in primary gaze or significant abnormal head posture, there's a deviation induced amblyopia, diplopia in primary gaze, or a restricted binocular fields. Goal of surgery is to improve the position of the affected eye in primary gaze and to increase the binocular field of vision. Sometimes you have to tell the patient that it's no primary gaze only that we are interested in. The eye may not elevate too much, not as much as the other eye, but as long as the patient is not hypotropic and both eyes are ortho in primary, you have achieved your goals of surgery. So this is a very interesting flow chart that I found in DOS times. If you have MAD, first thing that you should do is an FDT. Do an FDT for inferior rectus thickness. Either there is tightness of inferior rectus or there is no tightness of inferior rectus. In short, if there is tight inferior rectus, you have to tackle that. If it is not a tight inferior rectus, then NAPS surgery will be very useful. So NAPS procedure, what do you do in NAPS procedure? I think I'll explain it with the video. So here the FDT is being done. Any kinds of restrictive strabismus, FDT is mandatory. FDT always should be done. It will give you a lot of information and that will help you make important decisions. So this is the medial rectus and the lateral rectus muscles which are isolated and disinserted. And here we have hooked the superior rectus muscle. So we want to get the tendons of lateral rectus and medial rectus near the superior rectus muscle. So the superior rectus which is not working, so the lateral and medial are utilized to help superior rectus elevate the eye. And the beauty of this procedure is that it does not affect the horizontal position in the eye. One important thing that you have to remember is in case there can be some cases where there is inferior rectus restriction plus MAD also where you have to do a NAPS. But you should never try to operate 3 recti muscles at the same time because there can be inferior anterior segment ischemia and that can be a sight threatening problem. Here also be careful that you are not touching the superior rectus fibers. Just get it close to the insertion. That also works very well. You don't have to anchor it to the muscle. You can just anchor it right next to the insertion. So there are a few cases to demonstrate that. So this is how the girl was preoperatively. You can see that the left hypotropia. It is only after you elevate the lid you come to know that it's not just a case of ptosis but a case of MAD. In postoperative, she did very well with NAPS procedure. This is one very interesting boy. He also had the Marcus Gunn jaw winking. He's post-snap. So when his father said Dola, he opens his jaw and the elevation has improved considerably. So what does the literature say about NAPS procedure? That they found that magnitude of vertical correction obtained by NAPS did not correlate with the preoperative magnitude of deviation, regardless of prior performance of inferior rectus recession. Also, Bandopathay, Cooper and Calderia noted that the effect of transposition surgery increases with time, which probably was the cause of overcorrections that are noted on follow-ups. So it is important to know these things because that's how you will be counseling the parents and deciding on the follow-ups of the patient. So though NAPS procedure is a well-established surgery, it is not free from shortcomings. So it has shortcomings like there is no grading, there is a large variability in the amount of correction, and there is a tendency to drift towards overcorrection with time. So Sneer et al. Compared NAPS with augmented NAPS procedure. Augmented NAPS is you put a posterior fixation suture on the horizontal recti, and they concluded augmented NAPS is a surgery of choice because it will give you more predictable results and there is lesser need for resurgeries. Again, there can be cases where you have MED, along with that you have horizontal deviation. One option is that you can do a modified NAPS procedure wherein you divide the muscle into two, the lateral and medial rectus, leave the inferior parts for the recess resect procedure and transpose the superior parts to the superior rectus. Or another option will be do a NAPS in one eye and do the horizontal surgery in the other eye. Literature has found that separating the two, that is doing NAPS in one eye and horizontal procedure in the other eye, gives predictable and better results. So to summarize, MED is a challenging condition, but very interesting. The management of amblyopia often takes a backseat, which should not be overlooked. NAPS procedure is the procedure of choice, and though it should be taken with complete understanding of how it will work for that given patient, treatment is multi-staged and proper counseling of the parents about the outcome is essential. Thank you.
Thank you, Dr. Zai Kedkar. It was an excellent talk. What is your experience in NAPS procedure? How many cases you have done so far?
Till now, I would say we have done about 8 cases of NAPS. Two of them also had associated the Marcus-Gunn jaw winking phenomena. One patient had inferior rectus restriction. The child with inferior rectus restriction somehow did not achieve that outcome, where in cases where there was no inferior rectus restriction. But overall, NAP is a very predictable procedure, and I have no experience of the modified NAPS, but regular NAPS has definitely worked very well.
Okay. Counseling these patients is really difficult, or it's easy?
Counseling these patients is not difficult because once you know what you're set or what you are decided to do, then you can take the parents in confidence. It is not that you see a patient of squint and immediately post them for surgery. There are lot of chair time is essential because parents are very worried because the eye looks cosmetically really disfiguring. They know that they are going to require several procedures. So it is very important that you see the child first, assess the amblyopia, give them time, see them over about say a few months and build their confidence, and then this is the time to operate. But first start with the amblyopia therapy. If the ptosis is not too much, correct the refractive error. All these things have to be taken started first, and all the while keep on counseling that even though we are doing this, after all, surgery is the thing that is going to be needed.
Dr. Jai, this was an excellent result. Yeah. Yeah, it was very nice.
So, Dr. Rushikesh, did you ask me something?
No, I just said that this was
speaker, Dr. Abha.
It's okay.
Dr. Abha Kanade, ma'am, are you there?
Yeah, I'm there. I will start sharing my screen.
Ma'am, you want me to share from here?
Actually, I can from here.
Sure, ma'am. Yeah.
Okay. Yeah. Yeah. Slide. Yeah, I'll start. I'm thankful to Dr. Gitanjali and team for giving me the opportunity. Can you see me? Hello? Hello?
Yes, ma'am, we can hear you, ma'am. Just put the presentation on a full screen mode.
Yeah. Yeah, I have kept it on full screen mode. Is it visible?
Ma'am, on the slideshow.
Hello?
Yeah.
I'm thankful. Yeah, it is. I'm showing the slideshow. Is it visible?
Yes, ma'am.
So, yeah. Actually, the incidence of ESO is more in the areas which are below the equator. And above the equator, the incidence of exo is more. But we should know the ESO deviations because most of the time the treatment is conservative. You give spectacles patching depending on the cause. And the next thing is that the chances of developing amblyopia are more in esotropia as compared to esotropia. It may be associated with the underlying pathology. I've seen one patient with ESO deviation, very smart, hubby child, and she was 9 months old and she had retinoblastoma. So we should know about this. That's why I consider that the strabismus should be considered as sign, so that the patient is patient may be having some refractive error, there may be amblyopia, there may be paralysis of the extraocular muscles and any underlying retinal patching. The etiology or classification of esotropia is difficult in the sense because there are several overlapping factors. So broadly, we can classify into early onset or congenital and acquired. In the early Hello? Hello? Hello?
Yes, ma'am.
हाँ, is it मतलब सुनाई दे रहा है ना मैम?
Yes, ma'am.
हाँ, okay. So you'll find there may be inferior oblique overactions, or sometimes you will find dissociative vertical deviations. Forward. And the next type is the acquired or acquired. You can divide it into two: accommodative types and non-accommodative types. In the accommodative types, there are two types, that is refractive and the non-refractive. These are usually, you will see that you see this video, the patient is given glasses and you can see that, can you see the video? When he wears glasses, the deviation is corrected.
Ma'am, we cannot see the video, ma'am.
Okay.
Ma'am, actually, your screen share has been stopped somehow.
Okay. So can you start screen sharing, Dr. Mukesh?
Yes, ma'am, I will do that, please.
Yeah.
Which slide were you on, ma'am?
Yeah. Next. Yeah, this one. Yeah. So when you see, when he removes the glasses, there is definitely a deviation, and when he wears the glasses, his eyes are straight. That means when you give the refractive error completely with the spectacles, he gets corrected. So he doesn't need surgery. Parents will say that when he removes glasses, there is a deviation. You have to explain them the treatment is glasses only. But in the partially accommodative type, you will see that there is a ESO deviation of the right eye. After wearing glasses, the deviation has reduced, but not fully. So you will need the surgery for this remaining deviation. Now you see this patient, this is non-refractive and high AC by A ratio patient. So when I ask him to, this one, the video, will you please, start the video. See, when I ask him to look into my camera, there is a left ESO deviation. But when I ask him to look far distance, there is his eyes are straight. Okay, so that means this is a patient with high AC upon A ratio. This patient needs, next slide, this patient needs a bifocal. Yeah, you have to start in the lower segment with plus 2.5 or plus 3 in the lower segment. Give executive type, and the lower segment of the executive type should cross at the pupillary margin. You can gradually decrease by plus 0.5 in the next visits, and the patient should be off bifocals by 10 years of age. It is very essential. Next slide. See, in the acquired paralytic type, I have seen only one patient. This patient presented with the right head turn. And when I examined the patient, you just, the next one, this is video, start the video. Next to this, yeah, start the video. Yeah. So when the ocular movements were tested, there was right lateral rectus paresis. Usually, the patients with the refractive errors will also come with the sudden deviation of eyes, but they are not having paralysis of the extraocular muscles. Okay, this patient definitely had an abnormal head posture. He gave me the history of vaccination 4 or 5 days back when he came to me. This is a very 6-7 years back. So even if the patient has refractive error, he will complain of sudden deviation, but it is because of the refractive errors, and this is a type of decompensated. We require a lot of energy to look at, to the straight eyes. When the patient develops fever or anything like that, they get decompensated and they will present to you as a sudden deviation. Now, with this background, when the patient comes to you, first examine the child. Don't waste time in taking the detailed history. You can ask these things later because there is a less attention span of children, especially the non-verbal child. It requires 2-3 visits before you come to a conclusion and the diagnosis in non-verbal child. Next slide, please. So your examination starts with as soon as the child enters in your room. Look for the abnormal head posture and note it down. It may or may not be significant, but you should note it down, the abnormal head posture, because next your all examinations are in the straight head position and the patient may feel difficulty in getting the abnormal head posture. Then first confirm whether it is a true or pseudo deviation. Then find out what is the visual status of the patient. Look for the ocular movements. Find out the cause of deviation and then the management. Next slide. You know, this is what I have taken picture from the Balika Vadhu. When she looks for distance in the center, the eyes are straight, but when she looks sideways, it looks as if there is a deviation. Next. This will be the pseudo deviation. Next slide. Now start video. Pseudo deviation will be confirmed by the cover test. You can see this is a similar type of patient. When she looks sideways, it looks as if she is converging, but actually not. There is no movement on occluding the alternate on cover test. So this is a patient of pseudo, and it is very difficult to convince that they don't have the squint. The next stage is to find out the visual acuity of the patient. You see, in a non-verbal child, you have to find out the CSM. This is a method. That means you have to see the reflex in the cornea, whether it is in the center, whether it is steady, and on binocular movement, whether it is maintained or not. In the middle picture, you can see that the corneal reflex in the right eye is centered and there is left eye iso. Now, in the left side picture, you can see when I close the right eye, the left eye is straight, it is centered, there is a steady, but when we open both the eyes, the patient again takes a fixation with the right eye. That means the vision in the left eye is either poor, or even if it is not poor, it may become poor or go into amblyopia if you don't treat these type of patient. Next slide, please. There is a video. The next. Start video. You can see that the right eye is iso. The right eye is straight, left eye is iso. On covering, The left eye takes a fixation, but when both eyes are open, he again fixates with the right eye. That means the vision in the left eye is poor. You have to explain the parents that your visual acuity, whatever you are taking, is a gross. We want to know whether there is any gross inequality of vision is there, because the patient may be having amblyopia. So our aim is to find out whether there is gross inequality of vision is there or not. The next slide. Next slide. Yeah. Then no. Next, no problem. Next. Yeah. Then you should take the ocular movements. Always take the uniocular as well as binocular movements. You can see in the top, in the center, the patient is having esodavation, but when the patient looks to the right in the extreme left slide, you can see that it looks as if there is a right lateral rectus palsy. Now in the left side picture, when the patient looks to the left, it looks as if there is a left lateral rectus palsy. But when we see the uniocular movements, you will find that there is a full movement of the lateral rectus. So always taste the movements uniocularly as well as binocularly. Otherwise, you will misinterpret that the patient is having lateral rectus palsy. Next slide. Next slide. After this initial examination, you have to use the appropriate cycloplegic to refract the child. I always use Entropion eye ointment below 5 years of age, especially if the patient is having esotropia. If the patient is having exotropia, I use home Entropion. But if the patient is having esotropia and below 5 years of age, I give Entropion, and with the proper instruction that अगर बुखार आया है तो क्रोसिन देना है, एलर्जी आया है तो दवाई बंद करना है, and I give twice a day for 2 days, and third day I call for the refraction. And very important point is that proper instruction, ask the parents not to try the medicine in their own eyes. I have seen 2 parents that they put the medicine in their eyes and they have to use bifocals, they have to use the presbyopic glasses for next 10 days. Nowadays the parents are very this thing. So the next thing is you can do retinoscopy even in a non-verbal child. Show the video. There is a video. Start the video. Yeah. You firmly hold both the legs. Ask one of the parents to firmly hold the hands as well, and ask the parents to open the lids. And you can do refraction. Before that, you ask for any habit of breath holding, because while doing refraction, retinoscopy, the child may cry. So it is better to ask for habit of breath holding, and inform the parent that he will cry, but it is better option than doing it under anesthesia. Next.
Ma'am, can I request you to sum up, please?
Yes.
Yeah. Next. Next slide. Yeah. So the management, the treatment is proper refraction. There is no need to show video if it is not, there is time constraint. Patching in case of amblyopia, bifocals in case of high refractive, high AC by ratio. Frequent follow-up is very important. And in case of surgical treatment, it is, this is post-op. This one, the left side. Sorry, the right side video is of the post-op. Yeah. In case of surgical treatment, it is done for the stable angle. And in case of acquired paralytic cause, wait for the 6 months to 1 year. Next slide. Only 2-3 slides. Next. So carry a message. Once prescribed, check the spectacles. Sometimes the patient will say that, yeah, he's using glasses, but I remember that the patient was given a very high refractive error. I prescribed him +10 and the optician gave him +1. So always check the spectacles. Counseling is very important. Most of the time, the patient with the high hypermetropia, they are not, initial period, they are not good with the glasses. So ask them to, we have to supplement with the cycloplegic under correct esotropia. And there are specific indications for conservative and surgical treatment. Next slide. So always refract. And There are simple methods to know the visual status of normal patient. Even a child below 1 year of age wears glasses. Don't wait till 5 to 6 years of age. This is a very wrong practice to ask them to wait. As I have told you that patient may be having some retinal pathology. Treat amblyopia before taking the patient for surgery, and look for associated condition, I have said. Thank you. Thank you, sir.
Can I request Dr. Prasad sir, so in respect of time, should we proceed with the next session, or do we have small case presentation, sir?
I think still we can just present, because we have just prepared a bouquet of various cases.
Sir.
Just a simple take-home message. Nikhil, can you just do the videos?
Yeah. Mukesh, we just have a few case videos, that's all.
Sure, sir. Sure, sir.
But short on time, we'll just present some take-home messages, that's all.
Excellent, sir. Yeah.
So we don't have a theory talk. Okay. So special cases, challenging cases. Directly we'll move on to this thing. You can see in this. Am I audible clearly?
Yes, yes.
Okay. So in the center picture, you can see that the lady is almost ortho. And as soon as she looks towards the right side, you can see a narrowing of the palpebral fissure of the left eye. And similarly, and of course, with the restriction of abduction of the right eye, plus same thing is repeated on the left side. That is restriction of abduction in the left eye and narrowing of the right eye. So this is a case of DRS, or Duane's retraction syndrome type 3. And we have a small video about the same. So as soon as she looks towards the left, you'll see she's looking towards the left, and there is that narrowing of palpebral fissure in the left eye, and the right eye is not getting abducted. So this is very typical. And plus there is slight widening. Now right eye gets narrowed and the left eye gets widened, and there is restricted abduction. So very typical case of DRS type 3. Now this is a DRS type 2. I'll just show you all a quick video. Don't have time now. So we can see here there is restricted adduction of the left eye out here. The left eye is not coming in totally. So this is a case of DRS type 2. Type 1 is restricted abduction, and he's the same guy after surgery. He had an anomalous head posture, which is now corrected. You can see that he is looking straight ahead. So that is DRS type 2. Now this is another rare case. It's called CFS, or congenital fibrosis of extraocular muscle. So the child will have a constant chin up position, and the eyes are fixed in down gaze and outwards. So this is down and out position in both eyes. So we've taken them, we operated the lateral recti and inferior recti of both eyes and weakened them. Here you can see inferior oblique overactions in both eyes very clearly, almost a grade 3 inferior oblique of the right eye, as well as grade 3 of the left eye. This one is very interesting. You can see the child is almost ortho when she's looking straight ahead. But as soon as now, I don't have the video, unfortunately, couldn't find it. But this is just after we've broken the fusion and with the Spielman's occluder. And you can see that as soon as we've removed the Spielman's of the left eye is up and it is fixed there, because this is our DVD, or hypertropia of the left eye becomes manifest. In the video, you will see the DVD when the eye comes down very slowly. So in that case, you have to weaken the superior rectus of the left eye. Most of the times you have to do a bilateral superior rectus weakening. Now this is again very interesting. You can see an anomalous head posture in this baby out here because of a right inferior oblique overaction. Generally, the head will be tilted towards the same side and face turned towards opposite. As soon as we weakened the inferior oblique of the right eye, the head has become straight. So in which we are going to see this picture, and the child is looking totally straight ahead. In this case, again, you can see a large inferior oblique overaction of the left eye. Now, this is an interesting video. Very quickly, you will see how an upshoot in Duane's retraction syndrome looks like. Just look at the left eye. When the left eye is going to get adducted, there you go. It just gets pulled up. It's beyond the control, and this is because of a very severe the lateral and the medial recti get co-contraction. So both the recti of the left eye are getting contracted at the same time. So it's like a leash effect, and the eye is getting pulled upwards. So it's a very typical upshoot, and it has to be differentiated from inferior oblique overaction. So now this is, this happens to be my favorite topic, nystagmus. You can see that the child has a very constant anomalous head posture with large pendular plus jerky nystagmus. And after surgery, of course, the child has become straight. The nystagmus doesn't get abolished, but the jerky nystagmus in this case is gone, and it is just the basic pendular that remains. This is again another nystagmus. You can see the anomalous head posture. This is a constant left-sided face turn that the child has. And when you make him straight, the nystagmus becomes manifest, because the anomalous head posture is to bring about the null zone and to reduce the nystagmus. After surgery, the child is looking straight ahead. This is absolutely the next day post-operatively. Looking straight ahead, almost nil nystagmus in primary gaze. So it's quite amazing. We'll skip this one. Now this is very quickly I'm going through all of this. The young girl had a partial third nerve paresis of the left eye with pseudotosis, and all we did was operated her for the third nerve palsy, bringing the eye, making it straight, and the ptosis has disappeared. So the message here is differentiate pseudotosis from true ptosis, and it's going to disappear as soon as the left eye becomes, or it comes up into the fixing plane and it takes up fixation. So you can see that, and this is aberrant regeneration, typical to aberrant regeneration of third nerve or partial third nerve. You can see there is a restriction of adduction. The lateral rectus is normal. The inferior rectus will be less, and the elevation. This is another partial third nerve that she gets better after surgery. Now, I think last couple of slides, going quick. Look at the left eye again in this case. Very severe Duane's retraction, and yeah, this is like the eye is totally disappearing. The cornea is just going up. So again, very, very strong upshoot in the left eye. This is the right eye Brown syndrome, congenital Brown syndrome. Look at the right eye, it doesn't get elevated at all. There you go. There's no elevation. So this is Brown's plus, in fact, because there is hypertropia in primary gaze. Again, Browns of the right eye, Browns of the left eye. So this is inferior oblique, again, overactions of grade 2 to 3, right eye and left eye. And these are the post-ops. They're gone after surgeries. Thank you so much.
Just a few comments. So it's a whole bouquet of various. Am I audible?
Yes,
yeah.
sir.
Yes, sir.
Miguel has taken great pains to collect all this video bouquet. So just a few take-home messages, especially the Duane's retraction syndrome. Many times, it goes as 6-nerve palsy. The kids unnecessarily undergo CT scan, thinking them as 6-nerve palsy. So you have to really look for the lid retractions. Various other conditions which I have shown, especially in if it's uncharted territory, nothing can be done about it. But yes, there are some surgeries, there are some treatments with which can give beautiful nystagmus, the inferior. So Nikhil, thanks a lot for preparing a nice bouquet of cases, and these are just a few moments. Anything from your side?
No, that's it. I think you're already over time, so
you just rushed over. So thanks a lot for all the kind attention.
Yeah.
I would like to add one comment. It was very nice cases, and in cases of Duane's and Brown's, one thing is that you have seen that in many of the patients, the eyes were straight, for example, in Duane's, and then they showed limitation of movement. So in Duane's and Brown's, whenever the limitation of movement doesn't correspond with the amount of deviation in the primary gaze, you always think of Duane's and Brown's. You seen the eyes were straight, but it was showing on movement the lateral rectus palsy or something like that. So the amount of deviation was not at all corresponding with the limitation of movements. So think of Duane's and Brown's. Thank you.
Dr. Panjali, can you conclude, please?
Yes, sir. Yes, sir. I would like to conclude the session. Thank you to all the faculties, and thank you to our chairperson, Dr. Meera Prabhudesai and Dr. Prasad Valde, sir. Now, next, I invite Dr. Srinivas Prabhu to take over the session. Thank you so much. Thank you all.
Thank you, Pranjali.
Thank you, Pranjali. Thank you, Gitanjali and POS.
Thank
you. Thank you, Prabhudesai ma'am. Thank you very much. Thank you, everybody. Yeah, it was a very fantastic session on glaucoma and more of strabismus with a very good take-home message from Dr. Prasad and Rishikesh, Abha madam too. Now we head towards oculoplasty session, wherein in fact our co-chairman is already in picture. We will be going for oculoplasty session. Next slide. Yeah. So
I'm also here.
Yeah. So yeah, a small request for all audience as before, privacy protection of patients. Please, no photos or any video. Here is our today's chairman, none other than Dr. Subhash Bijlani, past POS president. Under his presidency, the first POS conference was held in 2008. This is the 13th one. He is a very famous quiz master of POS and MOS. Then today's co-chairman is Dr. Jignesh Bhai Taswala, already a vice president for MOS, previously president POS, member scientific committee MOS. Now I would like to introduce my today's faculties. Dr. Ramesh Murthy, who is a squint surgeon, children's eye specialist, is graduated from AFMC, trained at Arvinda Hospital, Madurai, and then fellowship from LV Prasad and Moorfields, London. He did his FRCS. He has got 129 publications and has presented in 21 countries with total presentation of 750 and 37 awards in medical career. Our next speaker is Dr. Suvarna Gokhale ma'am, MS of TAM, who is an ex-professor and HOD, SK Navle Medical College, Pune, and right now she is a consultant in Shashwat Hospital, Pune. The third speaker is Dr. Pooja Goyal. She's a consultant oculoplastic surgeon. She's head of the Department of Oculoplasty in National Institute of Ophthalmology, Pune. She's an aesthetic surgeon, surgical as well as non-surgical aesthetic management. She's very good at it. Our fourth speaker today is Dr. Adit Gupta. Next slide. Who is an oculofacial plastic and reconstructive surgeon. He's a double fellowship trained board certified ophthalmic plastic surgeon. He has trained extensively in the specialty of ophthalmic plastic surgery and facial aesthetics. He has completed his master's from PGI Chandigarh, and further training he did in LV Prasad Eye Institute and Stein Eye Institute, Los Angeles. Lastly, but not the least, our next speaker, Dr. Sonal Chaugule Yadav now, is a consultant ophthalmic plastic surgeon, orbit and mainly ocular oncologist. She is practicing in HV Desai Eye Hospital. So I now take the opportunity to call upon the first speaker to speak. And here the dais is open for Subhash Bijlani sir and Jignesh Bhai Taswala. Yes, now the show is yours.
Hi, good evening, good afternoon. Let me welcome you all for this excellent session. Actually love this session and this time. There are two reasons for it. Now with the mask on, with all this COVID, the eye is the most important and the only organ which people are seeing. So aesthetics, of course, take primary importance. And second is between 1 and 2, the POS has not arranged any lunch session this time. So this is our lunch time. So guys who are attending this, go get your plates full of your bharleli wangi or paneer tikka or your butter masala chicken, whatever you want. Only thing is when you're eating it, don't slurp very loudly. As Dr. Prabhu just said, we have this excellent list of speakers. So without taking too much time, let's get on to them. And let me invite the first speaker, Prabhu.
Yeah, is Dr. Ramesh Murthy.
Thank you,
please,
sir.
Dr. Ramesh Murthy.
Thank you, sir. Can you hear me, sir?
Welcome, yes, Ramesh. Very nicely we can hear you. All the best, all the faculties. A good morning and a good afternoon to all the faculties. Prabhu and Dr. Subhash Bijlani.
Sir, can you see my screen now, sir?
Yeah, very much.
Sir, first of all, I'd like to thank Prabhu sir, Taswala sir and Bijlani sir for their wonderful introduction and making the audience live and happy. So I'll be talking briefly about entropion and ectropion. I'll just discuss one procedure in each, which we can easily do in our clinics and treat our patients. So we'll talk about lower lid senile entropion and lower lid ectropion. For lower lid senile entropion, my suggestion is that the Jones procedure is one of the finest procedures that we can do because it has 3 actions. It works on the lower lid retractor muscle dehiscence. It creates a scar tissue between the orbicularis, the pretarsal and the preseptal fibers. And it's also having an everting effect on the lids. So let's get on with this particular patient. As you can see here, this patient is having a right eye lower lid entropion. So you can see here that the lid is inturned. So what do we do in this particular case? The first thing we do is to go ahead and give an injection of local anesthetic in the infraorbital nerve region. I'll just see if the video works. Video should work. One moment, sir. I'll just remove the pointer. And the video will work. So we give an injection in the infraorbital nerve region. We have to stick to our time and not one. Yes, sir. Session's time, please. Next, what we do is we pass a lower lid traction suture here, which you can see. This is the lower lid traction suture which we have passed. And then what we do is we take a lower lid crease incision. I hope you can see my video.
Yes.
Yes. So this is a lower lid crease incision about 2 millimeters below the lid margin. Next, what we do is we start separating the tissues. We dissect the orbicularis. You can see here that we're doing a dissection just below the skin. So we're exposing the orbicularis fibers, and eventually we'll cut the orbicularis muscle. Next, what we do is we expose a lower lid retractor. So here you can see the white tissue, the white muscle, a very thin, papery kind of muscle. That is the lower lid retractor. So we've exposed the lower lid retractors. And how do we know it is a lower lid retractor? We ask the patient to look down, and you can feel the pull on the muscle. Next, what we do is we pass a single suture through the skin, the orbicularis on the lower aspect, and then through the edge of the lower lid retractors. You can see it's very clearly, it will be seen. Yes, so we'll mop it for you, very clear now. So you can see through the lower lid retractors and then through the orbicularis and skin to come out from the region of the lashes. And then we tighten the suture to see if there is a good correction of the entropion. We want a slight ectropion on table. So we pass a single suture. The next thing which we do is we pass 3 such sutures, one on either side, so that we can have a good correction of the entire length of the lid margin. So 3 such sutures. Then the sutures are tied. Once we tie the sutures, we have a good correction of the entropion. It has become a slight ectropion on table. The advantage is it's a fast procedure because we are tackling all the problems in one shot and we are not using more than 3 sutures. If you really feel there is a lot of gap, you can always put additional sutures on the skin. Skin sutures, if needed, we can put it. And this is how the result is at the end of the surgery. So the patient is having slight ectropion on table, and we can always call the patient back after 4 to 5 days to see if there is excess amount of ectropion, in which case we can release the sutures and we'll have a good result. So this is my little talk about entropion. For ectropion, I'll talk about lateral tarsal strip. Now these are very good procedures. Here you can see there's a lot of lower lid laxity in this particular patient, and the lid is actually turning outside. So what do we do in this particular case? We have given a lower lid block. We remove a segment of the tissue from lid, lower lid margin. We fashion a small strip of the tarsal, which you can see here clearly. And then we are going to tighten the lid by securing it to the periosteum. So here we have exposed the periorbital superolaterally. So we go ahead and we go above the region of the lateral canthus, and then we expose the periorbita. Next, what we do is we pass the fixation suture through this lateral edge of the tarsus and through the periosteum or the periorbita in the superotemporal region. And then we see what is the correction, whether it is giving good tightness. We want quite a good amount of tightening at the initial time, so that we have over time it's going to become lax, and then we have a very good correction over the years. So here we've used 50 bond. You can also use proline sutures. So first what we have done is we have tied a temporary knot to understand what is happening. So this is a temporary knot that we have tied. We find that the correction is good, and then we can make it a permanent knot. Now the thing is, you'll have excess amount of skin here. So you don't want to have a dog here, and therefore you'll go ahead and you're going to trim this extra amount of skin. See, this is a fold of skin that way, like a triangle it is. So we cut off this particular portion of the skin, and this will give a very good cosmetic outcome. So this is how the patient looks. He had severe ectropion on before, and now after surgery he's having a tight lower lid with no ectropion. And here you can see that this is the excess skin which has been cut. So this is a patient before, and this is a patient after surgery. So this is the procedure of the lateral tarsal strip procedure for lower lid ectropion. So my choice of procedure for lower lid senile entropion is Jones procedure, and for lower lid ectropion is lateral tarsal strip. I thank you once again for your patient hearing. So any questions you may ask?
Excellent. Excellent, Ramesh. Very, very nice. You hit a sixer. आते छक्का मार दिया यार. बहुत बढ़िया. In the initial stages, if I remember, earlier when we did not have subspecialty, this was a very common procedure to be done by the general ophthalmologist. You have taught it so nicely in that 10 minutes. I think any other general ophthalmologist or newcomer will be able to perform great surgeries in such a short time. No wonder you are an international faculty, Ramesh. Badhiya sixer maar diya. Thank you very much. Subhash, for your comments.
Ramesh. Hi, Ramesh. This is your presentations are very good as always. You know, there was a slight problem maybe with the videos, so you could post it on the POS a little later on the general group so that we see it a little more detailed and at comfort. Please do that later on. Tell me one thing. In this COVID, since we just talk about ocular aesthetics and the eye is the most visible organ, and this is addressed to all other panelists. How has been the response of the patients? Has it been more, less, or same, or there's no difference? I mean, forget about else. Ocular aesthetics.
Sir, it's very interesting. A lot of my squint patients have come and undergone surgery because they find that because they're sitting at home or they have a lot of time at hand, they want to undergo squint surgery. So when the marriage time comes, they'll be all ready for marriage. So that is a very interesting development.
Wow, great going.
Even with ptosis also, sir, even they have kind of done it. Initially, there was a lot of hesitation, like first few months, like April, May, June, July, August. And by the end of the year, things started improving, and now they're all keen on getting it done, so they can use the lockdown or the prolonged work from home effect.
Lovely. You're helping them get married better. Okay, Prabhu, back to you.
Yeah.
Thank you.
Hereupon now I invite Dr. Swarna Gokhale, ma'am, and would like to ask her also the same question as Ramesh said, whether ptosis operations also have increased. So she will be talking on management of congenital ptosis with Marcus Gunn winking phenomenon. Please, ma'am.
Is she back? Is she back in India or she's still in the US?
Yeah, she is very much back in India.
Am I audible?
Yeah.
Yes,
Dr. You are very much audible.
Yeah. We can see you on your screen.
We can see your screen also.
Yeah. Put it on the slideshow mode.
Please go ahead.
Swarna, put it on.
Okay,
yeah,
thank you. Thank you, Srinivas, for giving me this opportunity. My experience is also same because people are more aware about their cosmetic appearance rather than applying cosmetics over the face. So, today my topic of discussion is management of congenital ptosis with Marcus-Gunn jaw-winking syndrome. This is basically a congenital cranial disinnervation disorder. We have come across with the 4 cases, and the one which is not there, the video is not there, was a very small child of 8 months old, and he had only jaw winking at the time of sucking. So we could not take the video. The first video is showing he has a bilateral ptosis. Right eye also he has ptosis and left eye also, but left eye only jaw winking was present with left eye. The second case, having a more elevation and depression of the upper lid in right eye with chewing movement, not with the side-by-side movement. So basically, there occurs a coordinated synkinetic movement of the upper lid and the jaw as a result of an abnormal connection between the motor branches of trigeminal nerve and superior division of oculomotor nerve. The movement can be triggered by chewing suction, lateral mandibular movement, smiling, Valsalva maneuver, sternomastoid muscle contraction, tongue protrusion, and even breathing. Among all congenital ptosis cases, the incidence is very low, 2% to 13%, but incidentally we came across with the 5 cases within last 10 years. So in our series, left eye patients were 2 patients having left eye ptosis and right eye were involvement in 3 cases. Usually males are more affected than female, but in our series, we got 4 male patients and 1 female patient. How to go about the evaluation and correction of the jaw-winking phenomenon? So visual acuity is must because it is important to rule out amblyopia in infants and again anisometropia. Cycloplegic refraction mainly to rule out any anisometropia. Then we are going to see detailed examination about the extraocular motility test, cover test, and functions of the superior rectus, and to rule out any elevator palsy if it is present. You should be aware about the Bell's phenomenon if it is present, if it is decreased, and if there is any double elevator palsy. It is very crucial from management point of view. Then presence of lid lag and how much it is present, because in post-op presentation of the cases, if there is more lid lag, then the parents are more concerned about the lid lag. And presence of dry eye is to be checked because the child may be having dry eye. Then there will be a corneal decompensation post-operatively. Detailed pupillary examination and fundus evaluation is necessary. This is a case with unilateral right eye, Marcus Gunn jaw-winking phenomenon. She has got severe ptosis, and you can see if there is a contraction of the ipsilateral pterygoid muscle, then there is lid elevation. The importance is if the patient is looking down, while doing evaluation of the patient, if the patient is looking down, the lid movement is more as compared if the patient is looking in the center or in upward gaze. So the examination of the lid position during each gaze is very much important to calculate the amount of resection or to plan the surgical management. Then it may be associated with chin lifting for better vision. So again, if the chin lifting is there, then the patient's gaze is down. So your amount of calculation may go wrong. So you should calculate the amount of ptosis. Well, the patient is having centrally head in center position and the jaw in closed position. Because if the patient opens jaw, then again the ptotic lid goes up. So your calculation may be wrong. So these are the few points which should be kept in mind. Then we consider it as a mild ptosis when it is less than it is up to 2 millimeter, moderate if it is up to 3 millimeter, and severe if it is more than at least 4 millimeter. So to calculate or to evaluate the ptosis, we should check for the margin reflex distance, which is measured with eyes in primary gaze position. MRD1 is a corneal reflex to the central upper lid margin distance. So it should be measured with the jaw closed and patient looking in the center. This is to assess the amount of ptosis present. And MRD2 is a distance between the corneal reflex to the lower lid margin. It is significant in cases of hypotropia, like in this case. In case of double elevator palsy, MRD3 is again important. It is to be measured from distance of corneal reflex to the central upper lid margin when the patient looks in extreme up gaze. Then evaluation of levator function is to be done. It is a distance in the upper lid which travels from down gaze to up gaze, with frontalis muscle is held firmly at the brow region. Normally, it is about 15 millimeter. We call it as a good when it is 12 to 14 millimeter, and accordingly we should grade the levator function. The grading of the jaw winking is extremely important, because if it is mild, then you may not go for surgical management of the case. The amount of jaw winking is the excursion of the upper lid in millimeter with the opening of the mouth. Then we can grade it as a mild, moderate, and severe depending upon the grade of a jaw winking. We have to rule out with certain systemic diseases from management point of view, like presence of cleft lip, cleft palate, or any other disturbances, charge syndrome, renal calculi, and ECG is very much important because these patients are predisposed to cardiac arrhythmias. Coming to the management, non-surgical management includes the patient needs aggressive treatment for amblyopia, occlusion, correction of anisometropia. Before planning surgical treatment, you should consult patient parents, because preoperative and postoperative lid lag may be there. Postoperative lid lag, corneal exposure, these are the some few minus points of this surgical management of the patient. The jaw winking phenomena is considered cosmetically significant only if the jaw winking is more than 2 millimeter. So if the jaw winking is cosmetically insignificant, or if the ptosis is mild, it is advisable not to proceed with surgery. If a correction is desired in mild ptosis, then procedure of choice includes Pasnella Servat procedure, or you can go for standard LPS resection. Then presence of amblyopia and vertical strabismus are the indications for surgery. If there is moderate to severe ptosis with or without levator muscle dysfunction, then also you can go for surgical management. If a correction is desired in mild ptosis, then procedure of choice is Pasnella Servat. If the ptosis is moderate to severe, then resection of LPS with bilateral frontalis suspensions may be indicated. So unilateral levator excision on the affected side combined with bilateral frontalis suspension. Some prefer going for unilateral LPS resection and combined with bilateral frontalis suspension. This leaves a normal functioning of the levator muscle and elevate the normal eyelid in the primary position. In severe ptosis, a super maximum more than 30 millimeter levator resection with frontalis suspension is necessary. So in this patient had severe ptosis and she had very poor LPS function. Along with that, she had right eye hypotropia with superior rectus palsy.
Yeah,
so
Dr.
we planned surgery.
We are having some time constraint, so just
okay. It's
next internet. Yeah.
So we have done a NAPS procedure, and followed by after 1 year, we went ahead with the LPS resection, extended LPS resection. She was not ready for frontalis sling surgery for the other eye. So we thought that because she had a slight hypotropia even after NAPS procedure, so we thought of doing only LPS resection, and the results are very good. These are the relative contraindications for the surgery, and these are the complications which are routine for the routine squint surgery, ptosis surgery. So this was a pre-op movement of the patient, upper lid movement, and this was the post-op upper lid movement of the patient. Thank you.
Thank you, Dr. Subhash Bijlani. Any inputs from your side?
Thank you, Dr. Sona Bukle. You made a difficult topic seem very, very easy. Diagnosis and the management and how to go about it with the rush about the complications. It was an excellent presentation. Hats off to you. Our next speaker is Dr. Pooja Goyal, but she has a talk of ocular trauma. I think she can speak for 2 hours to go on and on. Ocular trauma is such a massive subject, or the whole day maybe. But unfortunately, Pooja, Dr. Srinivasan is going to give you only 10 minutes. Dr. Srini?
Yeah. Sorry, because of time constraint. I would have loved to hear it for a day also. So we should speak only
Dr.
about
Suvarna ma'am, you can stop the screen share first.
Okay.
She will talk on only trauma in children, ocular trauma in children, management of ocular trauma in children.
Yeah, good afternoon, everyone. Am I audible?
Very much.
Absolutely.
Yeah. So to cut short, even the ocular trauma in children, I will be talking about the oculoplasty extraocular trauma in children. So still smaller.
Huge. Pooja, I think your screen is stuck.
Yes.
Yeah, now it's done.
Yeah. Now we can see.
Okay. Yeah. So the spectrum of pediatric ocular trauma is very huge, as we just said, right from birth injuries to chemical injury and burns to unexpected child abuse. So starting with sharp injuries, most commonly the one which we see is the one in infants which are caused while feeding by the mother's jacket hook. And it usually leads to such kind of a canalicular injury involving the proximal part of the canaliculus. Now the crux is to identify such injuries and to suture them as early as possible, so that the canaliculus can be identified and it is not yet scarred and retracted. So we can identify and intubate them with a stent and suture it around the canaliculus. If sutured early, they give very good results, and the patency is also established of the canaliculus. Later on, when they come for follow-up after 2 or 3 months, we can do a dye disappearance check test and check for the patency of these canaliculus. So this shows a monocanalicular stent in situ with the surrounding suturing which is done. We use an absorbable suture so that we don't have need suture removal in children. Now this is a child who had an upper lid injury with upper canaliculus injury which was repaired, and we see that the contour is very well maintained and the dye is practically not seen in the eye. This is something that I have been practicing over the last 2-3 years, is advising lactating mothers to strip their blouses with a small micropore tape. It's very cheap and effective way, and it can save very such kind of canalicular injuries. Now this is a patient who, along with a lacerated wound, also shows some yellowish prolapse. This is the orbital fat. So if you see anything like this, it indicates that the orbital septum has been breached. And when the septum is breached, there are 2 things to be done. One is to identify that it is violated, and 2 is to not go ahead and repair it. If we repair the orbital septum, try to suture it, we will have a lot of lid retractions as complications in the post-op period. So just push the fat back as much as possible in the orbit. If it is necrosed, excise it, but don't try to fish the septum and repair it. The next sector of injuries is burns, which are very common in the pediatric, especially the infant and toddlers, is burns with flames and chemicals and oils and spillage of all kind of beverages. Also, maybe explosions of cylinders and flash burns, electric burns, firecracker injuries are very common in our part of the country. Usually the eye is spared in these cases because of the protective reflex mechanism of the eye, and you will see huge, large area burns on the face and periocular region. Now, the thing is that they might look very scary, but most of them are very superficial wounds, like the first degree burns, which involve only the epithelium is brushed off. Second degree, as you see around the eye, where some part of the subcutaneous tissue is also necrosed and lost. And deeper injuries, third degree, are usually not seen around, where you have a lot of fat loss and deeper injury as well. So, if as soon as these patients walk in, one is to profusely wash them with saline, a lot of wound toileting. Locally, we need to debride these wounds as much as possible so that the scar tissue forms evenly on the surface and we don't have any secondary infections happening. Eye per se, you have to examine the eye, rule out any ocular injury. But even if there is no ocular injury, it is a good practice to give cycloplegics and antibiotics, eye drops in these children. Long-term associations, when we look for, is definitely skin contractures and loss of periocular tissue and eyebrows and eyelashes. Now, this is a child with a firecracker injury of the upper eyelid. It was a first-degree skin burn. So only the epithelium was abraded. We see there is few loss of eyebrows over here. But as it has healed up, you see there are these tufts of epithelium which are growing up, and this skin will heal in 3 or 4 weeks of time. In the early phase, it is important to give skin emollients and like Vaseline and antibiotic ointments. But as 2 weeks, 3 weeks pass by, the skin heals up completely. We have to start with scar massage and sometimes silicone gel sheet application so that this scar forms evenly and it doesn't start contracting. Now, these are the epithelial buds that I was talking about. These are signs of healing and recovery. And it is a good way to check for early formation of lid ectropion. If you have burns of the lower lid, we can just ask the child to open the mouth and look for any pull or traction, if at all, on the lower lid. So that is the earliest sign that we can pick up that the ectropion has started to form. Now, this person had developed already ectropion because of early chemical injury, which was repaired with a small patch graft of skin graft taken from the post-auricular region, and then he is doing well. There is no medial lag of thalmos, and there is the punctum gets opposed to the. Now, this child had a domestic cylinder exposure. There's a lot of soot and tar accumulated on the face. Looks very scary, but takes a lot of patience to clean all these wounds and get to the depth of actual injury and grading it into first degree, second degree, third degree burns and look for ocular injury. Stain the cornea, look for corneal abrasion or defects. Now, this has to be done regularly, maybe by you or your staff, but this debridement and cleaning has to be done on a regular basis to avoid secondary infections and contractures. This is a Pandora's box, blunt trauma. Children complain, report of maybe a trivial fall at home to road traffic accidents. Presents as a wide spectrum of lid ecchymosis, subconjunctival hemorrhage, orbital hemorrhage, subperiosteal hematoma, traumatic optic nerve injury, to orbital fractures, to orbital apex fractures, to skull-based fractures. It is a wide spectrum. So it is very important to stick to the protocol and evaluate, and always palpate for the periocular rim for any tenderness, or if there is any step deformity. Check for check the vision, check the extraocular movements in each and every patient, no matter how normal the globe might look like. Because you see this child now, he looks fairly fine, the eye is white, everything. But if you just look in ortho position, we will notice that the right eye is hypo compared to the left eye. Means there is definitely something which is there in the orbit which is displacing the globe downwards. This is a child. Similarly, we see if we draw a line, this globe is looking hypo. Other than that, we see only there is that some abrasions are present and the eye is completely white. Now, when we look extraocular movements, we will see that all the elevation, dextro-levo elevations are restricted. Go ahead and do an X-ray and a CT scan. We notice that there is an inferior floor fracture with entrapment of the inferior rectus muscle. Now, this is very important for us to pick up when the patients report to us. The eye might look white, but it might have an orbital fracture along with it. So the fractures will be repaired later with all kinds of implants and release of the entrapment muscle. But it is very important for us to pick up these patients and diagnose them early. Now, this is a child with bilateral ecchymosis called as panda eyes, which is very classical for a skull-based fracture. Next spectrum involves animal bites. So identify the animal, the circumstance, whether it was a pet animal in a spontaneous or a provoked, vaccinated, non-vaccinated animal. very important is to again clean thoroughly toilet all these wounds, and wound closure along with the now these are dog bites. We advise to infiltrate the anti-rabies vaccine into the wound also while closing them, and also give them intramuscularly as well. Local infiltration helps a lot.
1 minute remaining, Dr. Pooja.
Last 2 slides. Child abuse is a very neglected spectrum in our very busy practice, but it is good to have a suspicion when these children report late to our clinics, when they don't have a proper history and the history that they give does not coordinate with the examination that we are doing, whether they have cigarette marks, burns on the body, or bite marks. So there is a wide spectrum, and more you are suspicious about it, there is a possibility that you might pick them up, and even if you have the slightest suspicion, it is worth reporting them to the police or child protective services. So the approach to a patient is very challenging. It is important for us to remain calm and focused in all the chaos of the attenders and the cranky pediatric patient. Be gentle and polite with the parents or the attenders. Explain them the situation, and do not allow too many attenders in the clinic, as we all are hearing about the situations these days. Documentation is very important. Like you are in a hurry, you miss writing the history in detail, vision is not recorded for the other eye, which is normal. So, or the date is not mentioned, the time of patient entering into the clinic is not mentioned. So, make it a point to complete all your records in place during the patient visit itself. So in conclusion, being aware of the spectrum of trauma the children can present with is important. Not all the cases are going to be textbook scenarios. So it is important to have a holistic approach in dealing with the child as well as dealing with the attenders. Documentation is critical and important of medical legal importance, and always seek support of other specialties early than late in such kind of patients. Thank you very much.
Excellent tips, Pooja. Fantastic, especially the medical legal part regarding the child abuse and all. Very nicely covered. And I think every ophthalmologist should make a note of all this. One question about Pooja is the discoloration around the skin post-trauma. What do you advise for such, especially the marriageable age group girls who are having that?
So discoloration in the periocular skin is all.
Yeah, periocular skin.
It's usually because of the, in context of trauma, it is.
Yeah, in context of trauma.
It's usually because of the capillary bleeds and the ecchymosis which is there. It resolves in it reduces quite a big extent in 1 or 2 weeks after the trauma. But we can give some vitamin C supplements which helps in faster absorption of the blood and the blood products. So
any local ointment?
Thank you, Dr. Pooja, for that nice reply. Sorry to interrupt, Dr. Taswala. Our next session is international webinar session, and our guest faculty, Professor Minas from Australia, has already joined. Professor Minas, we welcome you on behalf of Pune Ophthalmological Society.
Do I invite interesting person Adit Gupta to talk on some interesting cases?
Yes.
Yes, Dr. Adit Gupta.
We have till 2 o'clock. We have till 2 o'clock. Adit,
yeah,
you're there with your interesting cases. Please come on.
Thank you. I'm sorry, it's taking a little bit of time to work out the technology.
Hello. Is my screen visible?
Yeah.
Okay. Yes. So I'll just be very quick with this. I thank POS and Dr. Gitanjali Sharma Madam for giving me this opportunity. What I'm going to do is try and show 3 or 4 interesting case scenarios which we might encounter rarely in our practice. If I'm extending beyond my time, you can stop me. I can stop at 2 or 3 scenarios as well. So we begin with this case. A young lady walks into my clinic with these bilateral white patches on the upper eyelid. This lady has been referred by a dermatologist who was taking care of her for vitiligo. Now, this is a straightforward clinical diagnosis, eyelid vitiligo. Now, till now, we would not do anything about this, but as we go ahead and advance in science, we can do a mini punch graft, which is autologous, using a 1 millimeter punch, and take a recipient area from the patient's own skin, anywhere around the thigh, the inner arms, or wherever it is concealed. And these grafts can then be stuck on by removing a split thickness skin from the upper eyelid and transposition there itself with the help of glue. Now, this is 2 weeks after the surgery. You can see how well the grafts survive, although there is an intermittent lucid area, but slowly that area starts filling up. After 2 to 3 weeks after the surgery, you have to start these patients on narrowband UVB therapy so that the pigmentation starts getting faster and the host melanocyte starts getting activated. This is the result 8 months after the surgery, which is a fairly decent result, although there are some intermittent areas of whiteness which can be taken care of with a subsequent procedure if the patient desires, but you almost get an 80 to 90% improvement as compared to the pre-op photo. So split thickness mini punch graft surgery is a good option for eyelid vitiligo cases who are stabilized with treatment and are not progressive. Coming to the second case scenario, let's dive into the orbit. As ophthalmologists, we very frequently encounter orbital tumors. Now look at this patient who has an orbital tumor right at the apex of the orbit. The optic nerve is very close to the tumor, and this is the cavernous sinus. Now I had been referred a patient like this by Dr. Subhash Bijlani sir itself, and these are complicated cases to deal with. Now this lady was a professor, had a vision which was deteriorating. She had an early RAPD, and her vision had dropped down to 612. So she was an intelligent patient, so she could pick all these changes before. Now, how to deal with these cases? Either you refer them to a neurosurgeon who can do a very extensive surgery and still end up with no vision. Observation if the vision is, or you can do stereotactic radiotherapy. Now, stereotactic radiotherapy had been tried in this patient with no response. And so we had to think about a surgical approach, either to decompress the lesion or to refer it to a neurosurgeon. Now, neurosurgeons would do an extensive surgery and expose the tumor by doing a craniotomy. But nowadays, with endoscopic approaches, we can approach these tumors. What we did in this case was an endoscopic lateral orbitotomy, wherein we opened up the lateral orbital rim through a small eyelid crease incision as seen here. And this is the endoscopic view of the tumor. This is the rim which I have removed. And then after that, I put the endoscope along with 2 or 3 instruments inside. With the help of a high-speed mechanized drill, I'm drilling the bones so as to get more area for exposure, because this area is very small. You cannot manipulate too many things here. You can cause pressure on the optic nerve. So this is the bone which has been done. Now this is the periorbita which I'm incising with a cataract knife. To be innovative in this area with your instruments, with the crescent you get very precise cut, and after the periorbita has been excised, you will see that the intraconal fat and the lateral rectus muscle comes into view. Once the lateral rectus muscle comes into view, with blunt manipulation you expose the tumor. So this is the tumor. Here you can see the third cranial nerve branch which is there, and slowly with rocking and rolling movement and with suture traction you remove the tumor successfully. Now this patient, luckily for us, had a good vision after surgery, but sometimes this surgery can also go wrong. Now this is the second. Coming to the third case, if you look at this lady, if she walks into your clinic, you might pass her off as a xanthelasma in a busy clinic. Now she was referred to us after 2-3 doctors had already treated her as a xanthelasma with lasers and different steroid injections, but with no response. Now what is different apart from xanthelasma in this is the fullness of the upper eyelid, the ptosis which has happened, and the bulkiness of the lesions. Now these lesions were also firm, rubbery and palpable, and so you have to think about something else. Now this is actually a clinical diagnosis. If you see this case once, you will never forget it. But on imaging, you see that the whole area of the anterior orbit, even the lacrimal glands have been infiltrated. You can see how they light up on contrast view. The lacrimal glands on bilateral sides along with the whole anterior orbit is infiltrated with the tumor. So we did an incision biopsy, and exactly as we had suspected, it turned out to be an adult onset xanthogranuloma. Now these are very commonly associated with asthma, so this is one medical history that you need to rule out. There are 4 types of xanthogranulomatous diseases in the orbit, of which the last 2 types, that is the necrobiotic and Erdheim-Chester disease, are very fatal, and that is why you need to know these diseases and get a biopsy done. Now our patient had adult onset xanthogranuloma with asthma, so the treatment options for these diseases include long-term immunosuppression or local injections of steroids. What we did was we did serial injections of triamcinolone acetonide, which we use as a subtenon's injection in ophthalmic practice, around 40 milligram per ml per session, distributed at the following points, and the intraocular pressure was checked. Now, with these injections, you can see that there is reduction in fullness. Her eyes have opened up, the ptosis has reduced. And at the final follow-up visit, you can see only the skin portion of the lesion is left, which can be later dealt on with a blepharoplasty surgery. And you can give very good outcomes by medically managing these patients. Coming to the last case, which I would like to stress upon, especially in our busy clinics, we tend to neglect these cases. This lady was referred as a case of bile ptosis on the left-hand side, along with a little bit of asymmetry. When I examined her, I did notice like a 1 millimeter ptosis, which was bothering her because in this era of selfie mania, women come to us even with 1 millimeter ptosis. What I noticed in addition was that you can see that her lower eyelid is a little bulging and she has a 1 millimeter proptosis. Now, she had a family history of thyroid eye disease in her parents. And so I advised her to do a TSH, T3 and T4 along with an imaging because I was suspecting something else. Now, this was just before lockdown. So this patient got lost to follow-up and returned to me this year after a year. And now what she had encountered was she was having a little bit of diplopia along with restriction of movements in all gazes. Now, obviously, she needs to undergo an imaging and see what the imaging reveals. It reveals a big tumor at the apex of the orbit extending into the cavernous sinus and causing backflow problems because of which she had the proptosis. Now, this was a meningioma which now needs to be taken care of by a neurosurgeon. So such small subtle signs, especially if picked up by an ophthalmologist at the right time, can diagnose these conditions earlier and can have good prognosis, especially if referred in a timely basis. So don't neglect a small ptosis, don't neglect a minor proptosis because these can be wolf in the sheep's clothing. I end my talk with these cases, although there are a lot of cases which can be discussed, but it should be we should respect time, and that's why if any doubts, I'll be able to answer them personally or at a later time.
Very nice.
Thank you, Adit. Thank you. You speed it up very well, and thank you for rescuing us from the shortage of time. With Srini's permission, we can go to the last speaker, who's Sonal Chaugale Yadav now.
Yeah. Yeah. We invite Dr. Sonal Chaugale Yadav. Please come. She'll be talking on oncology.
She has a short series.
Prabhu. Yeah, am I audible well?
Very much.
Yes, very well.
All right. So after hearing from eminent speakers, so like this pretty flower of valley, we all hope that our patients have something treatable, reversible, and something that doesn't threaten their eye, vision, or life. However, like these examples of toxic flowers, and especially flowers like this, which also can be carnivorous, we have to be aware of situations which masquerade as a common disease or a harmless situation, but are in turn harmful for the eye of the patient as well as the life of the patient. So I'm just going to present a very short series of 3 cases, but with a very important take-home message. All right, so we're going to talk about a few of the interesting cases in ocular oncology. So this gentleman was a 65-year-old male who presented to us with this mass, which he has been roaming around with for past 3 weeks, having been to a physician and was being treated as in case of an eyelid abscess, was tried a couple of combinations of antibiotics, even IV antibiotics were tried, with keeping the probable diagnosis of eyelid abscess in mind. However, he sought consult because he was not getting relieved of any of his symptoms. So as seen here, the lesion we could see was a little hard and indurated mass, which was sitting in his eyelid area, extending up to his eyebrows. On a worm's view, we did not see any much of a proptosis. However, the lesion was significant. It was a firm, slightly tender, fairly defined lesions with surface induration without adherence to the underlying periosteum. Extraocular movements were restricted in elevation without significant presence of proptosis. His rest of the anterior segment and posterior examination was unremarkable. Prompt CT scan revealed hyperdense, fairly defined lesion sitting in that particular area without much of orbital extent. So we went ahead with a layered incision biopsy, which showed presence of acinar cells with the possibility of adenocarcinoma of probable secondary origin. This prompted a series of investigations to look for the primary source of malignancy. We went ahead with a whole body PET CT scan and some serum markers. So the PET CT scan showed obvious activity in the orbital lesion. The tail of the pancreas had a huge mass sitting on it, with metastasis to liver, lung, para-aortic and mediastinal lymph nodes, thus making the patient the adenocarcinoma of the tail of the pancreas stage 4, or as we can commonly known as metastatic adenocarcinoma. So he was promptly referred to a medical oncologist who started him on a combination of chemotherapy of carboplatin plus capecitabine. After 14 cycles of chemotherapy, around 8 months of follow-up, he showed good regression in his primary lesion. The orbital lesion showed complete regression, and most of his metastatic sites were doing well. He followed up with us and underwent cataract surgery for the same eye at a later date. And now at a follow-up of 30 months, he is alive with regressed primary disease under a constant follow-up. So I'm proud to say this case was recently published in the Journal of Ophthalmoplastic and Reconstructive Surgery by our team. So the eyelid lesion here was a daunting presenting sign of a hidden pancreatic adenocarcinoma. Pancreatic adenocarcinoma per se, if they happen in the head and body of pancreas, can produce the symptoms really early because of obstructive jaundice. However, here the cancer started in the tail of the pancreas, which made the primary symptoms hide in the patient's body for long, and the metastatic tumor showed its presence. Moving on. This is a 22-year-old girl who presented to us with a history of gradual protrusion and displacement of her right globe, along with a lot of tender areas around her eye as well as right-sided forehead. On detailed history evaluation, she had a prior history of right-sided surgery done via a neurosurgery approach, a pretracheal approach, around 3 years back. The histopathology report that she carried gave description of a pleomorphic adenoma. Looking at a current picture, that was doubted to start with as well. On going ahead with the detailed clinical evaluation, she did have severe proptosis as well as inferior dystropia, extraocular movement restriction. Her vision had dropped down to counting finger 2 meters, with partial optic disc pallor had already set in, and a very classic presentation of right-sided forehead paresthesias was also noted. CT scan evaluation showed a fairly defined mass in the superior quadrant extending almost to the apex, widening the supraorbital fissure. This was almost the extent at the sagittal scan. So with an intent of taking an incision biopsy and or possible debulking of this lesion, I went ahead with a sublateral orbitotomy. Or arrowhead points at the already found bony destruction made by the tumor in the superolateral orbital rim. This was the size of the tumor which was excised. We could excise the tumor almost in toto en bloc along with the adherent periosteum. And as expected, the histopathology revealed presence of a poorly differentiated adenoid cystic carcinoma of lacrimal gland. Incidentally, I could also revive the prior biopsy blocks from the original neurosurgeon, and we got them reviewed as well. The prior specimen also did show signs of adenoid cystic carcinoma of lacrimal gland. So this was possibly a case of missed diagnosis, probably from the pathology side or the perseverance of the surgeon's side. She is not still completely out of danger though. She needs a complete body scan to rule out any present metastasis, adjuvant radiotherapy to her right orbit, and adjuvant chemotherapy to make sure she has minimal recurrences and minimal residual disease and is out of danger from systemic metastasis. Adenocystic carcinoma of lacrimal gland are quite aggressive in their nature in terms of distant metastasis and as well as threatening the life prognosis. So she needs close monitoring for checking her local, regional, as well as distant metastasis. Moving on. This is another case of a 70-year-old male who came to us with history of multiple prior consultations of being prior diagnosed as a left-sided chronic blepharoconjunctivitis. He had been taken a variety of treatments, antibiotic steroid ointments, as prolonged oral doxycycline, prolonged azithromycin treatment. however, without relief. So this was a slit lamp picture in the lower half of the slide. We could see a lot of things happening there, thickened eyelid margin. Yeah. So thickened posterior eyelid margin, as well as loss of eyelashes, loss of good architecture of eyelid margin, as well as marginal telangiectasia. So he was taken up for a prompt conjunctival map biopsy. This is how the map of a conjunctival biopsy looks, to take small bits of tissues from the conjunctiva as well as margin of tarsus to check for the histopathology diagnosis. And as suspected, this turned out to be a pagetoid spread of sebaceous gland carcinoma of his eyelid, involving almost 50% and a little bit of more than 50% of his ocular surface. So treat management options for such widely spread pagetoid spread sebaceous carcinoma of the eyelid are a little challenging. There are anecdotal cases of use of topical mitomycin C to control the disease. And other option which includes is subtotal anterior exenteration to get rid of the carcinoma and to prevent the further spread into locoregional metastasis. So he also underwent a whole body PET CT scan, ruling out other site metastasis. He is now scheduled for an anterior subtotal exenteration of orbit. He would need adjuvant therapy as needed. And same as other patients, he will also need continuous monitoring for any of his locoregional or distal metastasis. Thus, I would bring this together.
Last minute for you.
Last slide. Yeah, my last slide. All right. So these were the presumed diagnosis the patients were being treated on and follow up as. However, on a detailed evaluation and a histopathological diagnosis, the first case turned out to be a metastatic carcinoma of adenocarcinoma, pancreatic adenocarcinoma, the adenoid cystic carcinoma of lacrimal gland as in the second case, and the third came out to be a pagetoid spread of sebaceous gland carcinoma. So I would leave you all with this take-home message that ocular and orbital malignancies can masquerade as commoner benign pathologies. It is very important to identify the telltale signs to avoid missing the accurate diagnosis and delay in further treatment. The histopathology still remains the gold standard tool for most of the eye cancers. An appropriate index of suspicion is required from all of our part for a timely diagnosis and optimal management of such situations. I thank you for your patient listening. I thank POS for this opportunity to present at this forum. And I hope I stuck to the time limit.
Dr. Sonal, excellent presentation and a real eye-opener of cases, very unique cases, and how you have to go about it and come to a valid diagnosis. So also Aditya has also given a fantastic picture. Whatever 3 cases he could present, fantastic. A big thank you to the POS for allowing us to chair. Dr. Subhash Vidani to chair and me to co-chair, and Dr. Srini to moderate the session. Thank you very much.
Thank you, Sonal. This is a wonderful presentation. Just one small little point that whenever, and this applies to all of us, whenever you're giving a standard line of treatment to a patient that you suspect of something and he's not responding within the allotted time period of plus or minus 20% of the days or whatever you have a strong suspicion that it could be something else. Like she showed the 3 cases, they turned out to be malignancies. So if it is not responding, think of something else. Thank you, guys. Thank you.
Yeah, here I would like to conclude the session on oculoplasty, thanking Dr. Subhash, Dr. Jignesh Bhai, and all the eminent speakers who spoke so well. And let us head towards the session on international speakers, giving it to Dr. Santosh Bhide and Dr. Sangeeta Wah.
Yeah, good afternoon, everybody. I think Dr. Gitanjali would like to say a few words before we start the session. Our president of POS. Yeah.
Yes. Hello, everyone. I, Dr. Gitanjali Sharma, president of Pune Ophthalmological Society, welcome you all for this special session of international webinar session in our conference POS Spectrum 2020-21. I feel really fortunate today. It's a great moment. Best of East and best of West. We are having best and greatest eye surgeon as faculty for our conference. It's my pleasure and privilege to welcome Professor Minas from Australia. Namaste, sir. Dr. Michael Burden from United Kingdom. Dr. Neil Bressler from USA. Professor Chi from Singapore. And Dr. Archana Kulkarni from UK. On behalf of Pune Ophthalmological Society, I am grateful to all of them. The time zone is different. It's early morning in UK, it's around late evening in Australia and Singapore. So it is not so convenient for them to join, but still they have accepted our invitation and they are here. So on behalf of Pune Ophthalmological Society, I thank them all. May I now request my colleague, Dr. Sangeeta Wagh, to say a few words. Dr. Sangeeta, please.
It gives me immense pleasure to introduce Professor Minhas Coroneo. We are indeed humbled, sir, for you having accepted our invitation. Professor Minhas is the chairman of ophthalmology at the University of New South Wales, Sydney. The amount he has contributed to the science of ophthalmology is immense. And that's why I'm going to go beyond these 5 points that I mentioned. He started his interest in medicine, even though his father wanted him to pursue a career in engineering, because he was inspired by a doctor in his town who saved lives. He traveled to Germany, where under the tutelage of Professor Wiederhold, who is actually a scientist, but also an ophthalmologist, he switched to ophthalmology. He returned to Australia to make paradigm shifts and changes in the eye care. He's been awarded one of the highest awards, the Order of Australia, for the work that he has done, the outreach to the community in the eye care. The foresight he has had. In the 90s, he brought telemedicine to Australia. He's an innovator and a scientist. He has pioneered the use of trypan blue, for which we are also grateful, without which I cannot imagine doing a cataract surgery. He spearheaded the development of the bionic eye. And besides that, the scientist and engineer that he is, he has innovated devices, the drainage device, suprachoroidal, intraocular lenses to come over photopsia, amongst some of the very few innovations. And besides this, he goes beyond that, where he has co-authored a book, The Feast for the Eyes, in which he brings to us the Mediterranean cuisine that helps in prevention of blindness and aging. And in fact, today we look forward, while we are in the peak, the second peak of COVID in the city of Pune, Professor Minhas, we have this indistinguished honor of topping the list amongst all the cities in the incidence of the infection. And you have innovative treatments as well as diagnosis, and we look forward to listening to you. Thank you so much. As a personal note, I thank you on behalf of Pune Ophthalmological Society for having accepted our invitation. Professor, thank you.
Thank you for the very kind introduction. I'll just try and get my presentation up. Can you hear me?
Yes, sir.
Very clearly,
Yeah.
yes.
Okay, great. Okay, So thank you for the very kind invitation to present at your meeting. I'm going to speak on COVID-19, a different view. I have two declarations to make. One is that I had nothing to do with the naming of the virus. And two, I will have an interest in some of the matters that I discuss here. So it turns out that the pandemic wasn't as bad in Africa as people thought it would be. And this is a man called Bobby Wine, who's a politician and a musician. And so the message, the public health message, reggae, that's one way of getting the message across. In the last year, we've published 2 papers on this subject. More recently in Lancet Microbe about the SARS-CoV-2, that eye protection might be the missing key. And earlier, a paper in the ocular surface, the eye is the discrete, in both senses, or 2 senses of the word, but defensible portal of coronavirus infection. In the next 20 minutes or so, I will try to summarize what we've come up with here. So we've come to realize that God has not just a hand, but also an elbow, which is used in several ways. And so how can it be that an RNA particle has crippled humanity? There's no solution to date. And whether vaccines work or not, protection is still going to remain a priority. It has seemed as if this has been unstoppable. If you look at the top panel, the deaths, and the bottom panel, new cases, there's a recent dip. But it's really like an express train. And now we're in a situation where we're almost completely relying on a vaccine to work. But then how many people need to be vaccinated before transmission starts to drop? This is uncharted territory. This journey started for me at the end of the Hawaiian Eye meeting in January of 2020. And I was there with my staff, and I've been going for many years, and I had a very nice time, and I was planning a vacation in Hawaii. And then I woke up on the morning of the 28th of January, and this image was in the newspapers and everywhere. And it's a man in Hong Kong preparing to catch a train to somewhere in China. And you can tell from looking at him that he had been through this before. And you can see that not only is he wearing a respirator, but also goggles. And I wrote on the CareNet group, I suspect we're at the start of another saga. I just had a bad feeling about this. And one of our colleagues in Northern Italy said that ophthalmologists were working in intensive care units because the situation was so dire. So the early evidence of ocular transmission was in fact from Wuhan, where Li Wenliang caught the virus and died, and he was the whistleblower. And in the literature, Dr. Wang, a respiratory physician, also caught the virus, and it was documented that he had a mask but no eye protection. So we really are at risk. This is a survey from the US looking at the risk according to profession, and we are 13th on the list of those at risk. And one reason is that the slit lamp is the cornerstone of our practice. We are literally about 30 centimeters from the patient's face. And this lesson had learnt before, but ignored. This is a slit lamp from 1919, so from the era of the Spanish flu epidemic. And you can see in outline here is where the shield was. And I've spoken to people from the major contact lens slit lamp companies, and they essentially, this history has been lost. So one advance is we've made these bigger in modern times, but then it gets in the way and you can't easily get to the eye. So from a sense of self-preservation, I said to myself, shields probably don't work all that well, do something. And so this is from Mark Manus, a video from...
A little drop of some yellow dye in there, okay? If I can just get you to look up to the ceiling. Excellent. Okay, and if you just pop your chin onto the rest, head against the bar. That's good. Yeah, that was absolutely fine. This is what it's good for
Professor, we can't hear you.
Sorry, is that any better? Is that any better? Hello?
Yes, it's better now.
Sorry. Okay, so here I've taken this device, which was made by Tool Meditech, and attached it to a slit lamp, and if I blow smoke, it goes all the way across the slit lamp to the other side. And here, if I turn the fan on, you can see that the smoke, in fact, is dispensed inferiorly. So there's still quite a lot of controversy around how the virus is transmitted, whether it's aerosol or droplet. and how much contact transmission occurs. And it's surprising after a year that this is still being debated. So when I got back to Sydney, the first thing I did was I put a filter system in the air conditioning for my office. These were in short supply because we'd had bushfires. My staff were trained. They did all the conventional things of masks, gowns, gloves, goggles. We made up chloroquine phosphate eye drops, which we used on days that we were consulting, and I'll come back to that at the end of the talk. However, all the mitigation paradigms that have been tried have in some way failed. We've used social distancing, we've used masks, but the thing that's worked in Australia mainly has been quarantine and isolation, and we have been very lightly touched by this virus. So what are we missing in general here? So my lessons from 2020 are, the first is that respiratory viruses, including SARS-CoV-2, are oculotropic. They head for the eye. And so because the virus infects the lungs, does not necessarily mean that it gets there by breathing it in through via the nose and mouth. It seems obvious to say that to ophthalmologists, but that lesson has yet to be learned. The next thing is that the virus sticks to the tears and to the ocular surface. Both the virus and the tears are lipophilic. There are electrostatic charges involved, with the virus being positively charged overall and the ocular surface being negatively charged. And there are relevant receptors on the surface of the eye, which I'll come to later. We're all familiar with this drainage pathway, so I won't dwell on that. The second lesson is that the eyes are big. If you actually calculate the surface area of the eyelids, conjunctiva, eyelashes, and eyebrows, in fact, you get a number that's 2 orders of magnitude greater than the nose and mouth. And so the probability of a virus landing somewhere on the face is more likely to land somewhere near the eyes. And because of this muscle, the viral particles can then be attracted properly into the tear film. This is a droplet which can be, with a virus as small as 1 micron. A human hair is 60 to 120 microns in diameter, which begs the question as to how many viruses can dance on the head of a pin. We are familiar with this pathway, but the relations are interesting, particularly in those patients that secondary to coronavirus develop other infections such as mucormycosis. Now, the virus, when it lands on the tear film, can be there because of the turnover time for around 5 minutes. The virus then gets to the nasopharynx, where it incubates prior to spreading to the lungs, gut, and bloodstream. So it's a little bit like, for Star Wars fans, the Death Star. This is like Achilles' port, and you call this scene where port. The virus can remain aloft for 16 hours, which is quite frightening, and it reminds me a little of dandelion seeds. If you look at some of these, they can really stay stationary in the air for quite long periods of time, and there's underlying aerodynamic science to support that. The next lesson has to do with the human natural convective boundary layer flow. So the body emits heat, and so this rises goes up to 2 to 3 centimeters from the body. And this, of course, involves the face and the eyes. And we're not really all that aware as to how well we're protecting our eyes in this situation. So the key information in this is a paper from US Army Captain Kenneth Fuller Maxey, written in 1919. He was motivated by the fact that the influenza epidemic killed more American soldiers and sailors than weapons in World War I. He said that the eye has received little or no attention as means in the transmission of acute respiratory infection. He proved this concept and discussed the lacrimatory nasal pathway, and he used Bacillus prodigiosus, or Serratia marcescens, as a marker. And he was then, you imagine the ethics committee application for this. He used human volunteers and he exposed them to atomized bacterial spray at 4 feet, and he could recover virus from the nose and nasopharynx even when masks that covered both the nose and mouth were worn. Now, this paper has been ignored for just over 100 years. He pointed out that during the Great Plague epidemics, that these masks and suits were worn as early as 1619, And each of these masks had a large beak in which they put scented herbs and so on to protect against the stench of death. And all of them had these little eyeglasses and so they realized that the eyes were vulnerable in this situation. This meant that the plague doctors didn't see so well, so they carried a stick to both prod corpses and to tap their way around in these environments. This type of protection is called brute force barrier protection. And if you look at the current setup with compared to the 17th century, apart from changes in the materials, there has been really no progress. And in the 1500s, this book on contagion and contagious diseases tells us exactly what we know now. These are rapidly multiplying small things that infect us one of three ways: direct contact, carriers, and through the air. This is now not moving. Okay. So in this paper, I described how unexpectedly the eye is playing a central role in this epidemic. Many of the key research people are agnostic of ocular tropism and SARS-CoV-2, and this pathway may be key in preventing and treating this pandemic infection. All of you that have worn face masks know some of the problems with them, and their efficacy has in fact been questioned. I won't go into this in any detail for now, but issues include discomfort, become hot, wet, difficult to speak through and to breathe, and if you have skin conditions, they're often made worse. Goggles and face shields often fog. You can self-contaminate from taking these things on and off, and they don't necessarily reduce spontaneous face touching. Since the virus is airborne, my idea was to fight air with air based on my slit lamp experience. So using ultra-clean laminar airflow, we've been able to reduce infection in surgery, and personal air freshening devices with ionizers are available everywhere. So I decided to try and mount this on a hat. Now, down in the bottom right-hand corner, if you come to Australia, you see people wearing these hats with corks. That's because they drink too much and there are many flies, and this is quite a good thing. But a high-tech version involves having air coming out of the hat to basically stop air coming that's viral laden to reaching this critical area of the face. It has to be carefully engineered because if it's too close, it will cause a drying effect and so on. And it's aimed at reducing viral aerosols and convection flow. So I got some hats, and I got some anesthetic tubing, and I made holes in the tubing, and I connected it to a fan. And so in the top panel, the fan is off, and again, the smoke will hit face. And in the bottom panel, if I turn the fan on, the smoke doesn't get anywhere near the face. So this prototype has now HEPA filters installed. These fans are very cheap. They've been made for keeping computers cool and so on. And the cost is around $15. Now, with spectacles, there's inadequate coverage and fogging. So a way around this is to make a spectacle frame that has tubing which is perforated. And again, you will see when I turn the fan on, it stops air getting in from the side and from the front. So ionizers can be virucidal. In a bacteriophage model, they kill 99% of aerosol virus. They haven't been all that well tested so far for SARS-CoV that I know about. But this could be added to this system. And then hand touching of the face is very common and an ingrained behavior. And whether we like it or not, we touch our eyes, nose, mouth each 3 to 4 times per hour on average. And so this increases risk of contamination. So this device could have a movement detector to warn us that our hand is approaching our face. So if you know about Achilles, he was dipped in the river Styx. His heel was covered by his mother's hand, but the blink reflex meant that his eyes did also not receive protection. And so this is an Achilles eye phenomenon, not unlike the Star Wars scenario. Now, somewhat late in the piece, Dr. Fauci
I mean, if you really perfect protection of your mucosal surfaces, just for your audience, Ken, as you know, we all know, you have mucosa in the nose, mucosa in the mouth, but you also have mucosa in the eye. And that's one of the things that, you know, theoretically, you should protect all the mucosal surfaces. So if you have goggles or an eye shield, you should use it. I mean, it's not universally recommended, but if you really want to be complete, you should probably use it if you can.
which is rather ironic that people are everywhere, and so ideally, you know, and he doesn't really get into an appreciation of the surface areas issues and the difficulty in carrying out that protection, as I've discussed. So current personal protection is not designed for prolonged wear and is suboptimal. We know about the brute force approach. I've described a personal laminar flow device with features that will repel and kill the virus, and a warning system to warn against hand contamination. And it's taken literally centuries to get to this point. Here are some other devices that are around. Invariably, they're large and expensive and obviously still being developed. In the meantime, wear your spectacles. This is in a study in JMA ophthalmology, admittedly a small study. It appears that it reduces your risk of infection approximately 5-fold. These are preliminary findings, but if you wear glasses, you have natural protection. I'd like to finish up with a discussion about why certain drugs don't work. So apart from the politicization of these drugs, there are some other issues. So plaquenil, azithromycin, and zinc have been used in combination in some of the trials. And you need to understand about how cells have an apical and basolateral surface separated by tight junctions. And further, that the receptors for the virus, ACE2 and other proteases, are on the apex, and the virus invades the cell, replicates, and leaves by the basolateral membranes. So if you apply eye drops or a spray topically, you can do something with where the virus gets in. If you give these drugs systemically or by tablets, they access via the bloodstream and are really reaching the basolateral side of the cell. Drugs like hydroxychloroquine are mostly acting on something they have to do with the ACE2 receptors and the apex of the cell. So in the way that this has evolved, there's been some confusion about this, lack of understanding. So SARS-CoV-2 binds to the ACE2 receptors. These are on the apex, and if the drugs that work on these receptors don't reach the receptor, then that's what happens when we take them orally. To work, drugs must be applied topically. And we, in fact, have started to get resources to do a trial on this, and so far we've not been able to get very far with it. Now, because there are receptors on the cornea and the conjunctiva, people have wondered whether the virus gets in through the conjunctiva and cornea. This is from an COVID-19 epicenter in New York City, Amelia Schreier's group, and they reported in the Academy meeting last year, virtual meeting, 3 eyes of 3 patients with gelatinous corneal melts, perforation, and endophthalmitis. All of these patients were likely to have had a deficient tear film, allowing the virus to bind directly onto the corneal epithelium. One patient had keratoconus, another rheumatoid arthritis that had end-stage renal failure. So in a diagram, this just shows that if the tear film is intact, the virus doesn't hit it. If it gets onto the surface of the cell, a critical thing is that both the virus and the receptor are internalized, and ACE2 happens to have a protective effect on these cells, and when it is knocked out by internalization, it activates matrix metalloproteinases 2 and 9, and this causes disruption of the cell and inflammation and eventually melt. At least that's a schema by which we explain this. These drugs, hydroxychloroquine, azithromycin, and zinc, have been used safely in the eye topically for years and years. Now, the problem is many of the drugs were screened in vitro, and we know that in vitro does not equal in vivo results. And so that's how some of these drugs became used, were used rather systemically. So topical treatment with eye drops or a spray has the advantage of reaching the place where the virus gets in, and they're likely to be safer and cost effective. Vaccination is not going to work from past experience just with by using a vaccine. It will also involve any future treatments are going to also involve contact tracing, and that was learnt in the eradication of smallpox, which was achieved by universal immunization and exhaustive contact tracing. In my opinion, by neglecting the eye, our scientific leadership has dropped the ball at great cost to humanity, and the universal neglect of ophthalmology teaching has come home to roost. Many people have no idea about the eye and its functions. So just to finish with Bobby. Here's one virus saying to the other, what an amazing year, and the other virus saying best ever. I had an amazing year, and so far have lived to tell the tale. Thank you.
Thank you, Professor. That was, I'm really amazed at the innovations, how many ideas you've actually put into effect. And my question is, how do you manage to so quickly implement a thought, an idea into actual practice?
I've done it before.
It's amazing.
I've always liked to do things, and from childhood my father had a workshop that I had access to. And you know, your country is famous for innovation. And in many ways, some of these things can be proven, well, at least a start made with relatively few resources. And in a university system, in some situations, you learn to be frugal.
Wonderful. You also have some eye drops in the pipeline for prevention of SARS-CoV-19, is what we read in some of your reviews. Would you have anything to share on that?
Well, so we really need to get a clinical trial done, and I wanted to start with hydroxychloroquine. And, you know, it's a matter of proving this as a principle. And a number of other drugs, I mean, there are several other agents. I mean, ivermectin, for example, has been used clinically, and some, has been discussed as to how effective it is. There are problems with systemic administration with these big clinical trials. It has been difficult to prove efficacy. I think topical and ivermectin too has been, many of these drugs have been safe when used topically on the eye. So there is very little risk to the patient. And if they work, and this is early in the disease, right at the start before the nasopharynx is completely colonized, none of this will work once the virus has invaded your body. I mean, once the incubation has occurred in the nasopharynx, then it becomes very difficult to manage the situation. So we were proposing this as a very early treatment. And so until such time as we can get to prove or disprove this as a concept, you know, I think a good place to start is with drugs like hydroxychloroquine, which has been shown to work in vitro.
What would your advice be on the use of betadine? We've all been using a lot of diluted betadine, either as goggles. We make our patients do betadine goggles before taking them in the AR, and there are a lot of reports on the use of betadine nasal drops and eye drops as well?
Yeah.
In the prophylaxis and prevention?
Yeah, sure. This sort of tactic was tried during the influenza epidemic in the United States in 1919. And back then, they didn't do clinical trials like we do now, but there were reports. My concern about this approach is what effect the betadine has on the microbiome, the normal bacteria, because there are relationships between bacteria and viruses. And if you wipe out at the same time, not just the virus, but the other bacteria, then maybe you could make things worse. And there are reports from some of the army bases in the United States from 1919, and this is largely unpublished data. They're in reports that I've been able to dig up suggesting that it made matters worse. Now, I don't know what your experience has been, and I'm certainly not saying this with any great certainty, but you know, if you're going to do this, I think it should have been done in a clinical trial, and if it hasn't been, then that would be a good idea. You'd want to know what was going on. I personally wouldn't use betadine on myself.
Well, and there's been talks about methylene blue being consumed in dilutions, and we really, I mean, some of these could be really toxic. And any word of caution for?
Sure, and I would be careful about that. I mean, I know in your country, chloroquine phosphate is used for dry eye. At least there are reports of its use in dry eye. And the thing about chloroquine and hydroxychloroquine is that very likely it is more specific, that it's doing something to where the virus attaches to the cell. Now, sure, if you take it systemically, it can have a whole lot of side effects, but topically, I used chloroquine phosphate in my own eyes for some months when this started. And I don't think I've suffered any ill effects.
That's amazing. In fact, we have one of our ophthalmologists, Dr. Rajiv Raut, who has patented the chloroquine eye drops in the country. And maybe we should all look into it and use it at least next couple of months.
Well, again, it needs to be part of a trial. We had great difficulty getting it set up here. And now it's going to be really difficult because we have very few cases. The only cases that we're seeing are those that come in and are in quarantine. So there's virtually no community transmission in Australia at the moment. I'd be delighted if someone could, and I'd be happy to advise if I could or help in any way, if someone had the resources to do a small pilot study on using one of the chloroquines in this setting. And I think I would start with that rather than with betadine.
Thank you.
Thank you.
Kesh, can I say something?
Yes, sir, please.
We have two eminent speakers from United. We heard the views about Australia. We have speakers from United Kingdom. It will be very nice to have views of Mr. Mike Burden or Ms. Archana Kulkarni about what they are doing in the United Kingdom, because the spectrum differs from country to country. Has something significantly changed in the way they see patients in the OPD or in the theaters? And are there any practical tips that they would like to give, which all ophthalmologists would be able to use even in non-institutional setups like private clinics, which are most common in India? I would request Mr. Mike Burden or Dr. Archana to please comment on what have you changed in 2021 to protect the patients and yourself from COVID-19.
May I request Professor to stop the screen share so that it all can be seen on a single screen?
Thank you, Professor. Thank you.
May I request Professor to stop the screen share?
Yes, of course. I'm trying to find where it is.
On the top side. It will be there in the red.
Stop. Yeah, I've done that now. Yeah.
Thank you so much.
We can have an opinion from Professor Chi from Singapore National Eye Center. On the
hello. Yeah. Just like in Australia, we have no community cases
or maybe just one. So in fact, we feel very safe, and many of us, although we have the vaccine available to us, we are thinking a few times before taking it. Yeah. But, you know, definitely at the slit lamp, we have got a screen there to protect us. And this we did very, very early on. We are all 100% masked all the time, except when we're eating. And yeah, hand rub is very important. And of course, we avoid touching our face consciously. Yeah.
I think from our point of view in the UK, especially since I'm working with children, again, it's the screen with the handheld slit lamp as well as the main slit lamp. We have a screen for the indirect as well as gloves, lots of wiping. So our clinic times actually take longer because half the time you're wiping the chairs and the slit lamp. But so far, luckily, you know, I've been tested maybe 5 times over the past year, and it's always come back as negative. So we're obviously doing something right.
We have strong immunity.
Mr. Michael Burdensome would like to add something.
Yes, very happy. The COVID protection I was heavily involved with at the beginning, because at the time it all emerged, I was president of our college, and there was a huge debate about what was appropriate PPE, what procedures we should do. At the start, we had no idea how long this pandemic was going to last. And essentially, we first of all protected ourselves and our patients by literally restricting the number of patients we saw to just the people who would go blind or at risk of going blind within a few weeks. So it was mainly retinal detachment surgery, age-rated macular degeneration with appropriate PPE. And I can't tell you how much debate there was about whether FFP3 masks should be available to all ophthalmologists or not. It caused considerable concern. I think what's also happened now is this realization that we're going to have to somehow live with COVID, at least for the next year or so. I would think at least, probably long term if the new variants continue to emerge, and we're probably ending up. We're probably going to end up. Sorry.
May I request Dr. Jivan Ladi to mute the mic, please?
Okay. I think we're going to end up having a situation similar to the flu, where we will probably end up having a different vaccine every year if we're not careful. So I think whatever we do, we've got to realize that we have to adjust to provide the service. In the UK, I personally am not happy to simply say that cataract surgery is routine and therefore can wait. In the UK, the average age of cataract surgery is 76. Our life expectancy is 82. And we do need to get back to as good a service as we can. The one downside we have as ophthalmologists is, unlike a lot of our colleagues in neurology or other specialties, we do actually have to see our patients. And that is why, as has already been said, we are at risk. But I think we have tried to protect ourselves with a combination of PPE. We ask patients when they come to theatre to self-isolate for a week. We are well ahead, I think, of most of the rest of the world in vaccination. I've actually had both my jabs now. Whether that means I'm now immune, I don't know. But we're doing our best.
Thank you.
I request, with the permission of Chair, can we proceed with the next talk? I request all the panelists, other than the speakers, to have their microphone on the mute mode for the smooth conduct.
Our next speaker is Professor Chi from Singapore. At the outset, on behalf of Pune Ophthalmological Society, I would like to thank Professor Chi for accepting our invitation, and I welcome you on this international webinar. Professor Chi is a distinguished professor of clinical education in ophthalmology at Duke National University of Singapore, and she is professor at National University of Singapore. She is a senior consultant in ocular inflammation, cataract, and comprehensive ophthalmology at Singapore National Eye Center. She has keen interest in research in complicated cataracts. and she has invented many instruments and techniques for complicated cataract surgery. She has authored more than 200 peer-reviewed papers, and she has written many chapters in books. She is on the editorial board of prestigious journals like JCRS. She has received a Best Teacher Award by Singapore National Eye Center. Her videos are so excellent, and she's a great teacher, and we all are really looking forward to talk by Professor Chi.
So thank you very much for inviting me, Santosh, to participate, and also want to thank the Pune Ophthalmological Society for this great honor. So let's start. Okay. So I'll be speaking on pearls in managing subluxated cataracts and my financial disclosures with no relevance to my talk today. So the first pearl I want to share with you is that it's always important to examine the patient both upright as well as supine. You can see a patient here. When the patient's upright, the patient's got excellent vision, 20/30, and when the patient starts to tilt the head back, you can see this lens going backwards into the vitreous cavity. And at the operating table, this is the same eye, all right? You don't see the lens, and you don't want to be caught off guard. So you want to always examine the patient in a supine position in the clinic. Ultrasound biomicroscopy is a very useful tool when you have a patient whom you suspect to have lens subluxation, because firstly, when this test is done, the patient is actually in the supine position. So the images are captured with the lens actually in the supine, the eye patient in supine positions. Secondly, it also tells you the location of zonulisis, which is often not completely apparent because it's hidden by the iris. And in addition, if you have a good technician to help you, you can also tell the extent of zonular loss, whether it is partial or it's complete. So in a case like this, you can see this is partial loss. This is a lens that's dangling backwards into the vitreous cavity. In a case like here, you can see there's vitreous in the anterior chamber and there are no zonules in this area, and another area of complete zonular loss, but no vitreous. So should we be using iris or capsular hooks? To me, I generally prefer to use capsular hooks because they support the equator. And if you do not have this available to you in your operating theater, then what you could use is iris hooks to support the capsular rim with a capsular tension ring to support the equator, or you could use 2 iris hooks to support 2 capsular tension segments without a capsular tension ring. Now, if you have iris hooks, they are also useful, and I use this to provide counter traction during capsulorhexis in a case where the zonules are missing. So which capsular tension device should we be using? This really depends on the extent of zonulisis, the strength of the remaining zonules there to provide support, and the disease, whether it is progressive or static. And generally for progressive disease, you want to provide adequate support, assuming that this patient is young, that you want to provide at least 2 points of support. So I generally use the 4 clock hour rule, and we mix and match devices as necessary. So if you have 4 or less clock hours of support, then you can just insert a capsular tension ring. Now, if you have 4 to 8 clock hours of missing zonules, then you need at least 1 point of fixation, and you can choose from the devices here. Now, if you have more than 8 clock hours of zonulisis, generally you would need 2 points of fixation. So when do we insert a capsular tension ring? For a case of mild zonulisis, you should insert it late. And if it's severe, I would recommend that you insert it early. The reason is because the capsular tension ring expands the equator, keeps back the vitreous, and also prevents the anterior chamber fluid from misdirection into the retrolental space. So how do we do it? We inject dispersive viscoelastic just under the anterior capsule here all around, and then we insert the capsular tension ring into the subcapsular space, and this avoids trapping of cortex. Well, when you suture the Sioni eyelid to the sclera, I generally prefer to use a Hoffman pocket to a scleral flap, although this is also possible. And what you can do is then mark first of all. Generally, I use 1.75 mm posterior to the limbus, and then I use a mini crescent and dissect at least half scleral thickness. This is important because you want the suture to be buried, and you dissect backwards beyond this point that you have marked, and then you retrieve your sutures from your capsular tension device, through full thickness of the sclera, you retrieve it from the pocket, and then you tie the knot. Always remembering to tie a little tighter because the knot will settle 1.75 mm back from the limbus. What suture should we use? It should be permanent, and today I would recommend the use of Gore-Tex 7O, which is also known as CV8. This has got excellent longevity, and although many are using polypropylene 9O, there are reports here that you can look up that this may not last something like 5 to 6 years. And definitely we want to avoid 10O polypropylene because definitely this hydrolyzes in 5 to 7 years. So if you do have a suture like Gore-Tex, which has got a needle, is rather short and thick and really inappropriate for ophthalmic use, how do we make use of this suture in the eye? So you first preload it onto the capsular tension device. Now, if you think, well, if I had a lasso like this, I could just lasso this end of the suture. It would be easy for you to use in the eye when you place the parts of the eye together. And when you pull this lasso, you will then get the suture across. And this is exactly what we puncture the needle with this suture snare through the full thickness sclera at the desired fixation point and extend the lasso to bring the suture to the fixation point. And you can look this up in BJO 2018. So let me show you the steps. It's important to keep the suture dry. It's very important, I should repeat, because if you don't, the suture, although it's 7O, will become limp and you cannot direct it into this 27 gauge needle. I used to use 26, today I use 27 gauge needle. Second tip is to cut the suture on a slant so that it's pointed and it goes very smoothly through the needle, and you then retrieve it at the other end and you capture the end with the 1 cc syringe, and you bend this at an angle of 45 degrees. And when you use it, you enter the sclera full thickness 1.75 mm posterior to the limbus after having created a Hoffman pocket. And very important step, you want to direct this needle horizontally under the iris and avoid the capsule. So we use viscoelastic to create space in this region, and you can use a Coughlin hook to also depress the capsular bag so that you do not rip the anterior capsule. And then you pull the needle back to free up a little loop of suture so that you can retrieve this with a Coughlin hook. And once you've done that, you then thread the end of the suture loaded on the capsular tension device through the extended loop of the suture snare, and then you retrieve it to the scleral fixation point, and you repeat this for the other end of the suture, and then you are ready to tie your knot. So let's have a look at some of these pearls. So this is using a capsular bag hook. I direct the paracentesis towards the edge of the capsule rhexis. This is important so that the direction is correct and you do not pull up the capsular bag. Now, people have difficulty inserting attention rings. I'm showing you this without the lens, and you see you just need to lay out 3 clock hours before you inject. And this is real time, so it goes in within 10 seconds. I'm going to show you a severe zonulitis case of mine, and you can see a UVM very interestingly just picked up the vitreous in the anterior chamber and showed us that the lens was decentered. So I had used the femtosecond laser, which is an extremely useful tool in such cases of severe zonulitis. And just from the paracentesis, you can see the vitreous came forward, and therefore I'm going to start with vitrectomy. We always have to deal with vitreous when it's presenting in the anterior chamber. But first I need to support this lens. So I remove the capsule and support the lens bag with a capsule bag hook. And once I do that, I'm doing a vitrectomy from the pars plana approach, a trocar cannula there, stained it with triamcinolone acetonide so that we could remove it adequately from the anterior chamber as it's pulled back. And then we support the rest of the capsular bag with capsule bag hooks. And next, to support the equator after injecting viscoelastic under the capsule, just in that plane, we then inject the capsular tension ring in. This is a very important step. You create that clean plane of cleavage with the viscoelastic, and then we support the rest of the lens. And this was a young patient, so I just aspirated this lens very easily. You don't really need femto for the nucleus, it's more for the capsulotomy. And before you take instruments out, always maintain the space with viscoelastic to prevent further herniation of vitreous. And after the RL has been inserted, I now know where the bag is centered, and therefore I'm enlarging and centering my capsule rhexis. and creating the suture snare. In this case, I was using a 27 gauge needle, thread it, bend it, and load on a capsular tension segment, and deciding exactly where's the best place when the lens is centered. That's the right clock position to place it, creating a Hoffman pocket with the help of a mini crescent, bend my suture snare. Now create the space here, very important, viscoelastic, and the capsule hook, and the coconut hook actually presses it down, extend that lasso, and then retrieve the suture after threading it through the extended lasso. Again, we want to press down on the capsule and pull back on that needle a little to allow that loop to be formed as we extend the lasso, and then bring both ends to the Hoffman pocket. We retrieve the suture from within the pocket, and now we're going to tie a 2-1-1 knot after centering the intraocular lens. Remember, the tension is used to adjust the RL position so that it is centered at the end of the surgery. And here again, we're going to check for vitreous, stain it with triamcinolone acetonide, and there's no vitreous, but we're going to the back again through the past planar, and we ensure that there's no vitreous prolapsing. So I'm going to show you another case that's dangling a little posteriorly. First, we start with vitrectomy after staining it with triamcinolone acetonide. And after doing that vitrectomy, put some viscoelastic into the anterior chamber. And then I use a 27 gauge needle to levitate this nucleus forward, cut it with my capsulorhexis forceps. And then we're doing a bimanual capsulorhexis and supporting the capsular bag with iris hooks. I prefer iris hooks to capsule bag hooks for this. And then creating a suture snare, as you saw earlier. And then the plane of dissection just under the anterior capsule. Make sure you pick this up, a nice clean plane so that you will not trap cortex. And then inserting a capsular tension ring with a 1-point fixation, gentle hydro dissection. And I'm going to trough, right? In this case, I have to do phaco in the older patient. And I cross chop so that I do not have to rotate the nucleus and lose more zonules. And I just pick up the pieces with my chopper, and then we remove all the cortex, inject the viscoelastic into the bag, anterior chamber. And then again, I'm going to enlarge and center this capsulorhexis that was created manually. And then I'm going to inject a EDOF lens. And that's why I want to make sure that the rhexis is adequate size and centered. And then my Hoffman pockets are now being created. So I will definitely need 2-point fixation because this is more than 8 clock hours of zonulysis. I now anchor this point with the cortex sutures like what you saw earlier, and then I create another point of fixation, and I insert a capsular tension segment. It's much easier to do it this way, mix and match rather than using a Cioni 2L. Otherwise, you have to rotate against no zonules. That's really tough. So in this case here, we just insert the tension segment into place and then use the suture snare, a very useful technique to bring the suture point to the fixation point. And when we retrieve the sutures from the capsular bag, we do a 2-1-1 knot. We don't finalize it until we've adjusted the tension to center this EDOF lens, and then we finalize the tension and pop the knot into the Hoffman pocket, which is at least half scleral thickness. We check for vitreous again, and we have a perfectly centered lens. I'm going to show you another patient here that I didn't think too much of the UVM images and, well, some diffuse zonulysis. So this patient also has an intumescent lens, and I was milking the cortex, making sure I did not have a run-out of the capsulorhexis. I noticed that there's a lot of capsular bag movement, so I'm doing a bimanual capsulorhexis using Brian Little's maneuver here to pull the rhexis inwards and to control its size after staining it with dye, capsular dye, and then injecting just under the anterior capsule into the plane to insert my capsular tension ring to expand the equator. Well, as I said, I didn't think too much of this zonular weakness based on the UBM, although I knew it was rather shaky here. And I said, well, let's carry on. And I was chopping this nucleus, and I was a bit surprised this cataract was a little harder than anticipated. But nonetheless, we are doing reasonably well in separating all the fragments. And as I went along, I suddenly noticed that as I was trying to do all these divisive movements with my fragment, that the capsulorhexis changed shape. thanks to the capsular dye. And so I stopped everything and I realized that my capsule back hook had actually come off. And now we're on track, but we have a little strand of vitreous coming there. So to continue, I cut that strand and I continued. And I realized I lost my red reflex because the dye had gone posteriorly. So now we are facing greater difficulty, but we are putting in the RL to act as a scaffold so that the vitreous didn't, the misdirected fluid didn't come forward and push my posterior capsule in. And this time I'm going to fixate this capsular tension segment with polypropylene 6O using a flange technique. It was started by Sergio Canabrava from Brazil, and I'm doing it on the opposite end, and you'll see it goes through the full thickness conjunctiva sclera, 1.75 mm posteriorly. And then now I'm not feeling good about the vitreous, so I decide to cut the vitreous, right, both posteriorly as well as anteriorly. And now then I thread in my capsular tension segment and pull the suture through, adjust the tension, flange it with cautery, and the lens is now well centered. I've buried the flanges, make sure I don't have any vitreous, and we can have an excellent result this way. So in summary, these are my pearls. Use capsular back hooks to support the equator, stain and deal with vitreous in the anterior chamber. Whenever it presents, you must deal with it before proceeding with phaco. You can use anterior assisted levitation for a lens that is dipping into the vitreous with a 27 gauge needle without bending the bevel, and then bimanual capsulorhexis, and then place the capsular tension ring before phaco in severe zonulitis, and you inject the capsular tension ring into the plane just below the anterior capsule cleaved by this viscoelastic. Create Hoffman pockets at least half scleral thickness so that the Gore-Tex knots are actually well buried and do not get exposed or erode the conjunctiva. So I would recommend Gore-Tex 7O with the suture snare technique. And remember to always create space for the needle as it comes through and adjust the suture tension to center the LL. Thank you very much for your attention.
Thank you, Professor, for excellent talk and excellent videos as well. There's lots to learn from you. The surgery looks very easy in your hands. Actual surgery in subluxated lenses, it's quite difficult.
It's not too difficult if you have lots of practice. So, yeah.
Capsulorhexis is tough, especially in subluxated lenses. Capsulorhexis is tough, and if you don't have access to femtosecond laser, but bimanual capsulorhexis technique which you have shown, it looks easy. It's difficult to perform.
Well, you can try it
throughout the surgery. Which no, we can't hear you.
You can try it with your standard cases, just grasping onto it and then doing it. Yeah.
Usually you use which viscoelastic device during surgery in such cases? Do you have any preference, particular preference for such cases?
I still prefer to use visco. I have no financial interest.
So you use visco in all the cases?
It protects the cornea very well as well, and it creates space and stays even, you know, where you put it. Yeah. So you will see that if you visco dissection just under the capsule, you don't see me trapping cortex at all. So I think that's a very, very important pearl I want to share with you.
And the dissection of the cortical space before injecting capsule tension ring, that you do just blunt dissection or you do visco dissection?
It's always visco dissection, yes.
Dissection with visco.
So yeah, and you only need to dissect about 3 clock hours. And once you've got your tension ring injected into these 3 clock hours, it tends to stay in that plane 360 degrees around.
Great, great, nice. Any other questions by panelists? Dr. Dixit sir, do you have any question for Professor Chi? Dr. Archana, would you like to comment on her surgeries?
I'd just like to say that Professor Chi, you just make it look so easy. That's all.
Thank you. Thank you.
Excellent presentation. Excellent surgical.
I had just one question.
Yes.
The Professor Chu, when you lasso the suture and pull it through, does it remain stiff enough, or is it just cortex, or would any other material also follow through the needle as easily?
Actually, if you use 9O polypropylene, it would do the same job. But usually 9O comes with a nice needle that you can use to directly suture to the sclera. The reason why I devised this technique is because the needle that comes with the 7O Gore-Tex is really too thick and it's too short to actually span across the eye to reach the sclera for the fixation. So I devised this technique so that it makes it really quite easy to handle the suture.
And you did mention there are reports on the polypropylene degrading with time. Does it degrade or does it snap, or what exactly is the problem? Because I think most of us are using polypropylene here.
I think there have been reports showing that if you are using it with an eyelet, for scleral fixation, that eyelet can sometimes be rather rough when it's magnified on electron microscopy, and that actually, with eye movements and so on, it actually chafes against the polypropylene and actually cuts right through.
Thank you.
Thank you.
Thank you, Professor, once again.
Thank you.
We go to the next talk, Mukesh.
Yes, sir.
Now we move from the Eastern Hemisphere to the Western Hemisphere. The next talk is going to be by Dr. Archana Kulkarni, Miss Archana Kulkarni, as is known in UK, after you do your fellowship. Dr. Archana is a consultant ophthalmologist at the South Warwickshire NHS Hospital, UK, since the year 2014, where she leads the pediatric ophthalmology and strabismus services. She's also a visiting consultant at the Birmingham Children's Hospital, where she contributes to a very unique and interesting multidisciplinary rare disease services, including Wolfram syndrome, which we also call as Didmore syndrome, Alstrom's, Bardet-Biddle syndrome, etc. And she has a special interest in ciliopathies and optic nerve diseases in children. It's a matter of great pride for us that Dr. Archana graduated from BJ Medical College, Pune, and I consider myself very fortunate to have known her since her residency days. While being in UK, I have observed her over decades that she worked extremely hard and sincerely to climb the ladder to reach a fellowship, to reach the absolute pinnacle post of a consultant in the United Kingdom. She had done her fellowships in pediatric ophthalmology at Birmingham and pediatric and neuro-ophthalmology fellowship at Leicester in UK. She has an active interest in research and has contributed to numerous scientific publications. Because of her interest in childhood visual impairment, she took a lead to establish Warwickshire Eyesight Support Group and also founded Sight and Beyond non-profit initiative to broaden horizons for the visually impaired through assistive technology, workshops, as well as seminars. With her interest in global vision, she is involved in projects with H.V. Desai Eye Hospital of Pune and also the Kenyatta Hospital, Nairobi in Kenya. Dr. Archana, I must tell you that you are a role model and inspiration for many of the postgraduates who are attending today's webinar. And you have shown a pathway that from studying in BJ Medical College or from other colleges in Pune, one can excel with hard work to get a foothold in the United Kingdom and also on a global scene. I request Dr. Archana to kindly deliver her talk on orbital cellulitis in children. Dr. Archana.
Thank you, Dr. Dixit. It's a pleasure to be here. Can you hear me?
Yeah, very well.
And thank you for your kind words. It's truly humbling, but it's just nice to be back in Pune, even though it's virtual. Right, so just trying to get the slides to work. There we go. Right, so periocular infections, that's something that really gets me on edge, especially in as they come in as a medical emergency with very unhappy children, very anxious parents, and being a sight-threatening or life-threatening possibility with intracranial complications. It's really something that I tend to worry about. Right. So anatomically, we know that typical that the orbital cellulitis is as classified by Chandler as a preseptal or postseptal. Then you have the periosteal abscesses or orbital abscesses, and then spreaded intracranial complications. Clinically, of course, you've got the, we're well aware of the preseptal and the orbital clinical presentations, where you have with the orbital cellulitis, you're worrying about if there's chemosis, proptosis, painful eye restrictions, and optic nerve dysfunctions. But there's never a clear-cut differentiation between the preseptal and the orbital. And often in children, the preseptal can rapidly progress into orbital, and the children can deteriorate quite rapidly. The age of presentation is also something really important, where we have find that the younger children are 5 times more likely to have preseptal cellulitis, which can be treated medically, whereas the older children are more likely to have orbital and deeper infections, which may go on to need surgical intervention. So the older the child, the more worrying, and from experience, we found that it takes longer for things to settle, and you have to be prepared for the unexpected. So underlying causes of periocular inflammation, you've got both the infective as well as non-infective. So here, especially during the flu season, we find that the infective cases reach a pinnacle, and the wards are completely full with children with periorbital inflammation. And the commonest cause would be sinusitis, dacryocystitis, herpetic infections, trauma, insect bites. The non-infective ones I've actually seen more in India with rhabdomyosarcoma, retinoblastomas, scleritis. And there are different protocols all over the UK. So the different places that I've worked with all have different protocols. And there's no unified protocol. It depends on how you liaise with the microbiologist, the pharmacist, ENT, pediatrics, and then decide on a local protocol. But the simplest way of approaching the management of any periorbital cellulitis is one, early diagnosis, having a multidisciplinary team approach where you have the pediatricians, ophthalmology, ENT, radiologists, microbiologists, all working together. Start off with treating with antibiotics, then go on to do the investigations, which would include your conjunctival nasal swabs, blood culture, and monitoring the CRP, and then deciding on whether a child needs a CT scan if they haven't responded to treatment, or depending on the presentation. What's really important is to reevaluate the child again, and then decide on the next line of action, whether they need to go on to have an MRI or rush in for surgical intervention. But often examining children is not easy. So in my clinic, I end up being under the table trying to get a look at them. And with very unwell children as well, it is quite a challenge to examine. So often in preseptal cellulitis, you have a very puffy, sore eye, unhappy child, and you often find it very difficult to examine the vision, to open the eye. But if you can, that's quite a key test to do, and to try and look at the ocular motility, and difficult to test for proptosis in a child with puffy eyes, but if possible, that would be helpful. So in preseptal, commonly you see lots of inflamed chalazion, which you can treat just with oral as well as local antibiotics, or a mixture, a combination of antibiotic and steroids. But in this case, it obviously needed to be surgically incised and curetted. Herpetic ones are also tricky ones to treat, but more than the local infection is, why is this child got such a severe herpetic infection? So is there is the child immunocompromised, or is there anything else going on? So just local treatment and observation would be helpful. And if they're systemically unwell, obviously the first thing to do would be to admit the child. Recently, we had a child that came in with just mild preseptal cellulitis, severe headaches. So he had the oral antibiotic coamoxiclav, went home. 2 days later, he comes back with a severe rash, severe throbbing ache, and quite a lot of lid swelling. So he was treated like progressive preseptal cellulitis, almost orbital cellulitis, and was admitted, given IV ceftriaxone, which is what part of our protocol, oral acyclovir as well, and he also had topical antiviral eye drops. So we'll come back to that patient towards the end. Very often, especially in the winter season, we get lots of little children, the younger ones under 5s, coming in with a runny nose, being unwell, fever, and with very swollen lids with preseptal cellulitis, and having to admit these children, even if it's preseptal, mainly because they can deteriorate quite rapidly. And dacryocystitis, again, is not very common, but when it happens, it can be quite unpleasant for the child and needs to be admitted and treated again according to the protocol. You have to expect the unexpected. So this was a child that came in with a recurrent small cyst. It looked like a dacryocystitis, but well away from where the nasolacrimal sac would be. And treated with, so right from the age of 8 months, she had recurrent ongoing infections in a very localized area under the lid, but away from the nasolacrimal sac. So settles down each time with the antibiotics, but kept coming back. So we had a CT scan done looking for a possible aberrant ethmoidal sinus cell, but in children where the sinuses are quite small and not as well developed, it wasn't seen, and no other cause was found. So from the literature, there have been 1 or 2 case reports of these aberrant ethmoidal cells, which is what we presumed. So treated surgically, so is excised and excised as much of the deeper tissue as possible. And soon after that, she settled down. The other things too, so any puffy eye, you have to lift the lid and just check for any other cause, such as dacryoadenitis. So our local guidelines, so this is in discussion with the ENT team, the pharmacists, microbiologists, pediatricians, and all the different guidelines that we could get hold of. So this is our protocol for preseptal cellulitis, where if it's just limited to the lids, we'd give them oral antibiotics. And if it hasn't settled down over 48 hours and the child's getting worse, then you admit them and give them coamoxiclav. And if it doesn't settle down, then the choice of clindamycin. And the younger ones, we try and avoid metronidazole, but the older children, well, that's something that we would consider early on. And then preseptals, we don't normally scan unless they're getting worse and not responding to treatment. And with these children, with preseptal between 1 to 2 every 2 days, we would do the ophthalmology examination to make sure that the optic discs are fine, not developing any optic neuropathy, and visual responses are remaining good. The orbital cellulitis ones we treat a little bit more aggressively, where they, because they can deteriorate and have intracranial complications sooner. And in these, it's important that we have clear optic nerve function assessment with vision, color vision, if age-appropriate color vision, if possible, and if the child is well enough to do that. Fundus examination, and wherever possible, we try and do OCT images of the disc and Optos images, which helps with follow-up. So this is a child that came in, 12-year-old, so an older child. It always, rings out warning bells. So an older child, very slight, as you can see in the first picture. First day, his mother mentioned just a little bit of redness of the conjunctiva and the lid. Even the lower lid's a lot more puffy. The next day, the lid is even more puffy. So he comes into casualty. In the casualty, he's treated with oral flucloxacin, goes home, and suddenly the next day he's deteriorated. So he's quite drowsy, severe swelling, severe headache, but he's afebrile, probably because, he's taking paracetamol at home. comes back in and we straight admit him. He's given IV, according to our protocol, IV ceftriaxone. Starts to feel a little bit better. Vision's good, no evidence of optic neuropathy, no disc swelling, but being an older child, he's also started on metronidazole along with the ceftriaxone. CT scan was done the same day, and he's got significant sinusitis with the frontal sinuses. There's also the sphenoidal sinus fluid noted. And you can see on the left here, you can see a subperiosteal orbital abscess and some extradural collection, which was small but significant. So the ENT team take him into theatre the same day. And we also get a neurosurgical opinion from the Birmingham Children's Hospital, and they agree with the ENT draining the subperiosteal abscess, doing a sinus washout, and observing with the IV antibiotics. 3 days later, he still has significant inflammation of the sinus mucosa, residual subperiosteal abscess, and still small residual extradural abscess, which is worrying, but he's had the treatment and he's watched closely with daily ENT ophthalmology and pediatric reviews. So he settles down, he goes home, then 2 weeks later, he suddenly comes back with increased swelling over the forehead, and now he has bilateral lid swelling. And an urgent MRI is done, and you notice that there's an increased extradural collection that you see there, along with the frontal sinus collection. So in discussion with the microbiologist, the antibiotics are now changed to vancomycin. He's also given dexamethasone and continues with the Becanase decongestant nasal spray. An urgent neurosurgical opinion is requested, and he's now been transferred over for further treatment. But interestingly, this child was otherwise well. So he was afebrile, well in himself. At this point, there was no drowsiness, no optic neuropathy, but it's just been very suspicious. So you could, if you just look at the external surface, you could say maybe it's preseptal extending a little bit higher, but it's quite indurated, which is a key sign. An older child, indurated swelling, you have to be really, really suspicious, because this could end up with a cavernous sinus thrombosis and severe intracranial complications. So the local guidelines for orbital cellulitis is we give, so before all the investigations, is start them off on IV ceftriaxone or cefotaxime. And if they're really unwell, you can add on clindamycin, metronidazole in older children, and if they're not responding, consider vancomycin or changing over to clindamycin. Arrange a CT scan, and ENT team have to see them within 4 hours, and ophthalmology within on the same day or the next day. So this is another, again, older children. We really worry about the older ones. So she came in with headache, fever, bit of nasal congestion, vision's excellent, but she's got limitation of upgaze. So again, that's highlighting an older child, limitation of upgaze, very suspicious. So she had a CT scan done, which was extensive sinusitis. So she started on ceftriaxone and flucloxacin. And had an endoscopic sinus washout, and there was a copulent infection and pus that was washed out. And following the microbiology, she changed over to ceftriaxone and clindamycin. So it's always finding that balance between what antibiotics you use and how they're responding. So 2 days later, she comes, she's on the ward, and she suddenly has an epileptic abscess there, and you can see that against the superior orbital wall, there is an orbital abscess. So again, she's blue lighted across to Birmingham Children's for further neurosurgical and ENT surgical intervention. Right, so again, so management of all these subperiosteal abscesses. So the younger children, you could get away with medical treatment. So with
Archana, your volume has gone down, Archana. Can you probably come a little closer?
Is that better?
Yeah, a bit better, yeah.
Yeah, thank you. So, so the management of subperiosteal abscesses, again, to consider at the age. So the younger child, you could manage them medically, treating them with the IV antibiotics and close watch, and 83% of those resolve. However, the older ones, you're more likely to need a surgical intervention. So it's important to plan that well in advance and get the scans done early, and then take it from there. And the other things to look for is if there's under 9, there's no visual compromise, and it's not a large abscess, and the abscess is located medially, then there's a better chance of it being treated medically. But when in doubt, I would say just get a scan. So it's also important to then revisit the micro. So if the child is not responding, it's important to revisit the microbiologist and discuss the infections with him and decide on what to do. There are clinical clues as to which bacterial infection it might be, and then that's needs to be considered and looked into. And it's important to review the treatment again with all the different antibiotics. So an older child, I'd add on metronidazole along with the 3rd generation antibiotic, and or consider adding vancomycin and clindamycin. Now, along with the inflammatory causes of orbital diseases, there are other causes. So we know the younger children, you have about 10% are due to periocular inflammation, whereas there is a larger percentage, 48%, which can be neoplastic. So that has to be considered. And the older ones will more likely be inflammatory, but you cannot rule out the fact that there could be a neoplastic or other vascular cause. So revisit the diagnosis if the child is not responding. Like, could it be could it be an idiopathic orbital inflammation, scleritis, vagueness, sarcoidosis, or could it be the dreaded rhabdomyosarcoma or retinoblastoma, which can present with sudden inflammatory changes? And then trauma, again, whether there's a retained foreign body. And also look into whether the child has sickle cell crisis. So it's important to keep the child hydrated. So always revisit the diagnosis and follow the cycle of checking again, but always be expect the unexpected. Where in that child that we saw with herpetic keratouveitis, 18 days later, he's responding well, although the scabs had settled down, his vision had suddenly deteriorated in the left eye, and then we noted that he had left optic disc swelling. So, and he had significant panuveitis. So there was no, he only had keratitis with mild anterior uveitis, but 18 days later that progressed, and it's taken almost 2 months for that to gradually go down. So after having antivirals, he's now just on the high dose topical steroids. So we didn't give him any oral steroids, and he's doing well. Another one is this, again, an older child. So again, be wary of the older child with preseptal cellulitis. Came in with lid swelling, severe headache, treated as preseptal, possibly going into orbital cellulitis. The MRI showed some meningeal changes. And interestingly, he also had this occlusive type of retinitis. So he was treated with, he had intravenous antibiotics, but he also then had oral steroids, and this settled down again. This took a couple of months to settle down, and his vision came back to normal. And then the dreaded retinoblastoma. So behind those closed lids, you have to try to open the eye and just make sure that there's nothing deeper going on and life-threatening. And of course, make sure that you lift the lid, because you might get something that's completely unexpected. So this was a child that just came in with a puffy upper lid, slightly red, pink, slightly red eye, just feels a bit uncomfortable. but she didn't lift her lid up, and then she had this retinal band that was there since about 4 years, but obviously that needed to be taken out. So just be prepared for the unexpected. And in children, yes, they don't allow us to have a look, but so we have to do whatever it takes to get them to open their eyes, even if it means bribery or tying them down, because it's definitely well worth the look. Thank you.
Thank you, Archana. It was an excellent talk. This is a very, very tricky area to treat for, especially for comprehensive ophthalmologists, because sometimes we can have a very laid back attitude, take things very lightly, and sometimes we can be too late. So thanks for telling us that we have to be inquisitive, we have to do imaging in certain cases, and have to be aggressive in a correct time. So very tricky situation, which you have explained. I must say that I'm very grateful that although it's something like 9 o'clock in Sydney, I believe Professor Minaz is still logged in. Mukesh, is Professor still logged in?
Yes, he's there.
Professor Minaz, I mean, hats off to you. So late on a
Still
Saturday
here.
night, but
Yes,
I would
still-
be very happy if you
still
would,
here.
if you would like to make some comments about this topic of orbital cellulitis in kids, a very tricky situation in your vast experience. Would you like to say something?
Yeah, just I wonder whether there have been more cases of periorbital cellulitis during COVID-19. Has that been?
That's an interesting question. We've actually looked out actively to see whether there has been an increase, and no, there hasn't. We normally get the flood of cellulitises during the winter season, so between November to February, which was pretty normal, but no, nothing different with COVID.
Mr. Burden, you work in the same center. Would you like to add something, Mr. Burden?
We don't actually work in the same centre. It's in fact, it's probably the first time I've seen Gunn for quite some time. In fact, it's funny how you always meet at meetings. No, I thought that was an excellent review of the subject. I have seen cases in the past with a similar complication range that she's described, and I think it is really very important, as far as I can see, to monitor your child very carefully. I think you cannot just assume that if you give them the antibiotics, you can send them home and they'll get better. You have got to make sure they're getting better. And I was particularly interested in that relapse of the zoster. I think she's done remarkably well for that child to have regained the vision with that frosted angiitis. That is a very worrying sign when you see that in association with HED. So anyway, great cases.
Professor Chi, would you like to add something, comment your experience in Singapore?
I think Professor Chi has left because she had some family commitments. She had somebody coming to her house actually, but in spite of that, she accepted our invitation, and so she requested to leave. So she.
But I think before it's too late, it's my duty to ask the president of POS to formally thank Professor Minaz, because as I said, it's getting a bit late in Sydney. I'm sure he's going to listen to the last talk by Mr. Burden, but still we must complete that formal duty. Dr. Gitanjali, can I please ask you to formally thank the professor?
Yes. We are on behalf of Pune Ophthalmological Society. Professor Minaz, we are really, really grateful to you. In spite of being so late in Sydney, you are here, and it was an excellent talk, great innovative ideas implemented, and especially again when we are getting a second wave in Pune, whatever tips you have said, whatever precautions and safety measures you have suggested, I'm sure every member of Pune Ophthalmological Society and all those who have joined as delegates today will definitely follow. We are really, really grateful to you, sir, for joining for this conference as faculty and accepting our invitation. Thank you very much from Pune Ophthalmological Society.
Thank you very much. It was a great.
We do look forward to you visiting us sometime in Pune, whenever we can have you next.
I would
let's go to the final talk now. It's indeed my privilege and honor to introduce our next speaker, Mr. Michael Burden. He's a consultant ophthalmologist at the Queen Elizabeth Hospital, Birmingham in England. I've seen his CV, but Mr. Burden, I have read a lot about you and seen your interviews. I've worked in England intermittently for over 3 decades, but I've never had the privilege or the fortune to work with you in Birmingham. I know that your father was a GP and you took inspiration of becoming a doctor through him. But I've also read that although you had a lot of interest in physics and mathematics, it was your motto in life to serve people. And by becoming a doctor, of course, you fulfilled that desire. I also read that back in 1985, when you were doing your electives, which in India we call as internship, you were doing that in Uganda, and while observing cataract surgery, probably that stimulated you to become an ophthalmologist. Mr. Burden got his training in London, Oxford, Brisbane in Australia, and Moorfields. As a consultant, his areas of interest are cataract, glaucoma, strabismus, and of course, neuro-ophthalmology, which is the topic of his lecture today. Mr. Burden went well beyond the clinics and hospital and established a permanent link between his department in Birmingham and a medical center in Tanzania. The link helps to train ophthalmologists from Tanzania. It helps them to develop subspecialty skills and also support clinical research. Mr. Burden is responsible for establishing a link between the Royal College of Ophthalmologists and the east, central, and southern part of Africa. Mr. Burden served at the Royal College for almost 10 years, which culminated in him becoming the president of the Royal College of Ophthalmologists between 2017 and 2020. He held a variety of leadership roles, including chairman of the National Institute of Health and Care Excellence Cataract Guidelines Development Committee. He has developed a large center of neuro-ophthalmology at Birmingham, which I must say is quite unrivaled in the world. With these words, I request this highly distinguished individual to deliver his talk. And today, in this era of phaco and flax and injections, what we are going to hear from him is something which we rarely hear: modern management of third nerve palsies. Mr. Michael Burden.
Thank you very much for that extremely kind introduction, and I would like to congratulate you on tracking down that much detail. I'm usually quite modest in what I let out, so you've done a very impressive job for me. So thank you very much for inviting me to be part of the meeting today. What I'm going to do is just review a little bit about the third nerve palsy. That I think is a simple message, as you will see, but a very important one. So those are my disclosures. As a neuro-ophthalmologist, I have no financial disclosures. So what I'm aiming to do is to review the history of the investigation of third nerve palsies. And the reason I want to do that is it's sometimes useful to look back and see where we've come from and how much medicine's evolved. But I also think it's very important to understand now what you will read in some of the older textbooks and why I think it is no longer appropriate. So at the end of the talk, what I'm hoping to do is to provide you with a very simple and safe recommendation as to how third cranial nerve palsies should be investigated. So we all know that the third cranial nerve innervates most of the muscles related to the external and internal eye. And when patients present to you with a complete third nerve palsy, they don't complain of double vision because they can't open their eyelid. But if you do that for them, you find that the eye is deviated laterally, the pupil is large. It's said to be down and out, but because the superior oblique is only particularly a depressor in adduction, it's not, in my experience, particularly down. So here is a patient with a complete third, and if you watch the lid, you can actually see a little bit of movement outwards. And in a second, we will make it easier by lifting his lid, and you'll see that his pupil is, hang on a second. Let's start that about there. You should see that His pupil is dilated, the eye is deviated laterally, the pupil is fixed. And when we test the eye, the only movement he can do really is abduct. But if you watch very carefully, when we try and get him to depress, there is a small amount of torsion, making this an isolated complete third. Partial third nerve palsies are a little bit more difficult sometimes to pick up, but it should be considered if there is limitation in direction of any of the muscles that the third nerve innervates, if there's a ptosis, if the pupil is enlarged, or if there is evidence of aberrant regeneration. So this lady has got a right partial sixth cranial nerve palsy, even though the class is on her left side. So she can abduct the right eye. She can move the right eye well beyond the midline, but not fully. Upwards is not too bad. Downwards is not quite so good. And there is a partial ptosis on that side. So I would categorize that as a partial and pupil sparing third nerve palsy. Signs of aberrant regeneration are important to look for, partly because unless you think of them, you can be very confused as to what is actually going on when you see a patient who's got well-established aberrant regeneration. But it's a marker usually of long-standing compressive lesions, such as an aneurysm, such as a meningioma. And what you may see is elevation of the upper lid on down gaze or adduction, adduction or retraction of the eye on attempted up or down gaze, and constriction of the pupil on attempted adduction. So here's a patient with a left partial third nerve palsy with a degree of ptosis and depression. But interestingly, when she looks down, the left lid remains elevated and the left eye actually adducts. So when you're faced with a cranial nerve palsy, the most important first question is that palsy isolated? In other words, are there other cranial nerves involved, or are there other peripheral limb signs? And if the cranial nerve palsy is not isolated, it basically indicates almost certainly a structural lesion, and you should consider urgent imaging guided by the localization that your examination has shown. So up here, this is tending to jump ahead. This is a section through the midbrain. The third nerve nuclei are up here, and in the colored section here is a fascicle of the nerve the third nerve as it emerges. If you have a lesion, perhaps an infarct in this area, you will get a third nerve palsy on this side, but you'll also get a contralateral hemiparesis, because these are the descending cortical spinal fibers that drive the limbs. This is a lady with a massive aneurysm that started off as part of the intracavernous carotid artery. Most of this, there is actually calcification of the wall of the aneurysm. A lot of this is clot within the aneurysm, but there's still a lumen and there's flow on this CT angiogram still through this massive aneurysm. Now, if the cranial nerve palsy is isolated, then what you're going to do is investigate, guided by the likely underlying cause. And the way we classify isolated cranial nerve palsies, such as a third nerve, is often by an anatomical classification, starting off at the nucleus and possibly affecting the fascicle, the subarachnoid space, the cavernous sinus, area, and the orbit. But actually, from the patient's perspective, it's more important to know what's causing it. And as we all know, the causes of an isolated third cranial nerve palsy, most importantly, include an aneurysm. Microvascular third nerve palsies are more common, but the most important thing at the outset is to recognize that this could be an underlying aneurysm. Tumors, meningitis, demyelination, they're all, I've seen them, but it's the aneurysm that dominates our management of this condition. And the reason is the third nerve, as it passes from the midbrain, passes forwards in association with the circle of Willis, and there are various locations where you will find aneurysms, and most commonly it's the junction between the posterior communicating artery and the terminal ending of the carotid artery, the posterior communicating artery aneurysm, that is responsible for a third nerve palsy. So why is it important? Well, aneurysms are reported to be about 14 to 56% of isolated non-traumatic third cranial nerve palsies are due to an underlying aneurysm. The fact that you've developed a third nerve palsy indicates that the aneurysm is expanding, and if it's expanding, it may rupture within hours. I personally heard of a patient who had the palsy diagnosed rapidly, was in an MRI scanner within an hour, and died in the scanner. This is a very, very urgent problem. If your aneurysm ruptures, you have a 66% chance, 2 in 3 chance of either dying or being left with serious neurological disability. Now, Jonathan Trobe is a very impressive professor of neurology and neuro-ophthalmology in the States. And he wrote in 2009 about the use of modern imaging to detect aneurysms. And he made a lot of points that in that article that I recommend you have a look at, that I entirely agree with. Now, one of my first fellows was an Australian, and in the Australian way, he one day came to me and said, you are more likely to die of an uninvestigated third cranial nerve palsy than from a shark attack. And he produced these statistics, essentially about 100 people attacked by sharks every year, out of which about 8 are fatal. If you have an uninvestigated third cranial nerve palsy, the risk of death is about 11%, based on approximately 1/3 of them being due to aneurysm, of which 2/3 will rupture, and once rupture occurs, 50% mortality. So just have that in your mind next time you see a patient with a third nerve palsy. Now, aneurysms and their association with cranial nerve palsies has been known for a very long time. This is a large series reported in 1907 by Cecil Beadles, a Hunterian professor at the Royal College of Surgeons. And he classified them into those where the first indication of the cerebral lesion has been an apoplectic attack. That means a sudden, often fatal attack due to rupture of the aneurysm. Then there are those which that fatal apoplexy was preceded by some neurological dysfunction, such as a third nerve palsy. Those where there have been indications of cerebral tumor only, in other words, there is some onset of neurological dysfunction, and then those that are only discovered post-mortem accidentally after death. And what we're looking at, with this is when we see our third nerve palsy, we're in this group, and we want to stop them turning into this group. He concluded his article by highlighting the problem of how you diagnose these. And he commented then, essentially, the exact diagnosis of cerebral aneurysm during life is no more possible today than it was when Gunn wrote nearly 50 years ago. Although we may, from the circumstances, sometimes suspect the presence of an aneurysm within the cranium, we have at least no symptoms upon which to ground more than a possible diagnosis. In other words, at that time, there was no way of diagnosing aneurysms, and actually, to be fair, there was almost certainly no sensible way of treating them. That all changed courtesy of this gentleman, Professor Egas Moniz, who invented cerebral angiography, this incredibly impressive Portuguese doctor who actually won the Nobel Prize for other activity. On the 28th of June, 1927, developed, and this is the first photograph of him doing cerebral angiography on a live patient. And cerebral angiography was the only real way of looking for aneurysms and other vascular problems in the head until the advent of CT scanning in 1975. But it had significant risks. was complex to do and really only available in specialist centres. And in 1962, a review of Field et al.'s series of 2,000 cases reported that this had a complication rate of 0.4% deaths and 0.4% permanent severe morbidity. And even in 2009, there was a 1 in 200 chance of permanent neurological deficits as a result of the investigation. And that really dominated our thinking about the possibility of having aneurysms as an underlying cause of the third nerve palsy. We had a test that was complicated to perform, complex, required admission. It was a significant amount of danger to it. So what they try to do is refine our knowledge of the impact of an aneurysm on the third nerve to know who we should actually subject to that test. Age does not help. You can have aneurysms from the age of 20, and there's a peak incidence in the 5th and 6th decades, which overlaps entirely with that from microvascular causes. Both aneurysms and ischemia can be painful or painless. And it was the pupil impact that people really focused on. And this was kicked off by a chap called Rucker in 1958, who reviewed a whole series of cranial nerve palsies and observed that in the vast majority of cases, aneurysmal third nerve palsies did not spare the pupil. And in the 2 cases that the pupil appeared to be unimpaired, the extraocular muscles were not completely involved themselves. And this led to recommendations, again by Professor Trobe in 1985, that he said that if patients have normal pupillary function and completely palsied extraocular muscles, that was almost certainly going to be microvascular, and you don't need angiography if the patient is over 50 and therefore likely to have an underlying microvascular cause. However, if the patients have a normal pupil function, but the muscles themselves are not completely palsied, then they need angiography. And patients with a subnormal pupil sphincter and completely palsied extraocular muscles, so-called relatively sparing, relative pupil sparing patients, they should have angiography unless they've got clear-cut vasculopathic findings. And people drew tables like this, which basically correlated the degree of pupil involvement against the degree of extraocular muscle and upper lid involvement. And they tried to weigh up the risks of this person having underlying aneurysms and therefore being subjected to angiography. And eventually, you will find in most textbooks today this sort of classification of third nerve palsies: complete external ophthalmoplegia, pupil sparing; complete external ophthalmoplegia, pupil involving; partial, and in brackets, pupil only. And really, that is the latter is only really seen in the context of neurosciences centres, where the patient is having a herniation of the brain. And in that classification, the recommendation is that the patients with complete external ophthalmoplegia involving the pupil or have a partial ophthalmoplegia are the ones that are likely to have an aneurysm and therefore the ones that should be investigated. However, the reality is that if the patient has an underlying aneurysm, but the pupil is spared initially, the pupil may become involving over time. And therefore, the current recommendation is if you don't scan them or investigate them immediately, they are going to require close monitoring until the nerve palsy has recovered, indicating that it was microvascular, or if it hasn't recovered, you're going to investigate them. The other more fundamental problem amongst more general ophthalmologists, and certainly a lot of my trainees, is a misunderstanding of partial versus complete. And to me, unless every extraocular muscle innervated by the third cranial nerve, including the lid, is completely involved, not partially involved, then it is partial. So if the lid still works a bit, it's partial. If they can adduct the eye a bit, it's partial, even if all the muscles themselves are affected to some extent. And the other issue, of course, is that we now have modern, widely available, non-invasive imaging. And therefore, I agree with Professor Trobe's 2009 statement, revising his own statement from nearly 20 years earlier. Yes, but basically he's now saying all patients presenting with an isolated third cranial nerve palsy should undergo immediate imaging. The choice of imaging actually, I think, doesn't really matter these days. The posterior communicating artery aneurysm that's big enough to cause a third cranial nerve palsy is almost always at least 4 millimeters in diameter. And modern CT angiography and modern MRI angiography are both capable of detecting such aneurysms. On the whole, however, in the emergency situation, CT angiogram is faster and usually more widely available, and you're likely to reserve MRA for people who are women are pregnant, for children, and those with some renal and cardiac impairment that might make the contrast media for CTA contraindicated. And you can get absolutely stunning pictures. And if you're lucky, your pictures will come pre-measured for you. But if you just take away those measurements and say, can I, as a ophthalmologist, or more importantly, as a routine radiologist, could I actually spot the aneurysm on that picture, even after all the image processing that has been done? It is not easy. And I would like to highlight this very important issue related to third cranial nerve palsies, is the need to make sure that people who are looking at the scans know what they're looking for. And this was highlighted by Dr. Ellman in the States in this article in 2011, where they reviewed 17 patients presenting with an isolated painful third cranial nerve palsy that was eventually found to be due to an aneurysm. At presentation, 4 had evidence of a subarachnoid hemorrhage on the initial CT scan, basically leading to the diagnosis. 5 others, the initial radiologist got the diagnosis, but 8 of them were missed because the person reporting the scan really wasn't familiar with what they should be looking for. So my final recommendations have been giving you the background to why the literature, if you read back through it, and why the other textbooks insist on classifying third nerve palsies, it's now become very much more simple. I would strongly urge everybody to immediately image all third cranial nerve palsies. I would advise you to leave the choice of modality to the radiologist, whatever he or she is familiar with, but you must make sure that that radiologist is competent to report the scans that they performed. So there's been a lot of history related to third nerve palsies. The answer now is very simple. Scan them all, make sure the person looking at the scans is competent. Thanks very much.
Thank you, Mr. Burden, for an excellent talk. I would like to ask you something not related to third nerve palsies, but because working as a neuro-ophthalmologist, I would like your frank opinion about a fact. In general, comprehensive ophthalmologists, if we see a patient of any nerve palsy, third nerve palsy or otherwise, we tend to pass the buck to a neurophysician quickly, or if available, a neuro-ophthalmologist, because you have been working in a large department, you have interest in other subspecialties as well. What would you say so that the comprehensive ophthalmologist gets more involved in diagnosing neuro-ophthalmological conditions? It's a very common thing. I'm sure that most of the attendees who are listening to your lecture will agree with me that you see somebody with a nerve palsy, you just shunt it to somebody like a neurophysician. Yeah. How do you stimulate your students? How do you make them generate interest in seeing that more carefully?
Yeah, well, I think this goes to the heart of the matter of understanding how to make a safe clinical diagnosis. And there are conditions where you can do that. So in the UK, where multiple sclerosis is common, it is very reasonable to say that if a patient presents with progressive loss of vision over a week or more, maximum 2 weeks, with pain on eye movements that is consistent with a unilateral optic neuropathy with or without disc swelling, who's between the ages of 16 and 45, that is going to be demyelinating optic neuritis. And there you can, as I do, say this will get better. There's a separate conversation as to the underlying etiology, which is the risk of multiple sclerosis, but I don't scan those patients looking for evidence of the diagnosis. I scan them, if they want me to, looking for evidence of underlying disease of multiple sclerosis. Similarly, when you're looking at cranial nerves 3, 4, and 6, 3 is easy. You want to get rid of that patient. If you suspect a third nerve palsy, you should. The next sentence on your chart should be sent for imaging. It's as simple as that. It's a bit like writing possible giant cell arteritis. The next word should be given steroids. That's how simple that one is. The 6th cranial nerve is completely different. It is rarely due to an underlying aneurysm, and most of the underlying causes that turn out to be structural have been there a long time, such as meningiomas, and are not going to miss being diagnosed a few weeks later. So for those, if your patient is over the age of 55, particularly if they have vascular risk factors such as diabetes, then the chances are that isolated 6th cranial nerve palsy will be microvascular. And what I do with those patients is to say, this will get better over about 12 weeks, and we'll investigate you if it doesn't. And in the meantime, don't forget to treat their double vision either by patch or prisms. And similarly, the 4th cranial nerve palsy, it's either congenital, which you can diagnose very simply by the vertical fusion range and the lack of torsion when they tell you about their double vision, or it's traumatic. And again, you can wait for it to get better, or if it's congenital, you can consider operating. It's about understanding and learning those key characteristics that allow you to make a safe clinical diagnosis for the common stuff. That's what I would encourage people to acquire. There's no point, to be absolutely blunt, there's no point in me teaching you how to recognize CJD by just listening to the patient, because you'll never see a case. But understanding the common stuff well will make you a better clinician, and I think will also expand your horizons. I think we're all trained as general ophthalmologists, and unfortunately in the UK we have a tendency to specialize until we are really only masters of one condition. And I have to say to my colleagues, there's a danger there that you've got to live with that condition for 30 years as a career. So maintaining a general interest, I think, is very important.
Thank you. You talked about 6th nerve and 4th nerve palsy, that many of them or most of them would get better. But in your experience for decades in dealing with patients of all nerve palsies, because the patients ask us right in the beginning, or maybe after a week or two after we see them, am I going to need a surgery to get correction of my strabismus or the disability? In your experience, how much percentage of these patients did you have to do surgery on them in order to give them alignment?
Interestingly, I have had very few patients with 3rd cranial nerve palsies that I've operated on, and that's for 2 reasons. One is if they persist in having a complete 3rd cranial nerve palsy, it is very difficult to do anything that will help. You may be able to do lid surgery and possibly detach the medial rectus and put some fixation sutures for cosmetic purpose if the patient really wants you to, but essentially complete thirds I have not operated on because it's very difficult to achieve anything. And interestingly, the ones that recover, often with time, recover to an extent where the patient regains an area of useful binocular single vision, usually centralized, and anything you then do might disturb that. So I've not had to do much from thirds. 4th cranial nerve palsies, if they're congenital, which is probably the most common, they go for immediate surgery, and inferior oblique myectomy is my preferred option, first option. It is a very easy operation, provided you cut the hole with the inferior oblique, and it is amazing just how well it works. Sixth cranial nerve palsies, most of them are microvascular. If you leave them long enough, most of them will recover completely. Some require a bit of botulinum toxin into a medial rectus if there's a residual bit of ESO, possibly because of contracture in the medial rectus during the time when the lateral rectus was paralyzed. But the sixth nerve palsies that have required surgery have often had underlying untreatable causes, such as meningiomas growing around the cavernous sinus region. They themselves are often unoperable. And the difficulty there is the patient has a partial sixth cranial nerve palsy initially, and you are sort of tempted to do a recess-resect procedure to straighten the eye, which would be appropriate for a partial sixth cranial nerve palsy. The problem is that sixth nerve palsy is going to progress, maybe over a few years, to a complete palsy. And then your options are transposition surgery. And what you're then potentially faced with is you've done 2 muscles already, you're now threatening to do 2 more muscles, and you will potentially cause anterior segment ischemia. So for those patients, I really try and do nothing for as long as possible or until I've demonstrated a significant length of time of a partial sixth before taking on surgery for that group. I'm also amazed just how well transposition surgery works. It is a delightful operation to do because it is so good. And I've even done it with patients who've got an associated partial third nerve palsy, and it's worked just as well.
Thank you. Those are very useful tips, because this is something which practically the patients ask, and unless somebody like you who has experienced, very, very useful tips about when to wait and when practically we cannot even do anything. Any of the panelists or attendees, you want to ask something, Mr. Michael Burden? Any of the panelists?
I had a patient I'd like an opinion on. He was in his mid-30s and he came with what looked like a third nerve palsy, and I was really on edge and sent him for imaging. And the radiologist was so excited because he called me back and said, this is a classic ophthalmoplegic third nerve. And when I spoke to the patient, of course, he recovered, and I did refer him to the neurophysician. And he comes back with a file later on, and he has sequentially had a sixth nerve as well as a fourth nerve, and now this was the third nerve. So, I mean, this was the first ever case I'd seen of a pure ophthalmoplegic migraine. And it was a radiologist who pointed it out to me. So I just wanted to share this and wanted your opinion on that, Mr. Burden.
Yeah. I've seen ophthalmoplegic migraine a few times. There is now evidence to suggest that there actually might be an underlying lesion associated with the rootlets of the third nerve as they emerge. I've personally not seen somebody's done a third 1 week, a sixth another time, a fourth another time. So that is very interesting. I'd love to see that. One of the problems I have with these recurrent third nerve palsy syndromes is this mental thought that, yes, they've done it again. It probably is the same as last time, but there's nothing stopping somebody having an aneurysm as well. So I've sort of had this tendency in the past to really have a low threshold to just do another scan. The analogy I use there is with idiopathic intracranial hypertension. I don't know how bad it is in your country, but we have an obesity crisis, and idiopathic intracranial hypertension and papedema is very common. And the mistake people make at presentation is they look at the patient, usually a woman, realize they are considerably overweight and make the diagnosis. The reality is that just because you're overweight, it doesn't stop you from having a brain tumor. And just because you've had ophthalmoplegic migraine once in your life or several times in your life doesn't stop you from having a serious underlying condition the next time. So I tend to be quite conservative, and I image. And if I don't find anything, then we can all relax, including the patient can be relaxed, knowing that it's likely to pan out the same way as it did last time. And the doctor is going to relax because he knows he's not got anything life-threatening to deal with. So that's how I'd approach that situation.
Any other question from any of the attendees?
And what might be the radiological finding? Like he described increased thickness of the third nerve as it emerged.
Yeah, there is a bit of literature related. I think you'll find it in the Journal of Neuro-Ophthalmology from around about 6 or 7 years ago. I think somebody did a named lecture on the subject a while ago, and then other reports came out. So there is a bit of literature. It's not common. I haven't seen an ophthalmoplegic migraine patient for probably 2 or 3 years. And I don't know whether that's because I've now got 6 colleagues and we're seeing them all between us, whereas I used to be the only one and did all the work. But I haven't seen one for a while. They're not common.
Then, Professor Minas, you wanted to ask something? Professor Minas was wanting to ask something.
Just to comment that I'm guilty.
Sorry, I've lost you.
So can you hear me now?
Yes.
Yeah, I just said I'm guilty of the subspecialization disease. I'm afraid. Did you hear that?
Yes,
yeah. Anyway.
You're guilty of the subspecialization disease. Well, that's true to some extent, but you clearly have wandered outside that, and you're clearly using your imagination to come up with the devices that you've come up with. My major concern about the subspecialist.
Thank you.
My major concern about the subspecialist is about how they maintain their interest over their whole extended career. Most of us are going to be consultants in the UK for 35 years. And you need something else apart from your one diagnosis or one group of diagnoses to keep you going. And that may be what you do. It may be get involved in college work, maybe involved in international work. But I think just being a condition in a subspecialty is not going to survive.
Yeah. Then.
Yeah, just to comment on this, there is a controversial. Could I continue?
Yeah, please.
Yeah. So there, just in terms of migraine, there's a controversial association between patent foramen ovale and migraine. Logical events, it's often worthwhile imaging them for doing hard imaging. There's a single case I could find of an association between nerve pins. And then finally, as an Australian, I should say to you that in the last 3 years, shark attacks, last year there were only 57, but 10 of those victims died. So there are attacks, but the attacks seems to have gone up.
So the sharks are fighting back.
Off having a third nerve palsy.
Your sharks are fighting back, are they? They've realised their
and Australia is shark capital, so don't come here for that purpose.
Yep.
Yeah.
The comment about PFOs and migraines is interesting. PFOs are actually common and migraines are common, and it is still difficult to know whether there's a true association between the two. And one of the problems is when we start looking for PFOs, we start looking hard for them. Some are very easy and obvious, some require bubble testing, and there is still a debate about what the true impact is, but people do get their foramen ovales closed for sometimes for migraines and for other paradoxical neurological symptoms.
Hello. Uday?
Far away?
Yeah, Jignesh, go ahead.
Yeah. Professor, excellent talk. In fact, one of the best talk on third nerve palsies I've ever seen. Take on your take on traumatic third nerve palsies, your line of treatment. Of course, it's a huge topic, but how exactly you go about it?
So traumatic third cranial nerve palsies are usually only in the context of significant head injuries. A fourth cranial nerve palsy, mild head trauma can cause it. Both a third and a sixth require significant injury. So usually there's going to be that understanding of what other injuries the patient has sustained. Thereafter, it's about extended waiting for recovery. So you've made your diagnosis. One of the other things you've got to be a little bit careful in the context of significant trauma is making sure that the patient hasn't developed some sort of aneurysmal swelling from the carotid artery as a result of the injury. So assuming you've ruled out all that and you've got a trauma-related third cranial nerve palsy, then it's a question of waiting. And you may have to wait for 9, 12, even 18 months. But usually, again, I've seen a lot of these patients recover spontaneously. Not always. And unfortunately, some are left permanently unable to move their eye or even open their eye. And again, as I said earlier, I've not done anything for those. Occasionally, we have done a little bit of surgery for third, but not very often.
Thank you, sir.
Dr. Abha Kanade, you wanted to ask something? Dr. Abha,
Yes, sir. I had one patient of isolated inferior rectus palsy, and the patient was referred by neurophysician. CT and MRI were normal, and patient recovered fully, but we couldn't diagnose what was the cause of her inferior rectus palsy. She was 35 years old.
So the
patient is okay.
In my experience, to be quite blunt about it, in my experience, I see a lot of neuro-ophthalmology where I can't actually explain what's happened. And I'm actually very good at explaining to patients why I can't explain what's going on. And that's part of the art of medicine as well as understanding the bookwork. When I see somebody with an isolated inferior rectus palsy, then my first question is this myasthenia? And the problem with that, as an ocular myasthenia, it can be very difficult to diagnose, because often the antibody tests are negative, the single fiber EMG is negative. It can be a complete pain in the neck to prove ocular myasthenia. So what I would do in the case of a patient who you've imaged and not found anything, the problem has gone away, is I would lodge that particular diagnosis in my mind in case they have another motility or neurological efferent muscle problem. Just, myasthenia could still be an underlying cause that could become more apparent later on.
Thank you, sir.
Just a comment on that, Mike. So during the COVID period, we had a patient that were, you know how the opticians say, oh, sudden onset third nerve, can you see this patient? And it was in the midst of the full lockdown. So we did our virtual reviews, and I got the patient to video the eye movements, and it didn't look like a classic third nerve, but I got the GP to scan him, so there was no aneurysm. But interestingly, this patient went on to have myasthenia. So unexplained, like you said, eye movements, you have to be suspicious of myasthenia, and with systemic symptoms as well.
Yeah, the last myasthenic I had came to my glaucoma clinic, very busy day. You just want them to sit down, have their pressure checked, quick look at the disc, tell them you're fine. And he starts down, he says, I'm feeling very down, feeling tired. I can't keep my eye open. I'm getting a bit of double vision in the evening. I was thinking, I don't want to know. And he kept going, and I sort of said, I don't know how you've done it, but you've landed in exactly the right chair to be diagnosed as having myasthenia at exactly the right time you needed it, because he got admitted, and within a few days he'd become generalized and was in urgent need. So myasthenia can turn up unexpectedly anywhere. I've made that diagnosis, I think, about 15 times in the last year.
Geetanjali, would like to take over to thank the speakers?
Yes, sir. It was an excellent talk, Mr. Burney.
Thank you.
Yeah, on behalf of Pune Ophthalmological Society, I take this pleasure of thanking you. We are really grateful, and the talk was excellent, informative. As Dr. Dixit sir said, most of us usually don't try to deal with any neuro-ophthalm patient. Immediately we try to refer somewhere. This was very step-by-step, how do we solve this issue. It was an excellent talk, and I'm really grateful to you. Thank you, sir.
Very much. Thank you. Hopefully one day we'll meet in person.
Yes, sure.
Thank you.
We just hope this COVID thing just gets out of this world, and then we'll meet definitely.
Thank you.
And dear Archana, to say thanks to Archana is difficult because she is my junior from BJ. So actually तो बहुत हक से काम बोलते हैं ना, उस टाइप का रिश्ता है कि if I invite her, she has to come. But thank you, Archana, and feeling so proud about you. Coming from BJ, going to UK, doing so great for yourself. It's really a proud moment for all BJs, for all Punekars. that one of us is doing so well and you spoke so well. This is again a different topic of inflammation. Okay, so that was really good, and thank you very much, and convey my regards to your family, to your brother, your husband, your kid, everybody, and thank you for joining for today.
Really humbling, and you know, I've got a lot of my trainers here and a lot of colleagues, seniors, so it's really wonderful to be back virtually. Thank you so much. Thank you.
Say hi to Rupen.
I will.
Yeah, many of you are from BJ and they all know you personally. They are sending in chat box.
Gitanjali, she is a magician. You know that?
I know. She's a magician. And
अभी का इधर का भी magic हो गया, बढ़िया बढ़िया. Very nice.
You still remember that?
Thank you.
Thank you very much.
Okay.
Dr. Mukesh?
Yeah. Is Dr. Sachin here?
Yeah. Good afternoon, everyone. We are moving on to retina talks now. It's my pleasure to introduce our next speaker, Dr. Neil Bressler, who actually needs no introduction. All of us know him, but just a formal that Neil Bressler has been a member of Wilmer Institute faculty since 1998. His specialization in retinal diseases with special interest in diabetic retinopathy and macular degeneration. Actually, he has been a principal investigator for majority of trials on diabetic retinopathy like DRCR-NET and RMDs. He has huge, more than 300 peer-reviewed publications. We are going to listen to him shortly. It's a pre-recorded talk. Let's listen to him. Thank you.
This is a great time to discuss how to take care of people who have diabetic macular edema at all times, but even the challenges that COVID-19 present to us. These are my financial disclosures, and I'm going to approach how we treat diabetic macular edema by emphasizing some of the things that Tien just mentioned, some of the items that I think Ken and Warporn will be bringing up as well. And I want to do it by discussing how we approach a case. The two most important things when you see somebody with edema, and in this case, the patient had visual acuity of 20/63, but I'll discuss what happens even when the vision is better than that. And there's edema with thickening there. The two most important things is early treatment, but early intensive treatment means two things. The first is that we typically want to initiate treatment with 5 to 6 monthly injections. I'll discuss why we want to do that. We should be out of the mindset of 1 or 2 or 3 injections. That doesn't work for over 95% of the people. So if we see a patient like this and we immediately begin to discuss with them the need to treat about 5 or 6 times to start, and then monitor them very closely, that will maximize their chance of having excellent visual. But the other thing I'm going to emphasize is that we want to identify edema ideally before there's vision loss. This allows us to do the fewest number of treatments if we can catch the edema early on. But let's go back to why we want to start with these initial injections. Let's take a case like this. This patient has edema, and by the time we see them, the visual acuity is not very impaired, but it's 20/40. And the central subfield thickness is about 400 microns. Now, what we want to do here is decide how are we going to treat them and what agent might we use. The DRCR Retina Network in Protocol T showed that when the visual acuity is 20/50 or worse, your chance of having improved vision that's clinically relevant, for example, gaining 2 or more lines of vision at 1 year or over 2 years, is greater if you use aflibercept than bevacizumab or ranibizumab. Those other agents still can lead to substantial improvement, but you don't know who is going to have a greater chance of improving. And so given 100 people, if you start them with aflibercept, on average, they're going to end up with better vision than if you start them with bevacizumab or ranibizumab when the visual acuity is 20/50 or worse. In addition, there is no evidence, as long as you know what the baseline visual acuity is, that the approach should be different if there's subretinal fluid, if there's cystoid abnormalities, if it's very thickened, if it's only a little thickened. So that we want to approach this by starting intensely with many injections. And the reason is because on average, the visual acuity keeps improving when you start with 6 injections. In some people, there may be very little improvement after the first 3 injections, and that does not predict whether they will improve later on. In other people, there will be some improvement after 3 injections, but that doesn't mean they may not still improve. So that we want to consider looking at this patient and saying, we want to start with 5 or 6 injections because they're likely to continue to improve if we go that course. Now, the other thing is, which agent should we use? And as I said, when they're 20/50 or worse, we want to consider aflibercept if we have access to it, because on average, they will do better. And we don't know if we started with ranibizumab or bevacizumab and they're not doing well and we switched, we don't know if they would ever catch up to where we would be if we started with aflibercept. Now, how about in this case? Well, in this case, what I didn't show you is the entire ocular exam. This patient has some posterior subcapsular opacity that's beginning to impinge on the central visual axis. I don't think it was accounting for much of the decreased vision, but I knew that a PSC is likely to continue to grow and cause more vision loss. And we want to get rid of the edema as fast as possible. Now, remember, I said that when the vision is 20/32 to 20/40, on average in the trial, the visual acuity is likely to be the same with aflibercept, bevacizumab, or ranibizumab. However, we don't have to start with one or the other if we have a rationale to consider that one may be better than the other. They're all alternatives. So in this case, we want to get rid of the edema promptly. And one way of getting rid of the edema promptly is we also learned that aflibercept is more likely to get rid of the thickening quicker and to a greater extent in the first year than with bevacizumab or even with ranibizumab. And that's why if I want to get rid of the edema before cataract surgery, in this case, I could use any agent, but I lean towards aflibercept because of the posterior subcapsular opacity. The same thing may be true if the patient was contemplating pregnancy and I wanted to get rid of the edema as fast as possible. So we're going to start intensely, and we started with aflibercept. Now let's talk about why 5 to 6 injections. After the first injection, it looks better. The vision's 20/32. The volume got better. We concentrate on the central subfield thickness, on the number, not the appearance, not the morphology, not the volume, but on the central subfield thickness. And it got better. But that doesn't mean it may not still get better. And the evidence says, and you can't predict in an individual patient, that if you continue to treat for 5 to 6 injections, you have a greater chance of improving than if you stop after 2 or 3. So we decided, even though the visual acuity was better, the volume was better, we would treat again. And so we gave a second treatment. Now the vision's 20/40, it worsened. Did it really worsen? Maybe. There's fluctuation going on here. It was just a month later, but this is the disease. If you watch it very carefully, you'll see that there are these little fluctuations from one visit to the next. Maybe the visit before was in the morning. Maybe this one's in the afternoon, and the person's edema fluctuates like that. So we don't base it on just one visit, but we decide we were going to start with 6 injections, and there's going to be movement in that first 6 months. So we give a third injection. And we find that now the vision improved even more. And had we not given that, had we switched to some other regimen and saw improvement, maybe it would have happened had we just stuck with the aflibercept. So again, we want to keep it simple, start with 5 to 6 monthly injections, and don't concentrate so much on what's going on in between time. The vision had improved here, the volume had improved, and the central subfield thickness had improved, so we treat again. So here's what happened. We treated 3 times, it looked like it got better. Do we stop there? There's no reason to stop there. We said start with 5 to 6 monthly injections to maximize the improvement. Even though the central subfield thickness and the volume are better, even though the visual acuity is better, we don't stop after 3 injections. So we gave a 4th. And again, the volume is improving. And we decided that's looking better, but we're starting with 6 injections. So we gave a 5th. And again, the visual acuity and the overall appearance may be improving. It's not just by 1 visit, it's over the first 6 injections that you want to follow this. And so now we have very good visual acuity, and it looks like it's normal, but it had improved from the previous injection. It was still a little over 300 microns. Because it was still improving, we gave yet a 6th injection. Now the vision dropped, but maybe it's just a variability of measurement. And again, the central subfield thickness may have improved. So we're not certain at this point that it's done improving. We want to be certain that it's stable, err on the side of treating versus not. So at this point, even though the visual acuity may have dropped a little, remember there's some PSC cataract here. It appears that the retina is improving. You have to put the anterior segment exam together with what you're looking at on the OCT. And so we said, we'll give a 7th to be certain whether it's improving or not. Well, look at that. It did improve a little bit. The visual acuity, despite the PSC, now measures 20/16, and that's how we approach it. Now, at this point, because it appeared that the central subfield thickness was reasonably stable over these last few injections, we decided that we would defer treatment. Now, once you defer treatment, you must still follow these people carefully. And so we see them a month later. It's beginning to thicken a little bit, and we decide, maybe we should consider treating that. It's beginning to thicken a little more with a second deferral, and so we decide that we're going to resume treatment. When we do that until it's stable again. So we resume treatment, it begins to improve, we decide that perhaps we have to give yet another injection. Now it may have reached some stabilization. We're not very concerned that there's still some slight thickening there, and we might consider removing the cataract at this point and being very careful that it may exacerbate at some point. And so once we reach a point of stability, we're ready to watch that eye. So that is why we try to start with 6 injections. Now, after that, once it's stable, we don't watch this carefully, but once it's stable, we say we're going to wait, and if it worsens, then we resume until it's stable again, both in vision and the central subfield thickness. So it's easier later on, but in the beginning, we start with 5 to 6 injections because there's likely to still be improvement in many people beyond just 3 injections. And that's why we want to start early intensive treatment to be able to take care of it, but then consider resuming treatment if it starts to worsen again. You can try to maintain the visual acuity that you need. So the lessons we learned that the visual acuity is more likely when it's 25th year work to be better with aflibercept and ranibizumab at 1 year compared to bevacizumab at 2 years, or maybe over 2 years compared to all of those agents. Because if you average the vision, because there's a...
Can I request others to mute your mics, please?
1 year, when you start with aflibercept and the visual acuity is 25th year or worse.
All delegates, please mute your mics, please.
Counts for that patient. If that patient has no difference among the agents, when measuring between 1 year and 2 years, they still had a benefit at 1 year. And so we want to consider when it's 25th year or worse, starting with aflibercept even if the visual acuities are the same at 2 years, over 2 years, that person experienced time with better vision, not just at 1 or 2 months, but throughout the first year. It was better with aflibercept than ranibizumab or bevacizumab. When the visual acuity is 2032 to 2040, there may be no difference. They're all alternatives, and you might have reasons to consider one versus the other because of finances, because you want to get rid of the edema quickly, and that's how we approach it. So these are clinically relevant outcomes because we look at the mean change in vision as the most sensitive way to compare these groups. But then as secondary outcomes, we look at changes, for example, of 15 or more letters. There's 5 letters per line. And we want to see if 3 or more lines of vision, where the letters double in size every 3 lines, is a clinically relevant outcome. And again, if there's persistent edema, but it's stable beyond 6 months, we observe until either the vision begins to worsen or the OCT begins to worsen, and then we treat those again. The other thing that we learned is that you want to understand that the number of injections is going to be a lot. It's 6 in the first 6 months for over 95% of the people. It averaged about 3 in the second 6 months, or a total of 9 in the first year. So we tell that to the patient. You are likely to need about 9 injections over the first year, and that will go down because we found in the second year, it was about 5. So we're down to about 14 injections with many visits. What do you get for that? Well, if they start 20/50 or worse, over 70% of them will be 20/40 or better by the time you get to 2 years, and many of them 2025 to 2020. And if you start at 2032 to 2040, over 75% will be 2025 or better. And so you can maximize that person's vision if you can convince them that you have to treat a lot, not monthly, but you have to treat a lot, starting monthly with 6 monthly injections, but then fewer in the second 6 months, 3 in the second 6 months, for a total of 9 in the first year, and 5 in the second year on average. Some will need more, a few will need less, but a lot of monitoring in that first year. Now, in Protocol T, we found that when we no longer systematically monitored these people and had them come in for one visit 5 years later after starting the study, so they were followed carefully for 2 years and then left to their doctor and their follow-up with one visit at 5 years, on average, the visual acuity began to decline. In Protocol I, where we systematically monitor these people through 5 years, the visual acuity remained stable, even though the same number of injections were given in years 3, 4, and 5 in Protocol I and in Protocol T. And so we strongly recommend that there be systematic, careful monitoring of all patients. If somebody misses a visit, you need a process to get those patients back in so that no one misses a visit, even if they're seen every 2 months or every 4 months. They mustn't miss that visit, and you must be very fastidious, very particular about getting them back for follow-up, because we fear without, there'll be 1 or 2 people that lose vision, and then another 1 or 2, and then another 1 or 2, and that adds up to a substantial amount of vision loss. There's a disconnect we've learned between the OCT central subfield thickness, the OCT morphology, and the visual acuity. So these are used to determine should we resume treatment. They are not used to determine is the patient doing well. So we may see no change in the OCT after the first 3 injections, but we continue to inject because we know that with 6 monthly injections, there could be continued improvement with injections 4, 5, or 6 when we don't see that with the first 3 injections. The OCT has a poor correlation with the visual acuity at baseline. The change in the OCT has a poor correlation with the change in visual acuity at 2 years. It only explains about 12% of the change in visual acuity. 88% of the change in visual acuity is not related to what happens in the change in the OCT. And so it's not good for predicting, should I be switching treatments? Am I doing well? you want to stay the course and start with 6 injections. How the person does it 3 months does not predict, either on their visual acuity or their OCT, how their outcome is going to be at 2 years. And so let's close in the last 5 minutes with the other meaning of early intensive treatment. The first I already discussed. Typically start with 5 to 6 monthly injections and then decrease so that you'll put your effort up front. It ends up being 9 injections in the first year, 6 in the first 6 months, and 14 injections on average overall. But what's just as important is to begin to figure out how to monitor these people so we can identify the edema before there's vision loss, when they're 2020 to 2025, as in this case. We didn't know how to treat these. There were many good alternatives. You could just start with anti-VEGF. It works when they're 2032 or worse. Why not when they're 2025 or 2020? You could start with laser, as was discussed earlier, and just add anti-VEGF if the vision begins to drop because of edema in the center. Or you could just observe these cases. The vision's excellent. Maybe if they have no symptoms, you only add anti-VEGF if the vision begins to drop. And so this was looked at in Protocol V. The approach was, if you're going to observe or laser them, see them once in 2 months. If the visual acuity is worse, that trumps everything. If the visual acuity is worse, and what we mean by that is 2 consecutive visits where it dropped by a line, or 1 visit where it drops by 2 lines or more, then start treatment, as I just explained. But if the visual acuity isn't worse, look at the OCT. Don't treat if the OCT is worsening and the visual acuity is not worsening, but look at the OCT to see if that's worsening. You might decrease your follow-up and follow the person a little more closely. The OCT affects the monitoring in this case. Only the visual acuity drives the decision to consider treatment. But if both the visual acuity and the OCT are stable and it's still 2025 or 2020, then just extend the follow-up to every 4 months until either visual acuity drops, as defined here, and start treatment, or until the OCT worsens and follow more closely. So in this case, the patient was observed. They start to develop right here, a drop in vision. The OCT happened to worsen as well, but it's the drop in vision that drives the treatment, and they begin treatment. They get 11 injections, and over 2 years, they're back to 2020. In this case, the visual acuity also dropped. The OCT did not worsen. It's the visual acuity that drives the decision. 6 injections are given. They remain 20/25. In this case, the OCT worsens, but the visual acuity did not worsen. No treatment. Watch the OCT worsen. Observe if the visual acuity is stable. And here, the OCT worsened, then it got better. It remained 20/16. Finally, some of these cases, both the OCT and the visual acuity get better. You don't have to treat these cases. About 30% over 2 years need to be treated. Here, the visual acuity and the OCT worsened, an injection was given. Here, the DME resolved, no injection given. We found that about 20% of the eyes that had a vision loss, it was due to a one-time visit of 2 or more lines of vision loss. In 40%, where they deteriorated, it was due to 2 consecutive visits of 1 to 2 line loss. So again, only about 30% need treatment. Sometimes that's due to a drop in the vision of two or more lines, then initiate treatment, sometimes not. But what you can find is that if they are just experiencing a 1 to 2 line loss, follow them. If it's sustained, start to treat. If it's not sustained, you don't need to treat. So 1 to 2 line loss, watch carefully, but you don't need to treat. And in this way, if you observe them, or you start with a aflibercept, or you start with laser, as long as you rescue with a aflibercept, the outcome is going to be the same. The difference is that when you identify it before there's vision loss, the average number of treatments over 2 years is 6. And that's why it's so important. Follow these people carefully. Even in an era of COVID-19, follow them every 4 months, because if you can detect when the edema starts, you'll start with 6 monthly injections, but many of these cases improve beyond 2020 with a flat retina with just 4 injections, with only another 2 injections over those 2 years. So they get an average of 6 injections. We want to identify these cases early so that when we start treatment, we might only need resources for 6 injections. They need a lot of monitoring. We have to get better, as Tien said, with monitoring remotely, both for visual acuity and for thickness. But in the end, if you start with 6 injections when the visual acuity is 20/32 or worse, if you realize what your alternatives are, and if you can identify the other cases that are 20/25 to 20/20, we now have an excellent approach to treat these cases.
Dr. Sachin?
Yeah, that was an excellent talk. Any comments from any panelist? Okay, I think we're running about 10 minutes late. So we're starting with the retina session for POS Spectrum 2021. It has been a very nice...
Dr. Sachin, give me 2 minutes. I would like to thank Dr. Udayan Dikshit, sir, Dr. Sangeeta Wagh ma'am, and Dr. Santosh Bhide for moderating the international webinar session. It was excellently done, and POS thanks you a lot. Thank you. Dr. Sachin, you can go ahead.
Thank you, ma'am. So we're starting the retina session now. On behalf of Managing Committee and Organizing Committee of Spectrum 2021, I welcome you all for the retina session. A special welcome to our panelists today, Dr. Nikhil Beke, Dr. Ketan Jathar, Dr. Devendra Venkatramani, Dr. Vidyadhar Patwardhan, and Dr. Piyush Bansal. We have 3 speakers today. We are starting with Dr. Bhushan Khare, sir. Dr. Bhushan Khare, sir, is a senior VR surgeon from Pune. He has done his fellowship from Shankaracharya, Chennai, and he is the retina surgeon at Khare's Eye Institute. I request Bhushan Khare, sir, to start his talk on understanding IPC. Dr. Khare, sir.
Can you see my screen, please?
Yes, sir. We can see it. Let's start.
First of all, let me thank everybody, especially Team POS, who has done a superb job over the last 1 year of difficult times. And we've been treated to a feast of seminars, including for this annual conference. So starting with my topic, I have to talk on polypoidal choroidal vasculopathy. The talk is basically targeted towards the general audience in addition to the retinal specialists. So it may be a slightly basic one for listening there. PCV may be contributing to about 40% of our clinical workload, although we may not be diagnosing everybody because we don't do ICG in all the cases, nor do we do an OCTA in all cases. Lawrence Januzzi had described this as old as 1978, when he first described repeated bleeding episodes in a cohort of Black patients, in which he described a condition which had 2 components. One was a network of blood vessels, and at the tip of these blood vessels, there were bulbous protrusions, which he described as polypoid lesions. He also showed later on that these lesions could occur in the macular area and that these could cause repeated bleeding episodes. The fact that these were deeper to the retinal pigment epithelium, he also demonstrated that an ICG angiography was needed to study this pathology better as compared to the available fluorescein angiography that time. Now, before I go to the clinical scenario for us to understand, I will just go in short of what pathology we are seeing here. Here the blue layer which I've shown is the Brooks membrane, and this is the elevated retinal pigment epithelium. It is like a type 1 neovascularization, but this neovascular membrane, it grows to split the Brooks membrane, and at the tip of these networks there are bulbous polypoid structures which were referred to as polyps. Histologically, these polyps show changes of hyalinization, which is very seen when intravascular pressure is high. Also, we should note that this differs from a classical AMD because we don't see a basal classical drusen are absent in these cases. Immunohistochemistry of histological samples also showed that 30% of these cases don't have VEGF receptors, which may explain non-response of these patients to injectables we use. Now, coming to the clinical scenario, there are two basic patterns of presentation. One is an exudative pattern in which there is a massive exudation, usually commonly seen around the macular area, or there is a hemorrhagic episode which we see, and typically we have this in a younger subgroup of patients, predominantly in Asian populations, common in Southeast Asians, the Japanese, as well as the Indian race. It has less of bilaterality as compared to typical AMD. Absence of large soft drusen is the important hallmark, and the serosanguinous or hemorrhagic pigment epithelial detachment is almost pathognomonic of this diagnosis. Although this pathology may have a relapsing and a remitting course, over time it is seen to be associated systemically with some issues. Systemic hypertension is commoner in these patients, and control of blood pressure does play a role in preventing or decreasing the bleeding episodes. Genetically, however, they also show similar traits like what the rest of the patients of AMD show. A classical subset of these patients have a history of recurrent CSR, which helps us understand that this is also a spectrum along the diseases of pachychoroid. Smoking also predisposes these patients to this pathology. Clinically, we have a varied spectrum. There may be nodular orange polyps which may be seen, which may be difficult to see in the Indian population because of the contrast which is less. There may be typically exudation or a hemorrhagic retinal pigment epithelial detachment, which is very, very classical of this pathology. This is something which we should suspect, and we should always investigate these patients on either the investigative modality of imaging or angiography, looking into a possibility of polypoidal choroidal vasculopathy. Even in patients of a British cohort, Alan Bird had shown that ICG done on these patients, he could identify a PED with PCV on angiography even in the British subjects. Here I can show you two large nodular polyps which are seen. It may be very easily missed. 50% or less than 50% patients show these polyps. Now, the easiest test which we have clinically associated with the clinics is a OCT imaging. OCT does help us classify this disease and separate it from the rest of presentations of AMD. What do we see on an OCT? A classical peaked PED, which is classically seen here, a thumb-like jutting out of the retinal pigment epithelium, and there is a double-notched PED with round structures under the retinal pigment, which are actually the polyps which I imaged on the scan. Also to be noted, I will emphasize, which you can certainly observe in the subsequent scans as well, the neurosensory retina is very healthy in these cases. The pathology is more towards the retinal pigment and the Brooks membrane complex, and the health of this retina helps them recover good vision if you keep on treating them. This pathology may be involving the fovea or extrafoveal areas, and area which you see a hemorrhagic RPD even in the mid periphery, you should suspect of this pathology. Here the OCT shows classical large choroidal vessels which are called as pachyvessels, which are associated with this, and the large jutting out of a spiked PED in the center. Also, classical features on the OCT is a double membrane sign, which you can see in the lower image along with the PED. And again, please note that the neurosensory retina is quite healthy for the node. Along with the OCT, the other modes in our armamentarium, the investigation, classically what we use is a fluorescein angiography, although it doesn't help us elucidate this pathology in detail. ICG is a much better tool which helps us investigate these cases. So here, just to re-emphasize, orange-red nodules, large hemorrhagic peptide epithelial detachments, large exudations, notched PEDs, a younger patient, recurrent CSR, and lastly but not the least, in a patient who is not responding to anti-VEGF treatment over time, please review your diagnosis and look into factors which may help you diagnose it as PCV. ICG angiography has been the current gold standard over many years in helping to label a patient as having PCV. What do we see in a classical ICG? The early phases of ICG within the first 1 minute are very important. These are the polyps which are seen as nodular. On stereoscopic photos, they are seen as nodular elevations with central hyperfluorescence, a rim of hypofluorescence, and a network of branching vascular network. If you have a video angiography, you can see the pulsatile nature of the polyp in some cases, which is pathognomonic of this disease. The Everest study, which helped us decide how to treat these, used angiography with ICG as the must-do treatment to classify and diagnose these patients with a set of criteria. Now, clinically, what do we confuse these with? There may be what we refer to as the occult CNVM, but in pictures here we can see that neither can we identify polyps nor a branching vascular network, and it remains a fuzzy hyperfluorescence. It doesn't fit the criteria to call it a PCV. The other condition which may be mistaken because it can also have retinal pigment epithelial detachment is a RAP lesion. It is a retinal angiomatous proliferans in which there is a communication which develops between the endpoints of two capillaries. Typically, it is at the edge of the foveal avascular zone, and it is in a cross section in the neurosensory retina. So it starts leaking there, and as opposed to a PCV, there are large cystoid spaces which start in the retina, and the blood vessels grow down, and then it leads to a pigment epithelial detachment. If we don't diagnose these patients early, they may form a large disciform scar. PCV typically does not form too much of fibrosis, in contrast to a disciform scar which may form in a lesion. Again, ICG can help us delineate the RAP lesion better in early cases. So ICG does help us differentiate various subcategories of AMD. So if we diagnose it as a PCV, why do we treat these cases? It is mainly because more than 50% of these patients end up with vision less than 6/60 over a 1 year follow-up. And once we start treating them, we have to first decide which of these cases have activity. Activity may be decided by the functional consequence of this lesion, or an OCT in the form of residual SRF or a pigment epithelial detachment, or clinically hemorrhage, or even a leak on a fluorescein angiogram. And on the treatment options we have to set what all we have to follow as a patient responds to treatment. We may keep a watch on the primary outcomes of functional improvement and the anatomical changes which we noted on OCT scans in our clinic. However, the various options of treatment available, we should have least of complications, we should have less of retreatment, and it should prevent recurrences of the disease. Now, coming to treatment, there are two basic pathologies which are involved in this condition. One is the polyps, which are the main hallmark of the disease and which leak in the early phase of the disease. The branching vascular network may not leak early on, but as the disease progresses, it may convert itself to a CNVM of the natural type. If the polyps are not at the fovea, we can use a conventional laser to burn them off. But if they are subfoveal in nature, we have to resort to other modes of treatment. Classically, the oldest method of treatment was PDT with the dye verteporfin, which was used in monotherapy long time back. However, as this treatment was repeatedly used, we could see that it can damage the choriocapillaries and it can cause a large area of choriocapillaries atrophy because of the spot size being used. With 2 or more treatments, there may be functional visual loss because of this choriocapillaries damage. For this treatment was followed by availability of VEGF drugs. Now, ranibizumab had a good drying up effect because of its anti-VEGF activity, but repeated doses were required. 30% of more patients had polyps which were not closed on this monotherapy, and persistent polyps were a ticking time bomb which could bleed in large areas underneath the RPE. So considering benefits of both types of treatment, why not combine PDT, which led to polyp closure, and ranibizumab, which helped decrease the leakage and the exudation? So these were very much complementary to each other. And then came the combination, which was proven to be superior to ranibizumab alone. Here we could see better polyp closure, less number of injections, and the visual gain was highest as compared to established therapies at that time. Here you can see classically the retinal pigment epithelial detachment, which flattens over time. And as it flattens, on the angiogram, you can see the branching vascular network, which is still visualized. You can also see a larger area of hypofluorescence because of the effect of the PDT, which was done to this patient. There were other things to be noted, that these patients had to be followed every 3 months with an ICG angiogram to note recurrence and the state of the polyps. If patient's vision was good, we had to spare these patients harsh treatment. So either we had to reduce the fluence, we could add steroid to the treatment, reduce the spot size, or if patient's vision is really good, we could counsel the patient and wait further. Sometimes on the ICG, we could not elucidate the area of the treatment, and we had to hold on PDT because ICG angiogram is very much needed to decide the spot size and the area of PDT. In these cases, even in those days, monotherapy of anti-VEGF was used as a treatment. Then came the stronger molecule of aflibercept. Now this had a higher polyp closure rate. And in these cases, without the use of PDT as a single monotherapy, this drug could cause wonders. There was flattening of the retinal pigment epithelial detachments, and long-term follow-up showed that these cases needed PDT over a period of 2 years. Whereas compared to ranibizumab with PDT, 54% of patients over 2 years needed a rescue treatment. Following this, now we have a new baby at hand, brolucizumab, which is a smaller molecule. So we can pack larger number of molecules in the same dose. Although it is non-inferior to aflibercept in visual outcome and has a robust drying effect on the wet retina, it has a small risk. It cannot be used in inflammation having eyes. It can cause inflammation. And the worst part is a small proportion can have vascular occlusions associated with these inflammatory episodes. Again, emphasize this pathology, the neurosensory retina is very healthy. So if you treat this pathology underneath well in time, you may be able to have a better prognosis as compared to typical AMD. Now, considering to this modality which is available now, the OCT angiogram, it may be hampered when there is gross hemorrhage or edema because of the elevated nature of the retinal pigment epithelial detachment and pathology at different layers of the retina. predetermined segmentation miss this disease. And the polyp pickup rate is 80% as compared to ICG. You can see here the left shows an OCT angio, and there are far more polyps which have been picked up on an ICG angiogram. However, with advances in ICG angiography and its nomograms, now we have concluded that ICG angiogram can be helped, or it can be used to diagnose these patients and label them as PCV if we are able to find signs of PCV. They have also changed the nomenclature to change the nomenclature to say that polyps are now referred to as polypoidal lesions, and the innocuous branching vascular network as a branching neovascular network to show its neovascular character. So just to emphasize, this is a condition which we can diagnose if investigated properly. For that, we need suspicion, and in cases who have a hemorrhagic retinal pigment epithelial detachment, large lesions, absence of typical drusen, we should look for OCT changes. If caught in an OCT, we may diagnose and treat them depending on OCT changes, or if you are inclined towards doing a PDT or identify the polyps in toto, you have to go ahead with the ICG angiogram and then decide whether polyps are to be treated with a PDT. Now to conclude, these are two articles which anybody wants to refer, very comprehensive articles, one in the IJO by Dr. Giridhar and one in ophthalmology, which comprehensively state how we treat this disease at the present day. I'll again like to thank POS to giving this opportunity to me to present this topic in front of this wonderful audience. Thank you.
Thank you, sir. Excellent talk. Any comments from the panelists? Dr. Devendra?
Thanks, Dr. Bhushan. That was really a very nice talk. I think you comprehensively covered most of the aspects that would be of relevance to anybody dealing with these lesions. I would just like to say, as you already pointed out, that we are quite hamstrung in our efforts to treat these patients because of the absence of access to ICG. But at this point in time, also the access to PDT appears to be a problem. So treatment of PCV is becoming a little more difficult in the current era. Let's hope these two factors are taken care of, and we can give at least better, more optimal management of these patients.
Dr. Piyush, anything to add? Piyush Bansal? Sir, can you just tell about the role of sir, the role of steroids? You want to discuss? Mention about steroids for IPC.
I think any of these diseases, steroids may help reduce the inflammatory component or the exudative component. But I think like use of steroids can cause its own share of complications. It may be restricted only to pseudophakics. It may not be the primary treatment which is used when you diagnose these as PCV, because we very well know that stronger anti-VEGFs give a better resolution of the PEDs.
Thanks. Prabhu Desai, sir, anything to add?
No, it's okay.
Okay. I think we'll move on to the next talk then.
Maybe.
The next speaker is our next speaker is Dr. Nitin Prabhu Desai, who is a senior most VR surgeon in Pune. He has been a past president of POS. He is director at Prabhu Desai Eye Clinic. He is also associate professor at Bharati Medical College.
While others are.
Yeah, and he has been very helpful to majority of us as a junior VR surgeons. We invite you, sir, for your talk on surgical management of maculopathies.
Thank you, Sachin. Can I share my screen, please?
Yes, sir, you can.
I think Dr. Bhushan, because I'm getting a message, you cannot start screen share. I think Bhushan has to stop his screen share.
Yes, stop. You can start.
Okay. Can you see my slides?
You can see it, sir. Your voice is cracking a bit. These slides are visible. You can start.
Is it okay now?
Yes, sir. Start.
Thank you. It's been a great pleasure to be the part of this webinar by POS, and I'm really thankful to the POS team, Dr. Gitanjali Sharma, Dr. Mukesh, and Dr. Sachin to allow me to be a part of this program. Now, today's topic we'll be discussing on the macular surgery in a day-to-day practice. I'll be more specific with clinical situations so that it's easy for every one of us to understand the role of macular surgery as we see it today. Now, actually, there is a great increase in the need for macular surgery in the last 1 or 2 decades. I think it's mainly because of lifestyle changes. We see that now senior citizens are also hooked on to mobile phones and iPads, and hence their need for good vision is increasing, as a result of which they keep coming to us even if there is a minimal change in their visual acuity. And most of them, these changes are due to macular changes induced by aging or other retinal degenerations. Also, to add to this, we have better devices. Now, most of the clinics have good fundus cameras, OCT machines, even perimeters, and as good as things like adaptive optics. So we can now diagnose these macular conditions much earlier and in a much better fashion. Add on to this is the improved surgical microscope with good visualizing systems, and even we have certain microscopes attached with OCTs now. We have better technique, better instruments, and hence the outcomes of these macular surgeries have been good. So all this is put together, I think we are now looking at more and more macular surgeons being done with better and better outcomes. Now let's look at the typical situation we see in a day-to-day practice. Now this is interestingly a 59-year-old female ophthalmologist who reported to me just last week with blurring of vision in her right eye. Their vision was about 6, 9, and 12, and she also had a little bit of cortical cataract. This was a clinical picture. You can see that she just inferior nasal to the foveal center, she had this cellophane-like change, which was seen more prominently with the red-free filter. But as you can see clinically, and even on 90D, I thought that the fovea was not involved. And I just was going to tell her that probably you could watch her. But if we did, when we did her OCT, it was seen very well that there is a complete PVD and a parafoveal ERM, which was causing traction on the foveal center. So now we have a young active, not very young, but an active person who needs good vision, binocular vision, and his one eye is showing this early ERM. So what we can do about it? We can either observe, we can consider vitrectomy with ERM removal, or even looking at her age, consider phacoemulsification with vitrectomy and ERM removal. So these are the typical situations we get when things are not very straightforward. You have to discuss with the patient, tell him about the pros and cons, and then take right decision with consent of both the parties. Now, if you look at the macular problems which we face in day-to-day practice, this is a cohort of problems. This is not the whole comprehensive, but this is what we commonly see. We have epiretinal membranes, macular traction syndromes, lamellar macular holes, full thickness macular holes, and lastly, submacular hemorrhages. Now we'll look at some typical clinical situations where we see these cases and how do we go ahead managing them. Now we'll first discuss about the epiretinal membrane or epimacular membrane. As you can see, it comes in various forms. It may be a parafoveal lesion which causes striae and involves the macular center, or it can be a whole gross diffuse membrane across the macular area, or a diffuse membrane with a central lamellar hole. So it can come in various morphological forms, and the management principles which we use in these situations is depends mainly on the vision and the patient's needs. If the vision loss is moderate, we most of the time tend to observe them. But if there is a documented drop in vision, or if the OCT shows progression along with vision drop, then it is a more stronger case for considering surgical intervention. So now let us look at this case. In December of 2019, the patient presented with blurring of vision dropping to almost 612. And you can see that the PVD is incomplete. There is an epiretinal membrane with some cystic changes in the fovea center, and also very early fluid under the pigment epithelium. And about a year later almost, he comes back with further drop in vision, and the OCT also showing worsening. The epiretinal membrane is more contractile now. The PVD is still incomplete, and the fluid in the retina is still persisting or slightly more, and the small sub-PVD fluid is also there. So all this indicates that there is worsening both of the vision as well as the morphology. Hence, probably it's a good case to consider surgery. And what do we achieve with surgery in such situations? We would go ahead and we did as vitrectomy with epiretinal and ILM peeling. And about a month down the line, just about a month down the line, 6 weeks down the line, we could see that the epiretinal membrane and PVD is all gone, but there is some cystic changes which still persist, and this sub-RP fluid is still persisting. So it's very important to tell these patients that this surgery is not like cataract surgery, where you remove the cataract and your vision would improve the next day. Here, it may take weeks or even at times months for the visual acuity to get much better as compared to the pre-surgery vision. Now, what's the surgical principle in this? We do a 3-port pars plana vitrectomy, and here we have completed vitrectomy and stained with the brilliant blue, and now we are peeling off the epiretinal membrane. Now, usually the epiretinal membrane peels off like a sheet. The whole sheet comes off. It's a thin sheet just running across the macula. And you have to be very careful in doing this, because as you can see, at this moment, the fovea is getting pulled up, but fortunately, there is no break formation. So you peel off that membrane, and once you peel the membrane, you would stain again to remove the ILM, because the ILM also gets slightly puckered in these situations. So here we'll be using after staining the ILM, we'll be using the ILM forceps to pinch and pick an edge of the ILM at the temporal area, and then slowly go ahead and go around the fovea and remove the ILM, usually up to the arcades, if it is possible, if it comes out easily. It's important that we have a good visualization in these cases, because you need good visualization and good stereopsis to perform these type of maneuvers. But if done well, the patient's vision is likely to recover, because the anatomy gets much better over a period of time. So once we do the surgery, this is the type of effect we get. This is pre-surgery, when you see there are a lot of striations, the vessels here have come together, they have in a sort of conglomerate. But once the surgery is done, it's just about say about 3 weeks post-surgery that the vessels are now separated, and their architecture is looking much better than before. However, as I said, the vision per se would take a long time to get back to normal. If you look at the other spectrum, that is the vitreomacular traction syndromes, usually here the symptoms are moderate. The patient may not basically come to you with symptoms, but usually this condition gets diagnosed on a routine evaluation. So do we operate all these VMTs, or do we watch them? I would say that all of them don't need surgery, but regular follow-up is required, as I'll show you on these cases. So this is a lady who came to us with the right eye poor vision. You can see that she has almost stage 2 macular hole. The operculum has not got separated, but the macular hole is almost complete there. And this is her left eye. Interestingly, the left eye at that stage had almost 6, 6, and 6 vision. But you can see there is definite vitreomacular traction. The PVD is incomplete. So this can also probably go into this stage, or at least in a lamellar hole stage. So because this right eye was a priority, we did the vitrectomy surgery and told the patient that, okay, you can come when we follow up this eye, we will look at this eye and see what is to be done. 6 weeks down the line, the right eye which had undergone surgery got better, but the left eye then when seen on follow-up and OCT repeated, we saw that it had already turned up into a full thickness macular hole. So this gets back to the question that at this stage, is it necessary to operate immediately as soon as you finish this surgery, maybe within a week you do this surgery? Now, again, these questions are unanswered because you can look at this case, which I saw just the other day. This patient is the right of the patient whom we had seen in August of 2020. And she had this extensive traction going on, and we thought that probably she would be going into full thickness or at least in a lamellar type of situation. So we had advised surgery, but because of COVID and other medical reasons, she didn't report immediately. And just she came the other day saying that now she's ready for the surgery. So can we go ahead with the surgery? We just, because it was almost 8 months, we did a repeat OCT, and you can see that now it has become into a laminar hole. There is no traction left. So we said now the role of surgery from this stage to this stage is now changed. And so we would rather observe rather than operating her. So sometimes these situations can spontaneously get cleared and you can go into this stage, which usually does not require surgery. Looking at lamellar macular holes, again, they have moderate vision loss. And once formed, they rarely progress. I'll show you some examples following me. So again, in these cases, we need regular follow-up because sometimes they may worsen, but most of the time they remain stable. Just look at these situations here. The lamellar hole has already formed. There is no traction. There is no ERM, so we would tend to watch it. Here, there is a periretinal membrane, so we would watch this closely. If it worsens further, maybe this would require surgery. However, as you can see, documented exactly over a date, 13th of April 2018 and 12th of April 2019, the lamellar hole has absolutely remained the same on OCT. There is no change. So most of them, as I said, they remain stable and may not require surgery. However, in this myopic patient, you can see that there is hardly any choroid left. This is a zipper type of lamellar hole, which tends to progress. The inner layers keep on separating. So here I would watch them more closely. And if the vision as well as this OCT worsens, I would definitely consider surgery and put in, remove the ILM and put in gas to try to flatten up these changes. Now, the other spectrum of this is the full thickness macular hole, which is one of the commonest macular surgeries we are doing nowadays. And I think OCT has really revolutionized in the diagnosis and management of this entity. About when we are doing our residency and other times, we hardly saw macular holes, we hardly treated them basically because there were no devices to gauge them. And also patients in those days thought that everything is cataract, so they would not report in the early stages. But now we know with OCT, we can pick them up early, we can follow them up very well, and hence we can treat them also in a very good fashion. Now, in general, when we look at macular holes on OCT, what we are looking at is this base of the hole. Larger the base, worser is the prognosis. Smaller the base and smaller the duration of vision loss, better is the prognosis. Also, we look at the lips of the macular hole. If they have a lot of cystic changes indicating the chronicity of the hole, maybe the prognosis is not as good. But if the cysts are not there and the base is small, we have very good prognosis. So there is also a thought process that if we don't treat, the hole size would increase over the period of time because something like a contractile force continuously working on the lips, and it will keep increasing. But again, sometimes we have exceptions. Now look at this picture. This was done in the May of 2020, and this is October. So 5 months down the line, the hole is almost the same. In fact, at this scan, at least it looks that the subsequent scan is a little better. The gap is a little smaller. There are certain reports in literature where there is a spontaneous closure of the macular hole without any form of treatment, but those are very rare. So in cases of full thickness macular hole, what do we really do? Over the period of time, last about 1.5 decades, this has been evolving again and again. The initial description was of a PVD induction, followed by fluid gas exchange and positioning. There was no there's no ILM treatment in those days, but subsequently we started peeling the ILM, putting in gas and then head down positioning. Now we are more into ILM flaps with the fluid gas exchange and positioning, and now there are certain studies where come up where they are questioning even the need for positioning. Also, if the hole is of a longer duration and the flaps have not worked or the ILM peeling has not worked, we have other methods being tried like the amniotic membrane graft or the lens capsular graft, or even autologous retinal implant transplants have been tried and have been successful. We have our own Indian surgeon who has devised a Trifine-like instrument to create this autologous retinal graft and transplant it to the macular hole area. So when we do surgery, we do a 3-port vitrectomy with removal of the vitreous and ILM, and then subsequently doing a fluid gas exchange and injecting an expansile gas. And this is the result we usually get after about 2 to 3 weeks of gas in the eye. And this is called a type 1 closure, which is usually the desirable effect of the treatment. Certain situations again as macular hole where there was impending stage 2 macular hole, which was treated, and over the period of 3 months, this is what the situation we get. Again, you can see that ISOS junction is good, so the visual acuity would be good in this patient. I'll show a short video of a retinal flap being created, the ILM flap being created for macular hole surgery. So here, after the staining of the ILM, we will start creating that flap, and we try to maintain the flap so that it covers whole of the whole area properly and helps in sealing the hole better. Now it is important that you grasp the flap and don't tear it off. And as you can see here, we have now placed the flap across, and once the flap is in place, you have to gently do the fluid gas exchange without disturbing the flap. You are just flattening the flap with the blunt tip of the cutter and seeing that it is well across the hole, and then you start the fluid gas exchange. There are times that when you are doing the fluid gas exchange, the flap may just lift up. So people have tried putting in some visco or some PFCL over the flap to maintain it. But most of the time, if the flap size is adequate, the flap doesn't move. Once you do the fluid gas exchange, settle the flap properly, you can inject the expansile gas. So this is what we get in such situations. This is the same patient who you saw the video, where this was the pre-op picture after the flap was placed. There's still some gas seen. So what 1.5 months down the line, this is the picture of his eye. Now, lastly, I'll be touching very shortly on submacular hemorrhage, which is either mild submacular hemorrhage or a severe submacular hemorrhage. In the mild submacular hemorrhage, which is usually to a wet AMD, we observe, and once the hemorrhage starts clearing, we will do an FFA and ICG if needed, and then go ahead with anti-VEGF injections or laser photocoagulation. But what is more important is this severe submacular hemorrhage, where usually prompt action is needed. We have two options available here. We can either use a lesser invasive approach of injecting intravitreal TPA, which will break down that submacular hemorrhage. Then at the same time inject anti-VEGF injection to treat the basic cause, and also put in intravitreal gas to displace the thinned out blood. So these things together in one setting, they are done, and this usually leads to fairly good visual recovery. Other more invasive approach, but maybe more specific, is the approach to perform a vitrectomy, peel the ILM, inject the TPA subretinally with a 40 gauge needle, and then perform FGE and positioning. Now we have this experience of ophthalmologist's father who had multiple injections for his wet AMD, but in spite of that, one fine day he had this massive subretinal hemorrhage. So this is one day after injecting TPA intravitreally, giving him aflibercept injection and putting in gas, and within a 24 hours period, you can see that the hemorrhage has fairly cleared. His vision started improving, and later on he was further treated as needed.
Sir, summarize yourself, please. We're running short of time.
Okay, I'll now conclude. So the macular surgery is being increasingly performed with results which are getting better by the day. Technological advances with improved skills will lead to many macular conditions being treated surgically. Thank you for your patient hearing.
Thank you, sir. An excellent talk. Dr. Piyush, I request you to hold on your comments for a bit because we have slightly changed the schedule. Our next speaker, Dr. Chaitra, there's a report at the moment. There's a fight to catch. Sir, can you stop sharing your screen?
Yeah.
We'll take the question of sir's talk after this next talk, please. Dr. Piyush is okay? We'll have Dr. Chaitra's talk first, and then we'll take the question for Dr. Prabhu Desai's talk. Which has a flight to catch in 20 minutes, I guess. Okay, our next speaker is Dr. Chaitra Jaydev.
कोणाची करायची तू आल्याशिवाय नाहीच म्हणली.
Our next speaker is Dr. Chaitra Jaydev. She is a senior VR surgeon at Narayan Netralaya. All of us know her. She is actively involved in editorial management, publication, and research. She to IGO from last almost 15-20 years. She is the youngest candidate to be elected as a member of scientific committee. More than 100 PubMed index articles. She has recently defended a PhD at Netherlands, and she has, to her credit, several state, national, international conference presentations. And thank you, Chaitra, for being very enthusiastic and participating in today's meeting. Dear friends at the airport and present her case presentation. We welcome you all. Welcome, Dr. Chaitra, and over to you.
Am I audible?
Yes, ma'am.
And my video seen?
Yes, ma'am. It's clear.
Thank you so much. Thanks, Sachin, for this opportunity, and I'm really sorry for the inconvenience of the unscheduled talk. I must thank POS for this opportunity. I've been part of the organization's annual meetings, I don't know, I think for more than 5 or 6 years, and it's been a pleasure. And to present it virtually this year, I think COVID has left us with no choice. So today I'll be speaking on the comparative analysis of anti-VEGFs, the protocol T and real-world data. I have no financial disclosures. So as we all know, the diabetic retinopathy pandemic, I must say, is looming large. And by 2040, we're going to have literally more than a third of people with diabetes suffering from some form of DR and 70 million having vision-threatening DR, which includes DME. So the focus of our talk today will be basically on DME, treatment options, why any particular drug. So we have different options here: bevacizumab, ranibizumab, aflibercept, brolucizumab, and biosimilars. Besides that, we also have steroids of IVTA and the DEX implant. Now, what is the evidence that we have here? Both we have trials and real-world data, and does any of them show that aflibercept is better? So let's quickly first go to the trials. I think most of us know the theory behind protocol T. It was an interventional randomized multi-center trial, and one eye of each patient was randomized to one of the study drugs. So the primary outcome was at week 52, and the change in visual acuity from baseline to year 1 was the main outcome measure. And at year 2, visits every 4 to 16 weeks, depending on the disease status and treatment. Now, okay. So what did protocol T do? This is the regimen. It was very strict retreatment criteria. So patients were scheduled to receive a study drug every 4 weeks. If improvement was noted or some worsening was observed in the clinical picture from the last intravitreal injection, the patient was re-injected. If no improvement or worsening was noticed after 2 injections, but the patient's clinical picture was described as normal, treatment was deferred. Now, if no treatment or worsening was observed after 2 consecutive injections and the patient's condition was not normal, then if it was prior to 24 weeks, the patient was injected, and it was after 24 weeks, the injection was deferred. So patient therefore received approximately 6 monthly loading doses. So what did we learn from protocol T? Now, this is with respect to early visual gains. There were rapid vision gains achieved across all study arms, but it was significantly higher, as you can see in the blue graph, with aflibercept compared to the other comparators at year 1 endpoint. And importantly, if you see from the first visit onwards, you can see the sustained separation of the BCVA curves, which means there was rapid early response. Now, was it sustained over the next year 2 of the study? Yes, the initial gains were sustained. And importantly, the mean number of injections required dropped from 9 per year to 5 per year. Next, what did we look at? The morphological changes. There was a rapid and robust anatomical change, which was superior to the other comparators. As you can see, the blue graph again coming down quite rapidly and maintaining up till the end of second year. So we saw early visual gain, we had sustained visual gain, and we also saw improvement in the central macular thickness. Now, going on to the subgroup analysis, how did the patients with baseline visual acuity of less than 20/40 react to each anti-VEGF agent. I think a lot of our patients do present, especially in India, with worse visual acuity at presentation. So yes, how did they perform? Even those with visual acuity less than 20/40, there were significantly better visual gains achieved with aflibercept than in either of the other two drugs in the first year. This is important. Whereas in the second year, it was more or less similar to compared to all the three different drugs. Now, what was the significantly greater mean visual acuity gains achieved with aflibercept than bevacizumab? So here there was a stark difference. If you can see the graphs, the difference between aflibercept and bevacizumab was quite significant. So now, if aflibercept is superior to ranibizumab at 1 year, but not at 2 years, why are we still considering aflibercept instead of ranibizumab when the visual acuity is worse? Now, here is where the area under the curve becomes significant. Here, it basically means what was the average visual gain. So when you're looking at that, the AUC was definitely greater with aflibercept than either of the comparators, again, for visual acuity less than 20/40. And when it was better than 20/40, it was not that very great. So our key messages here are the superiority of aflibercept over ranibizumab is through at least 1 year, which is a substantial amount for somebody, to experience better vision. And also there was a greater chance and more than 15-letter improvement that is clinically relevant for somebody, who reads, works, and drives over the first year of the 2-year period. Now, was aflibercept superior even in terms of CST reduction in this subgroup? Yes, we did see that even in the previous slide. And we saw that there was, despite, regardless of the baseline visual acuity, there was considerable reduction in the CST. And this important is that with eyes with better baseline visual acuity and thicker baseline central thickness, there was less visual acuity with bevacizumab. So maybe those patients who have a better chance at a better visual acuity or prognosis, these better drugs should be considered. So comparison of the proportion of patients requiring laser treatment. Definitely over the 2-year study period, significantly fewer patients on aflibercept required focal or grid laser compared to the other two groups, as you can see in these slides. So post-hoc analysis showed that patients treated with aflibercept experienced considerable reduction in CST regardless of the baseline visual acuity and the laser treatment. Now, this was as far as actually attacking the disease goes. What about disease modification and DME? Now, we know that aflibercept strongly inhibits VEGF-A and TGF in vitro. It binds with higher affinity to the native receptors. It has tighter VEGF-A binding. And more importantly, it suppresses the VEGF-mediated receptor signaling with greater potency than the other drugs, as you can see in this graph. So it has a VEGF-A binding affinity of almost 100% more. Now, when you look at the disease modification, if you look at this is a fundus photograph of a patient treated with aflibercept who experienced improvement at week 52. If you can see that the overall disease itself has improved much more at week 52. So basically, we're improving, the disease in the sense the severity is coming down with these disease-modifying agents. So here again, this is patients with advanced PDR also. There was great improvement with aflibercept compared to the other two drugs. And the next thing that they also show with aflibercept is that the VEGF-induced activation of VEGF-R, the receptors, is more strong with either ranibizumab or bevacizumab, close to 71 to 92 times greater. Post-hoc analysis again here showed that DME with NPDR with anti-VEGF did experience improvement in the DR severity, as well as with PDR, specifically with DME with PDR, aflibercept did better than the other two drugs. So what about the prevalence of eyes with persistent DME? So prevalence of persistent DME continued to decrease through week 24 with intensive treatment and was less likely to persist with aflibercept than either comparator, as you can see in this graph. And the proportion of eyes with persistent DME decreased with each visit. And again, those with, now going on to the protocol T, the study extension of 5 years, here it was just an observational study. Patients did not necessarily receive this, original treatment as per protocol T. Loss of vision, therefore, may be actually a consequence of reduced treatment frequency and both monitoring as well. So what does real-world evidence have to say? Bayer is supporting a lot of real-world studies. And among them, you have the Apollon, which is a treatment naive receiving. It did show that the mean number of injections required were higher in the first year compared to the second two, but the higher visual acuity was also noticed in this study. And it was quite comparative to the trials that we've been seeing, like Vivid. This is another aflibercept study where they saw meaningful visual gains with avoidance of vision loss in patients with DME. And this was seen, up till 1 year of study. And these many patients had poorer visual acuity, which is seen normally in clinical practice. This is the fighting retinal blindness registry with over 383 entrants, where again they saw that the treatment naive patients with DME did improve much better with anti-VEGF. This is the first study to be published in DME to demonstrate real-world effectiveness of aflibercept, and they again took treatment naive patients. This was about 29 patients. Here you see good improvement in visual acuity and reduction in the CME. So Cochrane meta-analysis, I won't go into the details. It did show that at 1 year, all efficacy outcomes were significantly favored aflibercept over ranibizumab and bevacizumab. And this is important because they've considered many studies, and they show that the certainty of evidence that aflibercept, bevacizumab, and ranibizumab were all more effective than laser in improving vision by more than 3 lines at year 1. So that is very high level of evidence that we have. This is another study which saw up till 3 years and did show very good anatomical and visual acuity outcomes. So these are the different retinal societies. They have shown that even the Euretina say that anti-VEGF should be the first line of treatment, and it should be preferred in eyes with a letter score of 250 or worse. And more importantly, it says that early aggressive treatment is very important. Now, this is as far as the Asian eyes goes. The diabetic edema study here also shows that in Asian population, anti-VEGF should be the first line. Choice of anti-VEGF will depend on the baseline visual acuity, and early intensive anti-VEGF treatment is very important in patients in Asia. So this is quickly treatment naive patient that we've been seeing very recently. We started treatment with aflibercept for DME after the indication was approved. So you see at presentation 624 in the right eye and 612 in the left eye, and post-injection, very good improvement at the first visit. This is another patient, presentation 612 in both eyes, pretty bad edema, and post-injection 1 month. We don't have long follow-ups because we've just started treatment, 6/9 vision in each one of them. This is a patient with recurrence. This is at presentation 612 laser PDR with DME. Recurrence after other anti-VEGF, the vision dropped, intravitreal and aflibercept given 1 month post-injection, extremely good response. Again, another patient with recurrence here, recurrence after drugs. We've given both the anti-VEGF and Ozurdex. Here, 1 month post-injection itself, we've seen good response. And last follow-up, the patient had 618 vision. Non-responders also, like initially they show good response to other drugs, and then eventually they fall off. So no response here. This is 624 with aflibercept 618 and 612, 2 months post-treatment. Last case here at presentation, no response for other drugs, aflibercept given, at least some improvement, 618, patient is happy. So this is a simple, small, analysis that we've done, and how response to aflibercept in patients with DME is there. Now, so my key messages are here that aflibercept is the preferred drug for treatment in patients with visual acuity that is worse than 69 ETDRS letters. The aflibercept molecule has been specifically designed to trap VEGF and PGF, which may occur at increasingly high levels. It is the inhibitor of VEGF and PGF leads to disease modification, and intensive treatment at year 1 can actually modify the underlying disease and improve outcomes. Emerging real-world data demonstrates the effectiveness of aflibercept as well. Thank you so much. I will first stop sharing. Hello.
Dr. Sachin? Dr. Piyush, you want to comment something? Now, can you unmute yourself, please? Yeah.
Yeah, I can unmute. Thanks,
But the
Chaitra.
video is not starting. Video is not starting yet.
Well, it's good to hear.
Thank you, Dr. Chaitra, for the excellent talk. I think we'll not hold you back for any questions. We proceed for your flight. Wish you a very happy journey.
Thank you so much. I'm so sorry.
No, that's okay. Relax.
I hope I managed to finish it on time.
Thank you so much. Yeah.
No, considering that it's the first time I've given it from an airport, it was quite a nervous situation, and I think I managed, and I'm going to board on time. So thank you, everybody. Thanks, Piers.
Thank you so much for joining in.
Yeah, thanks, Mukesh.
For you, I guess.
Wonderful talk.
Thank you. Thank you, Chaitra. I think we are moving back to Dr. Prabhudesai's talk. Dr. Piyush, any inputs? Prabhudesai, are you there?
I'm there, but my video is not starting.
No, you can answer. Dr. Piyush, you can ask. You want to contribute some comments? You can.
It's nice to get unmuted now. Good evening, everybody. It was a wonderful presentation by Dr. Prabhudesai, sir. Some lovely pictures and videos. I agree with what Sir said, is that with the changing times and the increased demands of patients and the lifestyle that people enjoy these days, that the requirements of surgery have changed. And during classically, what we learned as fellows is that let the patient earn his surgery. And now that dictum probably does not hold true in most situations. It's I probably think that it's let the patient earn for their surgery. So if they can afford to go in for surgery earlier, and they have these visual problems, metamorphopsias at visions of 6/9 and 6/12, probably it's a wiser idea to operate in such situations if there is worsening as well. In some of the pictures that Sir showed of vitreomacular traction and impending holes. So I think I agree with Sir, and these patients do pretty well, good candidates for smaller gauge vitrectomies, excellent instrumentation that is available to us. These patients tend to do very well with the 25 gauge and with 23 gauge vitrectomies. Also, surgery is quicker. The post-operative rehabilitation is faster. So very good outcomes that we are able to achieve for such patients with macular surgery requirements. Yes, over to you, Dr. Sachin.
Dr. Devendra, any input from your side?
With regard to the discussion on diabetic macular edema, I think a few cogent points are that rather than picking one anti-VEGF over the other, okay, I think we all agree that anti-VEGFs seem to be the way to go. But rather than picking one anti-VEGF over the other, I think sustained treatment with anti-VEGF is most important. And I think counseling the patient right upfront that multiple injections are going to be required over the course of the next couple of years is the single most important key to successful treatment. Because there's no point in taking expensive injections and dropping out of treatment and becoming non-compliant. I think sustained treatment is the most important solution.
Right.
I think in Indian patients, the overall health also is a major problem. We are talking about anti-VEGFs a lot, but the overall health of the patient, you see, as you see, their sugars, most of the patients won't have good sugars. They are having renal problems. They are undergoing various other treatments. So I think in Indian scenario, it's not only the anti-VEGFs. I think the overall health of the patient also has to be taken care of in the beginning itself. Otherwise, we just keep treating them without much benefit.
So if I may add to what Devendra said, excellent point that sustained treatment is more important rather than fixing the choice of treatment and then later on dropping out. We see a lot of these patients dropping out as well. And from the takeaway from the talk that Dr. Chaitra delivered, certainly we have evidence of aflibercept giving you excellent outcomes. It's a longer sustained outcomes. But it is in no way to be taken as a holy grail of the anti-VEGFs as of now. There are many patients who don't respond to aflibercept, and then they do respond to ranibizumab or sometimes bevacizumab as well, and sometimes even steroids. So you have to keep chartering newer territories also as against just sticking to one. And you also have to consider and be upfront with the patient right from the beginning that the requirement of multiple injections is reality, and affordability, financing, all this has to be taken into account before starting in treatment as well.
Thank you for the inputs. Dr. Nikhil Beke, are you there?
Yes, sir.
Any input from your side? And then we close the session.
I think Dr. Prabhudesai highlighted the possibility of need of a greater and stricter metabolic control. What I've seen in quite a few patients that even iron deficiency anemia, as is the case with lots of malnourished of our patients, and not just the anemia because of nephropathy. That also needs correction, and that goes a long way in treating diabetic macular edema. I think the rest of the points are pretty much standard and they've already been covered at depth.
Yeah.
Piyush,
Thank you so
just
much.
one more comment. Yeah, Sachin, can I have a comment?
Yes, sir.
Piyush, you have been talking about surgery for macular edema. Can you just want to add some points on that?
So I tend to, there are many times these patients who have recurrent hemorrhages, vitreous hemorrhages, and in any case, any patient with PDR, tractional macular detachments that we take up for surgery, I tend to pretty much try to peel the ILM in those patients in most of those cases now. I don't take patients with diabetic macular edema for surgery right in the beginning, but patients who are non-responders to all the variety of injections that we have in our bags. If they fail to respond, then that option certainly I do give to patients. These patients are extremely frustrated with the repeated injections, and most of them, the recurrence of macular edema, I have seen that it certainly reduces because of the increased perfusion of oxygen post-ILM peeling. The reduction of horizontal traction is also it's less post-ILM peeling. So these patients do quite well. You have to be careful, slightly more careful in these patients, because while peeling the ILM, because the retina is certainly more boggy and swollen up. So these patients do pretty well as long as they do understand that recurrence can still happen even after surgery, and the time duration for the half-life of these injections will reduce. So as long as they're comfortable with the risks and the benefits, I tend to operate these patients as well. Does that answer your questions?
Yeah.
Sir, I wanted to ask you something. May I go ahead?
Okay.
Do we have time?
So we are running short of time actually.
Yeah,
all
right. So then let's conclude.
Yeah. Thank you everyone for your inputs and contribution. I think the retina talk can go on privately also from many more times. That's fine. Thank you, everyone. Thank you, Prabhudesai sir. Thank you, Dr. Bhushankar sir. I think Chaitra has already left. Thank you all panelists, Dr. Piyush Bansal, Dr. Devendra, Dr. Nikhil Beke, and thank you everyone for joining for this session. I think we're finishing just in time, and our next session is about to start. So over to Dr. Mukesh for the next session. Thank you so much, everyone.
Thank you all. First of all, I'd like to give a special thanks to Dr. Sanjay Patil sir. He is here and he's our MMC observer. So all those guys who are here for MMC points, please make sure that he's there to observe you. And those who all are attending will get the MMC points. A word from Dr. Sanjay Patil sir, please. Sir, Dr. Sanjay Patil. Yeah. So, ma'am, concluding comments for day one from your side, ma'am.
Everything went on really well, and retina session was excellent. Dr. Sachin, Dr. Prabhudesai, Dr. Bhushan, Chaitra madam also joined from airport, so that was really great. Dr. Piyush, everybody spoke really well, and the whole day was smooth without any problem. So I must thank Dr. Mukesh for his hard work, and the whole managing committee. All the moderators did wonderful job, and then all the delegates also. Large number of delegates attended. International webinar went on really, really well. All the speakers were excellent. Even there we did not have any issue. And I thank everyone. And now we are going to start first time in POS conference. It is a virtual skill transfer course. So it is one of its kind. Those who wish to attend cornea and pediatric, right? I'm Dr. Mukesh. They have one link, and retina and glaucoma has another link. So you have to join one of the links, and there you can attend the virtual skill transfer course. And then tomorrow we have full day again with inaugural function, with award function. There are a few surprises, and especially those ladies are here. We have a special session tomorrow, Women in Ophthalmology at 3 o'clock. So we'll have fun then. So today we can conclude, Dr. Mukesh, and I invite all of you for tomorrow's award and inaugural function. Definitely, I'll be sending the invites now. So please do attend. Thank you.
Started on time at early morning, dot on time, finishing dot on time.
Yes, sir.
It's very
Yes, sir.
precision.
We have tried to change the meaning of Indian Standard Time, IST. So this year we have always, you know, we are keeping the time perfect.
Many thanks to DigiShield
and
for
Piyush,
all their
Mr.
support.
Piyush.
Mr. Piyush, Mr. Dipen, all of you, Natalie, all of you for the support that you have given, and we will need your support tomorrow also. Thank you, Piyush.
You're welcome, sir.
Yes, and DigiShield, this association will go on. I had attended your earlier IMA conference, and I was very sure that you guys would do a wonderful job. And today you have done a wonderful job. Thank you very much.
It's our pleasure, ma'am. Thank you so much for your kind words.
Thank you.
So shall I declare this meeting to be over?
Yes, and STC, those who wish to join will join with another link.
I'd request all the attendees to fill out the poll. I'll give you about 5 minutes for that. Your response is very valuable to us. Thank you.
You okay?